Okay.
Morning, we are live now, handing over to Dr. Trupti.
Yes, sir. Thank you, sir. Dr. Khushbu and Dr. Amrit Kaur, ma'am, you can begin.
Okay, thank you so much, Dr. Trupti. Ladies and gentlemen, a very good morning to one and all, and welcome to Knospe 2020. I, Dr. Khushbu Chotai, and my colleague, Dr. Amrit Kaur Raizadeh, are the hosts for today's inaugural function. Greetings from Krishna Institute of Medical Sciences, deemed to the university, or KIMS DU as it is fondly called. Spread across a sprawling 54-acre world-class campus, the institution, right from its inception in 1982, has been a pioneer in medical education, research, patient services, environmental consciousness. Krishna Institute of Medical Sciences, deemed to be university, is accredited by NAC with grade A with CGPA 3.20 on 4-point scale. It is also an ISO 9001-2008 certified university. Krishna Hospital and Medical Research Center is accredited by National Accreditation Board of Hospitals and Healthcare Providers, that is NABH. Neonatal ICU is accredited by National Neonatal Forum of India. The Blood Bank is accredited by National Accreditation Board for Hospitals and Healthcare Providers, that is NABH. KIMS Diagnostic Laboratory is accredited by National Accreditation Board for Testing and Calibration Laboratories, that is NABL, with due permission for testing and management of COVID-19. We have more than 2,500 COVID-19 patients successfully discharged from our institution, and we have also started plasma replacement therapy for the critically ill. The university is also recognized by the Malaysian Medical Council and Medical Council of Sri Lanka. So it is indeed a wonderful morning as we are here to grace this inaugural function. Allow me to welcome you once again to Knospe 2020. It's my honor, more than a pleasure, that we have gathered here for commencing the inaugural function of the virtual international conference with the theme Health Professionals' Integrity is the Hallmark for Physical Therapy and Rehabilitation, organized by Faculty of Physiotherapy, Krishna Institute of Medical Sciences, deemed university. I would not only welcome but give a hearty thanks to all the special people across the globe who have joined us here today to celebrate the first ever virtual conference of Faculty of Physiotherapy at Krishna Institute of Medical Sciences, deemed to be university.
Nothing is impossible as long as we have faith in God and His mighty power. In order to remove darkness, light is essential, and to invoke is to call in. An invocation song is a prayer to communicate with the God for inspiration and guidance. So I request students of physiotherapy faculty to invoke God within us with a devotional song and following the Indian tradition to light a lamp. First, before starting any auspicious event, we shall have a virtual lamp lighting ceremony before starting our conference to invoke divinity, wisdom, intellect, and good work. Moving ahead, may I now request Dr. Suraj Kanse to deliver the welcome address.
Welcome. It is my great pleasure to welcome you to the Virtual International Physiotherapy Conference, Knospe 2020, which is based on a unique theme, Health Professionals' Integrity is the Hallmark of Physical Therapy and Rehabilitation. This conference is hosted by Krishna Institute of Medical Sciences, deemed to be university's Krishna College of Physiotherapy, which is one of the oldest physiotherapy institute in Maharashtra. We dedicate this event to our beloved Honorable late Sri Jayantrauji Bhosle, who is the founder chairman of Krishna Charitable Trust and Chancellor of KIMS DU. Krishna Institute of Medical Sciences, deemed to be university, is one of the pioneering institutes in healthcare, led by our visionary Honorable Chancellor, Sri Dr. Suresh Bhosle, sir. I thank you, sir, for sparing time from your busy schedule to be a part of this grand ceremony. We welcome you, sir. We have been fortunate to be assisted by our Pro-Chancellor, Honorable Dr. Sri Shingare, sir. You have been a constant support and you have given a lot of encouragement. Your passion and dedication towards your work has definitely encouraged us to realize and direct towards our roles and responsibilities. We are fortunate to have you here. Welcome you, sir. It is a great honor to have Honorable Vice Chancellor Dr. Neelam Mishra Madam within us. We are overwhelmed to have you here. Your nature of initiation to make a wide and diverse base to make the mission possible is giving us enormous strength and direction to conduct such a beautiful event. I welcome you, Madam, on behalf of faculty and university. I wish to humbly welcome Honorable Chief Advisor to Chancellor Sri Dr. Ved Prakash Mishra, sir, for a profound confidence in us and our abilities to allow us to conduct such an important event in our university. Our university is blessed to have a personality full of energy and enthusiasm whose tireless efforts are building new blocks of success. I welcome Honorable Registrar Dr. M.V. Ghorpade, sir, on this occasion. You have been a huge source of inspiration and motivation. Welcome you, sir. This is your budget, the budget of all requirements, and I very much want to ensure that we build it together. So simple but elegant are words of Executive Director Mr. P.D. John. We welcome you, sir, on behalf of the university. Thoughts arise in every mind, but they need to be brought into reality. And this requires passion and decision. We are fortunate to have a person who dreamed for it and today made it reality. His vision and hard work has paid off. I welcome Dean, Faculty of Physiotherapy, Dr. Varadarajulu, sir, for today's gathering. I am honored to welcome the leadership of Dr. Sudeep Kayasar, President of Maharashtra State OTPT Council, to this event. Your personality to overcome things, learn from them, and become stronger both personally and professionally is laying down new horizons for us. You live within all of us, whoever forever changed by our time here. We welcome you, sir. We need to remain a nation that doesn't just welcome but that celebrates legal pillars for us to work, excel, and achieve new heights. It exactly reflects the nature of a beloved president of Indian Association of Physiotherapists, Dr. Sanjeev Jha sir. We welcome you, sir, for this occasion. People coming up and saying something nice is always welcome. But when you are initiating, contributing, and nurturing the profession for mankind, that's so nice. We would rather shake hands with them and exchange new thoughts and build a sound base for tomorrow. Yes, you got it right. I'm talking about our international speakers for today who have been so passionate and dedicated towards their services and who have achieved excellent heights in their professional career. We are blessed to have you all as today's speakers. I welcome Dr. Krista Barte from Sutter Senior Care, California, Dr. Brad Avery from Back Focus Physiotherapy, Australia, Eric Ferland, occupational therapist from California, Dr. Raju Metri, senior nurse CCU and primary PCI coordinator NHS UK, and Dr. Moria from St. Vincent's Hospital, Melbourne, Australia. They are often told stories about neighbors who lived side by side for many years but never had interaction, exchange of thoughts. That's how different professions are working nowadays. Integrity is the benchmark for professional and personal outcomes. We all should work hand in hand for it. And how can we miss our own countrymen who are our real gems? I would like to welcome our national speakers, Dr. Srinivas K., dental surgeon, Manipal Hospital, Bangalore; Dr. Deepak Anap sir, Professor, Department of Orthopaedic Physiotherapy, Dr. V.K. Patil College of Physiotherapy, Ahmednagar; Dr. Sunil Gugle, Orthopedic Consultant, Sanchiti Hospital, Pune; Dr. Nainital Sase, Medical Director, Wanless Hospital, Mirrors; Dr. Abhijit Shelke, Interventional Cardiologist; and Dr. Abhay Havle, Head of Department ENT, Krishna Hospital, Karad. I wish to heartily welcome our international alumni, Dr. Nittal Taude and Dr. Dhaval Bhanushali for today's event. I welcome all the participants who are online and those who are connected via Zoom or Teams. Today is a very special day for us as we are celebrating the milestone of 100 years of International Association of Physiotherapists. We are online for today's conference. With this remark, I end my speech and welcome you all. Thank you.
Thank you, Dr. Suraj. The unique theme of this conference, Knospe 2020, is focusing on the need of the hour for physiotherapy professionals. Unlike other conferences, it not only involves physiotherapists, but also medical professionals, dental, nursing, and allied health professionals. This conference shall be a stepping stone to create desired awareness about integral services and may lead to some interdisciplinary and collaborative research work and innovations in the field of healthcare management. To put a light on this, may I now request Dr. G. Varadarajulu, Organizing Chairman and Dean Faculty of Physiotherapy, to orient the theme for today's conference.
Thank you very much, Dr. Ambedkar. Very good morning, one and all. Dignitaries on the platform, Zoom platform, and the dignitaries as the delegates in this Nobel conference, and all the international speakers, national speakers, and all the delegates across the country and across the world. And it is my great pleasure and privilege to introduce the theme of this conference for the August gathering today. The theme of the conference is Health Professionals' Integrity is the hallmark of physical therapy and rehabilitation. So, my dear physiotherapists who are attending this particular conference, so I would like to tell you that our profession, that is physiotherapy profession, is like a water. We can mix with any kind of a fluid, and you know that this particular the water, the scarcity in the world is very much high. Without water, none of the things will live in this earth. So like this, that much extent, the physiotherapy profession is very, very important in case of an health governing, in case of healthcare management. So my dear delegates, I would like to tell you why this particular theme has been selected. See, we, the profession of physiotherapist, we go hand in hand with all the healthcare professionals. Let it be from super specialty in a medical discipline to a staff nurse. We join with all the fraternity in all the specialties, starting from orthopedic surgeons, neurosurgeons, and cardiovascular surgeons, and physicians. So with all the super specialists and specialists to a staff nurse, we get integratively to work for the better outcome, better therapeutic outcome. So that is the intention. That is also supposed to work as far as the physiotherapy services to go ahead. So the one more important aspect of this conference is, if at all the people, that physiotherapists who are working in any hospital and in an organization, if somebody says that in this particular hospital, in this particular physiotherapy center, that the physiotherapy services given are very good, or it is very appreciable, and they are doing a very good job. To say that the only requirement is that how best all physiotherapists are integratively working with other healthcare professionals involved in that particular center. Otherwise, this particular name we cannot fetch at all. So that is the intention. That is what is hallmark. So hallmark of your own hospital, the hallmark of your own physiotherapy department is highly depending on how much you are integrating with other healthcare professionals in your working atmosphere. That is what. That is also one of the reasons why we have taken up this particular theme of the conference. So now, in this conference, the topics, if you see, I have selected a few topics where we naturally come across in our day-to-day practice, like knee joint dysfunctions, in case of DPTV, that is vertigo patients, and stroke, and there are many other common patients who are all we come across every day. How do we go ahead with them? So how should be our approach? That will be clear by the end of this particular 2 days of virtual conference. So whenever we take an orthopedic patients, for example, a PA shoulder patient, so don't think that only a physiotherapist can achieve the 100% success, because there will be an orthopedic behind the source of energy for us, because they will be telling us this is the stage of lesion, this is what is an anti-inflammatory that medication that the patient has to undergo, and followed which the therapy that whatever you are going to be useful also will be beneficial. So that kind of integration should only lead to a quality practice. Same in case of a stroke also. Don't think that when a neurophysician hand over the patient to us and their work is over. No, they will hand over to us only when they ensure that this patient is stable now, he can undergo a rehabilitation. So in that case only they will refer. And we should always have a frequent relationship with a particular neurologist who referred the patient for us. So these are some few examples of how we are supposed to work in our practice. To strengthen this, to witness this theme has been taken as a theme of the conference. I think all the beneficiaries who are attending this conference will definitely benefit out of these two conferences. Please join and make use of this particular 2 days, and it will be a knowledge, a learning experience to all of you. So once again, wholeheartedly welcoming all the dignitaries, all the participants, all the delegates for this conference, and I once again welcome you all, and thank you very much for giving me this opportunity. Thank you very much.
Thank you so much, sir, for orienting us with the theme of this conference. We are also grateful to have the words of wisdom from the young, energetic, and enthusiastic physiotherapist, who is none other than Dr. Sudeep Kale, our guest of honor. Sir is the president of Maharashtra State OTPT Council and associate professor at Terna Physiotherapy College, Navi Mumbai. Sir is an advisory member of Mahatma Jyotiba Phule Jeevan Dayi Yojana, which is an health insurance scheme by Government of Maharashtra for physiotherapy, services and packages. We are grateful to listen to his kind words.
नीरज का फोन आया था।
हाँ,
ये कौन सा है जो बात कर रहा है?
नहीं, आपको प्रॉब्लम नहीं है, वो उधर से।
आता त्यांचं पण घेतलं असेल. सगळीकडे
Thank you, sir, for your wonderful words of wisdom. We are privileged to have the most illustrious member of the medical fraternity with a distinguished personality. We need not say much about our Honorable Vice Chancellor. The quote, which suits her best, is behind every successful man, there is a woman, and behind the success of every woman, there is a man. Ladies and gentlemen, she held the distinction of being the first lady pro-vice chancellor of the University of Health Sciences in the state of Maharashtra. Let us have the privilege to listen to our Honorable Vice Chancellor, Dr. Mrs. Neelam Mishra.
behalf of our Chancellor, Sir Dr. Suresh Bhasin, Sir, and managing body. For this first virtual international conference of physiotherapy, KNOS from our College of Physiotherapy, I wish all of you a wholeheartedly a great success. Theme of today's international conference is Health Professionals is the hallmark of physiotherapy and rehabilitation. For this, few words for the explanation. What is the meaning of physiotherapy? What is the meaning of rehabilitation? We all physiotherapists know what is physiotherapy is. Physiotherapy is a science which examines of Thank you, madam.
Thank you so much, madam, for this wonderful speech. Ladies and gentlemen, we are also grateful to listen to the words by an indomitable spirit to maintain the discipline in campus. Honorable Dr. Praveen Shingare, Pro-Chancellor at Krishna Institute of Medical Sciences, deemed to be university. His passionate dedication towards medical profession is highly inspiring and source of motivation to all of us. We are elated to listen to his kind words on our profession and on this conference.
At the outset, let me congratulate the organizing committee of the Krishna College of Physiotherapy for organizing this international conference related to the physiotherapy. And the theme of the conference is the integrity of the At the outset, let me congratulate the organizing committee of the Krishna College of Physiotherapy for organizing this international conference related to the physiotherapy. And the theme of the conference is the integrity of the health professionals, especially the physiotherapy professionals. Friends, nowadays physiotherapy is getting more importance because of this COVID pandemic. Majority of the serious patients, they need the ICU treatment, and in the ICU, physiotherapists play major role in treatment of the patient, especially the pneumolytic patches patients and respiratory physical therapy. The cure rate or recovery rate is more. It is because of the great contribution by the physiotherapist in the ICU during this COVID pandemic. So credit doesn't go to only a doctor, but also to a team of health professionals along with physiotherapists working in the ICU in this during COVID pandemic. Integrity is the hallmark of physiotherapy practice. Physiotherapists should have a soundness of the character and should have a strong principles. They must follow the ethical principles, moral principles, the uprightness during their practice, so that all these characters which are related to the integrity, they will benefit the patient. For example, in the integrity, the characteristic of integrity is the humble nature. If a physiotherapist is humble in treating the patient will automatically attract to him. And because of this humble nature, whatever is the therapy given to that, the emotional aspects of that humbleness will also add to the recovery of the patient. While treating, the integrity also includes the joy shown by physiotherapist when patient is telling him about his recovery, about his well-being, or about his improvement. One should not think that that has no importance, because patient requires their support from the physiotherapist as a part of integrity of the physiotherapist, that the physiotherapist is also interested, is also taking joy in listening to his recovery. Sometimes the patient may tell to the physiotherapist, I could not do this exercise for 2 days, 3 days, doctor, I'm sorry, this, that, etc. Usually we have to apologize that patient for not following your instructions and encourage the patient. So this is a part of integrity, that encourage the patient to follow from that day onwards meticulously, so that he will get the. So apology is also a part of the integrity. Otherwise, shouting at the patient, why you didn't follow it, don't come to me. These all behavioral aspects, they definitely will harm the patient, and then that indicates that you are not showing the integrity. The words of physiotherapy, the language in which you are telling to the patient, that also becomes a part of this integrity. If you are saying that within 4 days, 8 days, the pain will be relieved, or the tone will be there, the power will be there, this, that, etc. And if the patient finds that there is no improvement, not only in 10 days, but even after 2 months, 3 months, then your words were incorrect. And that is what the patient feels, that the physiotherapist is not accountable. So please use the word carefully, and those words, every word which you are using for the patient, that you must be accountable to that words. Whenever there is a not following of the instructions, then the physiotherapist should not become the aggressive, should not scold the patient, should not fire the patient. Otherwise, that will indicate that you don't have the good integrity while treating the patient. Your treatment must show some improvement, and that is what is called as authenticity, which is again a part of the integrity. Patients, it should appear to the patient, yes, doctor said, but within 1 month, this relief will be there, I got that relief. Then doctor said within 2-3 months, another relief will be there, I got that relief. And that is how the patient will believe that, yes, your treatment is an authentic treatment, and you are not lying. So don't lie to the patient. Lying physiotherapist means the physiotherapist without any integrity. The patient should appear to the patient, yes, I can rely on the physiotherapist, I can rely on my doctor, because whatever words he is telling me since so many weeks, and they all are true, and I got the benefit of all these words. So patient will think that, yes, I must rely, and that is a trustworthy nature of the physiotherapist, which is also taken as a part of the integrity. Whenever patient comes and tells to you that I got relief, doctor, and as you said, I exercise and these measures, etc., etc., then please don't take the credit of that relief to the patient yourself. You can give the credit to the patient. That is also very important. Otherwise, majority of the doctors just know, oh, yes, look how my treatment is so good. No, don't say like that. You explain him, yes, it is not because of my treatment, it is because you followed the instructions meticulously. You did all these exercises properly. You paid attention to all these things, and that is the reason why you got. So it is your efforts, not my effort. That is what one has to explain to the patient. Another part of the integrity is the time management. See, please value the time of the patient. You are in your consulting room, you are giving some physiotherapy to patient, and other patients coming with the appointment, they are waiting for minutes together, hours together. That means you do not value to the time of the others. So valuing the time is the integral part of your profession, and one should not be rude also. If you say that your appointment is 10 a.m. and you came at 10:30, don't be that rude. There are certain unavoidable circumstances because of which the patient may be coming late for the treatment after the appointment, or even sometimes before the appointment, saying that your appointment was at 11 and you came at 10. No, you have to wait for 1 hour, whatever. That means you don't value to his time. So all these characters, all these whatever I said, probably maybe 8 to 9 traits, what we call it, is the traits of physiotherapists, and all these traits are the integral part of the physiotherapy professional practice. I think all physiotherapists, if they behave in this way, then probably what is the status which the physiotherapy has achieved today, that will be more and more on the higher side. And probably today, what is the situation? A patient goes to a physiotherapist only when recommended by the doctor or by orthopedic surgeon or by intensivist or by any other neurologist, cardiologist, etc. So that situation will change, and with the own general knowledge, the patient himself will decide, herself will decide, why I should go to an orthopedic surgeon when I have a sports injury. I will go directly to the physiotherapist. I know that physiotherapy can diagnose, physiotherapy can treat, physiotherapy can give the exercise to me, and finally going to the doctor, he will also refer to the physiotherapist. Why I should waste the time? So that what is going on in the society, that should increase, and there has to be a direct flow from patient, from the injury side, from accident side, to directly the physiotherapy clinic. So this is all what we expect from the physiotherapy, and I hope that the deliberations in this conference will be fruitful to all the participants. I congratulate all the delegates for registering for this Krishna Physiotherapy College conference, and I wished the conference a great success. Thank you very much.
Thank you, sir. We feel honored to have an unending support and guidance of Honorable Dr. Suresh Bhosle, Chancellor, noted academician, administrator, who hardly needs any introduction. Sir has made all of us proud with his distinguished work in numerous capacities and his notable dedication and contribution in management of the COVID-19 pandemic in southern Maharashtra. We would now have Honorable Dr. Suresh Bhosle to add glory to this event by his precious words.
Hospital. And collaborative research on institution.
Thank you, sir. Ladies and gentlemen, now that we are about to conclude today's program, I'm pleased to invite Dr. S. Anand, Organizing Secretary for today's conference, to propose the vote of thanks.
Very good morning. On this wonderful occasion of virtual international conference, it's my privilege to propose the vote of thanks. As you all know, the organization of such events are generally the result of close cooperation among several organizations and individuals. I sincerely thank all of them. Krishna Institute of Medical Sciences, deemed to be university, is one of the pioneering institutes carried by our visionary Honorable Chancellor, Shri Dr. Suresh Bhosle, sir. I thank you, sir, for sparing time from your busy schedule to be a part of this grand virtual conference. We have been fortunate to be assisted by our Pro-Chancellor, Honorable Shri Dr. Shingare, sir. You have been a constant support and you have given us a lot of encouragement. Thank you, sir. I wish to humbly thank our Vice Chancellor, Madam Dr. Neelam Mishra, for your profound confidence in us to allow us to conduct such as important event in our university. I express my deep sense of appreciation and gratitude to our registrar, Shri Dr. M.V. Gorpade, sir, for being a huge source of inspiration and motivation. I express my deep sense of appreciation and gratitude to our Dean, Faculty of Physiotherapy, Dr. G. Varadarajulu, sir, for throwing light on this theme. Interprofessional integrity is the hallmark of physical therapy and rehabilitation, which is a brainchild of his long-term dedicated work in neurological sciences and rehabilitation. I must mention my deep sense of appreciation to our assistant registrars, director of research, and all the deans of different faculties under our university for their constant support. I thank you all, the resource persons, for carrying over the responsibility to conduct this event in a smooth and successful way ahead, which is to be coming to 2 days. I extend my sincere thanks to all the participants throughout the country and abroad to cooperate and attend the virtual platform with patience for these 2 days starting from now. I thank all the dignitaries, all the teaching and non-teaching faculty members, technical support team to grace this auspicious virtual conference. I realize that I missed a few individuals who have been supporting us. I wish to be forgiven for not specifically expressing our gratitude. Thank you very much.
Thank you, sir. With this, we conclude today's inauguration function. And now we will be proceeding for the scientific sessions of today's conference. May I now request Dr. Trupti Yadav to take over.
Thank you, ma'am. It was a great pleasure to be here at the inaugural function. We will take a break of 10 minutes and we shall join back for the scientific session. So the participants can join back after 10 minutes. So we'll be ready for the scientific session. Thank you.
Thank you, Dr. Trupti.
Avlay sir. Avlay sir.
Is online.
Yes, madam.
Sir.
Hello. Hello. Do you hear me? Do you hear me?
Yes, sir, we can hear you.
Huh?
We can hear you, sir.
Okay, fine.
So do you want to present your slide?
Right now or after the break?
You can try now, sir.
Try means, is it seen to all?
Yes, so those who are on the Zoom, you can start sharing your screen.
Okay.
And when you are set, we shall begin, sir.
Okay. Now, host disabled participants. Screen sharing, I am not enabled.
Just a minute, sir.
One guru. One guru. पहिली स्लाइडला नेऊन ठेवतो ना.
Rahul, sir. Rahul, sir.
आता फक्त त्याच्यावर क्लिक करायचं आणि जायचं ना.
Unmute and interact with Knospe madam. Amrit Parmel.
Hello, sir.
Yeah.
Right now.
Yes. Click. Madam, are you seeing my screen?
Yes, sir, it is visible.
Sir, I'm in a meeting. Will you call up? We'll talk later.
Dr. Krista? Dr. Krista?
This is Krista.
Yeah, ma'am, you shall begin after Howley sir has finished his presentation. After
Sure, no problem.
Yeah.
Thank
So,
you.
yeah.
कधी चालू करेल? Anand sir, can I start?
Yes, sir. I will introduce you, sir.
Anand sir,
Shall we
Okay.
start, madam?
Okay.
we'll give an introduction. You give sir's introduction, then we shall start.
Okay.
Okay, thank you. Very good morning. Today's first session will be shared by our Professor, Honorable Professor Dr. Abhay Howle sir. He is MS ENT, senior most ENT surgeon, working since 1989 for the past 32 years in Krishna Institute of Medical Sciences, deemed to be university. And he is our first resource person who will be sharing with abroad resource persons. Thank you, sir. You can start, sir.
Okay. Thank you, sir. Am I audible to all?
Yes, yes.
I hope.
Fine, sir. Fine.
Yeah. Good morning, everybody, to this physiotherapy virtual international physiotherapy conference, Knospe 2020. Now, I'm Dr. Abhay. I would like to share with you a common problem encountered in our routine practice by the physiotherapists as well as by the ENT department. That is BPPV, benign paroxysmal positional vertigo. Certain things are common to both the specialties, and some of you will be nodding your head saying yes, yes, or no, no, and getting into vertigo. So just to avoid that, I'm giving you a brief introduction or a brief lesson planning as how I'll be going through this topic. There will be introduction, a brief introduction, then there will be quick recap of functional anatomy of labyrinth. Then I will include vestibular physiology, then vestibulo-ocular reflex, then clinical features and management. Management is mostly done by the physiotherapy colleagues, that is you all, and therefore I will not be talking much in detail. Now let me go with the first slide. Now BPPV is the commonest presenting cause of vertigo. More than 90% of the time the vertigo caused is due to this entity. Now it has characteristic history and therefore it can easily be diagnosed during clinical examination itself. Now, BPPV is associated with reduced quality of life, such as frequent falls and being repeatedly feeling vertiginous, and especially the elderly people, they get into depression as well. Way back in 1952, Dixon Hallmark coined the word benign paroxysmal positional vertigo. And they were also pioneer in describing some of the provoking manners of this disease. Now, vertigo is a sensation of rotation in absence or actual presence of stimulation. A positional vertigo is similar sensation of spinning with certain head movements like head up or down. Other peripheral causes being labyrinthitis, vestibular neuronitis, Meniere's disease, and so on. Now, BPPV is caused by problem in the inner ear. The BPPV is thought to be caused by presence of debris, of endolymphatic debris in one or more semicircular canals. There will be tiny calcium carbonate stones present inside the semicircular canal of the ear. These otolith bodies, they help controlling the balance otherwise normally during natural movements. Now, displaced otolith bodies float into another part and then therefore causes abnormal movement of the inner ear fluid and stimulation of that particular or unilateral labyrinth. Therefore, the disequilibrium between the two sides and the vertigo. Now, BPPV is termed as benign because it is very much a naturally resolving condition. But BPPV is not entirely benign, especially therefore in elderly people, wherein it is often unrecognized and can lead to frequent falls and disequilibrium thereof. Now, similarly, it is not very benign. Causes for displacement of otolith may be known or unknown. There may be trivial head trauma to noticeable strong head trauma. So while eliciting history, one has to keep in mind. And then there'll be excessive stress like situation and of course aging. And these are some of the causes blamed for this condition. Now, just to recapitulate quickly the anatomy of the vestibular system, it is divided into two parts, mainly the saccule and utricle, and three semicircular canals. The macula and crista ampullaris are the two neuroepitheliums present in the vestibular labyrinth. The macula is present in utricle and saccule, and crista ampullaris is present in the semicircular canals, the ampullary ends of the semicircular canals. This is purely a diagrammatic picture, pictorial view of the labyrinth. This is superior semicircular canal. This would be a posterior semicircular canal, and this is a horizontal semicircular canal. These three semicircular canals, they have common place of opening, and that is called utricle. There is also saccule. Now, utricle is concerned with the movement or sensation of movement when it occurs along horizontal axis. And now this saccule is concerned with the sensation of similar movement along vertical axis. And whereas these semicircular canals are concerned with movement along any axis, circular axis. Now, combination of these three semicircular canals, which are in perfect perpendicular plane to each other. So, movement of head or body occurring at any axis, the combination will be able to sense. The ear will be able to sense the combination and then send accordingly appropriate information to higher centers. Now this is occurring in 1 year, and then opposite also will be occurring in opposite year. So say for example, plus some action potential developing in this side, and there'll be equal and opposite minus action potential will be developing in other side. And as long as they both are in equilibrium, the person feels in balance. Moment they go into disequilibrium, then there is a disease. That means peripheral vestibular apparatus disease or disorders produce disequilibrium and therefore becomes our concern. Now, next slide. Utricle and saccular maculae are overlain or overlaid by otoconial membrane. Now, this otoconia are the crystalline particles composed of calcium carbonate surrounding a proteinaceous core. Now, this is very important to understand. So also the hair bundles, as you can see here, these are hair bundles to which there are the nerve fibers attached. The one of the longest hair is called stereocilia, which remains directly in contact with the cupula above. And then this is again a diagrammatic picture of left semicircular canal, horizontal semicircular canal for better understanding, and a right semicircular canal, and then the hair cell of this crista ampullaris, and a diagrammatic picture also showing movement of head, rotational movement of head towards left will produce movement of inner ear fluid towards the right, as it is depicted by these blue colored arrows. Now this movement towards ampulla and away from the ampulla. This is occurring away from ampulla, and this is occurring towards ampulla, the stereocilia. So will produce accordingly excitation of the nerve fiber and inhibition of the nerve fiber. That means excited. If the head rotates to left, inertia will result in movement of the endolimb to the right and produce excitation in left horizontal semicircular canal. Similarly, opposite will happen and produce inhibition in the stem of the right horizontal semicircular canal. Vestibular ocular reflex is another thing to be remembered to understand proprioception. The vestibulo-ocular reflex is a complex system of neural interconnections that maintain foveation of an object during change of head position. Now, proprioceptors are the vestibular system of the vestibular system are the semicircular canals. And the semicircular canals, they respond to changes in the angular acceleration due to head rotation. Now, there are some terminologies like variants of BPPV. The most common variant is due to affection of the posterior canal. Then there can be affection of the anterior superior semicircular canal, then the horizontal or lateral semicircular canal, and combination of all these three canals, torsional BPPV. So these are variation of the terminologies. Now, coming to clinical features are very much straightforward, and moment we get such clinical features, one has to suspect BPPV unless proved otherwise. Now, sudden and distressing onset is commonly patients they present with. Then there will be recurrent episodes of vertigo and not lasting more than a minute. Now, symptoms are provoked by specific head movements, such as looking up while standing and sitting, lying down or getting up from the bed, rolling over in the bed, and waxing and waning pattern of vertigo. These are the typical features the symptoms will have. Then there will be nystagmus if you go to see, and sometimes there will be associated nausea and vomiting. This associated nausea and vomiting usually not present as long as the stimulation of the labyrinth is mild type. When then stimulation is excessive, then only it will be associated with nausea and vomiting. Otherwise, no. There will not be any neurological symptoms. So neurologically, patient will be absolutely fine or normal. Now, coming to management. Now, management consists of particle repositioning, which are free floating and abnormally moving maneuvers. There can be certain medications. These are symptomatic medications, and there are surgeries, of which surgery option is better avoided due to possibility of associated hearing loss. About more than 20% hearing loss will be there after any surgical procedure if it is resorted to. Now, amongst the surgical procedure, there is singular neurectomy, one may call it as posterior canal plugging procedure. Now, this is with an attempt to block the movement of the free-floating otolith bodies. If at all they are not able to be eliminated by proper positioning maneuvers, then one has to resort to a procedure called plugging of the posterior canal, where it is commonest site. It has to be plugged, thereby confirming that there is no movement or abnormal movement as to produce stimulation and relief from vertigo. And then vestibular nerve sectioning. All are associated with certain losses of quality of life. Now, medications are antiemetics, because if there is a nausea and vomiting and feature, antiemetics will come to help. Antihistaminics, by virtue of dehydration and labyrinthine sedation action, they will also come into help. And similarly, anticholinergic will be useful in hyperemesis. Now, regarding particle repositioning maneuver, that is mainly concerned with you people, physiotherapists. The best among that, the choicest treatment is Epil's maneuver, then Simon's maneuver, brand of exercises of home exercises are the important and easily remediable solutions to the problem. Using high-tech, regarding diagnosis, using high-tech video goggles with infrared cameras, a video nystagmography can be undertaken. Now, this video nystagmography, one needs to know, it is a recent advancement in diagnosis or diagnosis making of this condition. It addresses the function of each ear. It is also complete diagnostic system for recording one thing, and that is important from point of view of legal aspects or litigations, if any, then analyzing and then reporting of eye movement using video imaging technology. Little bit expensive since it is modern. It incurs a little cost, but it is more useful in this way. Now, by testing with VNG or video nystagmography, one can determine whether a balance or dizziness problem is due to central or peripheral vestibular lesions. And if peripheral, it can further differentiate between whether it is unilateral or both bilateral vestibular loss. So that's a little applied information about most recent diagnostic facility, video nystagmography. Now, BPPV can be treated overall by resetting the dislodged otolith using canal-lith repositioning either by Epil's, Simon, Foster, or Brander maneuvers. Now, after one sitting, two sitting, or repeated sittings, a person is asked to practice at home. That is head positioning exercises I think you all are well versed with it. I need not, therefore, I am not explaining in detail about it. Therefore, now in this head positioning exercises, like one sits at the edge of the bed, turns head to 45 degrees to right first time, and then quickly lie down on left side and stay like in that position for 30 seconds. Again, after 30 seconds, he quickly moves, maintaining the same position of head onto opposite side, that is right side of the bed, and wait for another 30 seconds or so, and return slowly to sitting position and wait for a few minutes. And one may reverse these for the opposite side as well. These are some of the treatment manuals. The best one can also advise, walking is simple yet powerful exercise for vertigo. And that's all. I think my talk is over. Hello.
Over.
Anand sir, I finished my talk.
Thank you. Thank you, sir. Thank you very much to you, sir. We are highly indebted to you. Please accept our thanks for your enlightened speech.
Thank you, sir.
Usually, we have seen many dignitaries fall down during the work or some after 40, 45. The patients suffering from vertigo, usually they have an emotional experience and they completely have a belief, complete belief of relief. Actually, when the facts are told by you directly.
Yeah.
So if we tell, they don't believe. When you are telling, they believe. I have seen in many people here in Satara, Karada. Yeah. So it was our pleasure for you to invite you, sir. Yes, people believe and they have belief upon the exercises. When we tell, we will confirm with the ENT surgeon. They will tell.
Yeah. Actually,
thank you very much, sir.
ENT and physiotherapy should go hand in hand.
Yes, sir.
And both are complementary to each other. I mean,
sure, sir.
Not only in this, many other disorders as well.
Yes, sir.
Yes. Thank you very much, sir.
Thank you, sir. Thank you, sir.
Bye-bye.
Thank you, sir.
Thank you.
Yeah. So we shall begin with the next session. Dr. Krista, are you here?
Yeah, I'm here. Thank you.
So shall we start?
Yeah, I can share my screen.
Yeah. Just I'll give an introduction. We will start.
Okay.
So a very good morning to one and all present here. Once again, we welcome you all to the International Physiotherapy Conference, Knospe 2020. Health professionals' integrity is a hallmark of physical therapy and rehabilitation. Now we shall start with the first international speaker, Dr. Krista. She is working at Slater Senior Care, Pace in California. Krista graduated from Touro University, NV in 2013 with a doctorate in physical therapy. Since this time, she has worked in several different settings, including acute care, acute rehabilitation, outpatient, home health, and now PACE. She has a passion to provide best care to our most vulnerable geriatric population. We welcome you, ma'am, from the organizing committee of Knospe 2020.
Thank you. Let me share my screen. Can you see it okay?
Yes, we can see the screen, ma'am.
Perfect. So my name is Krista. I currently live in Sacramento, California. I just wanted to say thank you for inviting me. I feel very honored. And I hope this presentation is helpful to you to provide treatment for patients in the future. So let's get started. I'm going to leave it like this so I can toggle back and forth between screens as long as everyone can see it okay. All right, so let's start with the anatomy. Just here's some basic anatomy just to review. There's three portions of the ear just to kind of orient us. There's an outer ear, middle ear, and inner ear. So we'll mainly be staying within this inner ear portion throughout this this lecture. So the inner ear, there's many different components. First, there's the semicircular canals. As stated prior, there's the anterior, lateral, and posterior. There's fluid within these canals, and there's a utricle at the bottom of them with a saccule. The otoconia are housed within the utricle. There's a gel membrane and these hairs, and the hair sends signals in the sensory cells to the vestibular nerve. So you can see that right over here. All right. So a little bit about pathophysiology. BPPV is actually the most common cause of vertigo in patients with vestibular disorders. It is a mechanical disorder of the inner ear, and it's caused by abnormal interaction of the semicircular canals, cupula, and displaced otoconial from the utricle. Otoconia cause an increase in mass of the cupula, causing the semicircular canals to become sensitive to linear acceleration. And the symptoms would include that vertigo or dizziness that's often provoked by patients will say, oh, when I'm laying down, I turn in bed and I just feel so dizzy. That's a sure sign of BPPV. So let's move on to differential diagnosis. There's other things that can present similar to BPPV, so you want to make sure that you're ruling them out before you decide that it is BPPV and go forward with the maneuvers. So the first one that I have a few up here that are common. So labyrinthitis, it's an infection or inflammation of the inner ear that causes dizziness and loss of balance, and it's often associated with upper respiratory infections. And then Meniere's disease, you want to make sure to rule this out as well. It's associated with a change in fluid volume within the parts of the labyrinth. It causes episodes of vertigo, but also like hearing loss, tinnitus, which can be a ringing in the ear, and a feeling of fullness. So often patients will say that they just are feeling a lot of pressure in their ear. And so you want to make sure that you're ruling out Meniere's disease. Vestibular neuritis, it's an inflammation of the vestibular nerve and can be caused by a virus. It affects young to middle-aged adults and often follows after upper respiratory tract infection. And then purulent fistula, it's a leakage of the inner ear fluid into the middle ear. So if I go back to the slide, this fluid can actually leak into the middle ear here. And this would cause dizziness, but as well as
Dr. Krista, can you unmute yourself, please? Dr. Krista?
Is that better?
Yeah, now it's fine.
Did you hear me throughout the whole thing?
Yeah.
Or is it just now?
Yeah, I can hear you.
Okay. Did you hear me prior or no?
Yeah, we were hearing you.
Okay, wasn't talking to myself. Okay, thank you. So this can often, you'll feel, the patients will feel more dizzy when they're doing something that's exertion. And it can happen after ear surgery or chronic ear infections. And so you want to make sure that you're ruling that out as well. And then the last one I have up here is orthostatic hypotension. Often patients will say when they're getting up, when they're sitting from laying down or standing up, they'll say, oh, I'm feeling so dizzy. And you want to make sure that you're ruling out and taking blood pressure when the patient is lying to sitting and then sitting to standing, just to make sure that you're taking out, you're taking into consideration their blood pressure. All right. So diagnosis and treatment precautions. Before you move into the testing for BPPV, you want to make sure that you're taking into consideration the history of the patient. So you want to make sure that you're taking into consideration any cervical disease, lower back disease, any bigger patients, they often have a harder time getting into some of the positions. So you need to take that into consideration, as well as vestibulobasilar insufficiency. So you want to make sure that you're using that vertebral artery test prior to any of the maneuvers. Okay, so there's two types of BPPV, canalophysis and cupulophysis. So canalophysis, when you're doing this testing, the symptoms will last less than 60 seconds. And in cupulophysis, the symptoms will last greater than 60 seconds. So the difference is in canalophysis, the otoconia will be free floating within the semicircular canal. So if we go back to the first slide, in canalophysis, these otoconia here can become dislodged and be free floating within the canals here in the inner ear. And it can happen in the anterior, lateral, or posterior, but most common is in the posterior canal where they would become dislodged. In cupulophysis, the otoconia, these deburse here, the otoconia, they'll become dislodged, but they'll be dislodged on the cupula itself. So that's on the bottom of these semicircular canals, and they'll actually be stuck. And so that's why the symptoms will last longer than 60 seconds. So in canalophysis, the otoconia are free floating within the semicircular canals. And so that causes the inappropriate stimulation of the sensory hair cells, which is causing that vertigo. Some treatments would be the Epley maneuver and the barbecue roll. So the Epley maneuver is used for the posterior and anterior canals, and the barbecue roll is used for the lateral canal. In cupulophysis, where that deburse is adherent to the cupula, you would use the Samant maneuver for the posterior and anterior canals, and then you would often use prolonged positioning for that lateral canal. Okay, so first let's move on to testing. And I have a few videos that I can show you. You won't be able to probably hear the volume, but I'll talk throughout. So first is the lateral canal, to test the lateral canal and to test to see if it is the lateral canal. You'll be doing what's called the supine head roll test. So let me pull up a video. And I'm gonna play it here. So you're gonna bring it down, the patient down. They're supine and their head is in 30 degrees flexion. He's gonna turn the patient's head to the right. You're looking for nystagmus when you're doing this. And then he's gonna turn the patient's head to the left. He's also gonna be looking for nystagmus. And then he's set back up. And then the second one, the second maneuver, and this one's often used, is the Dix-Hallpike maneuver. And so in this testing, I have a picture here. The patient is sitting, and you are going to bring them as down as fast as you can at their comfort. And you'll be bringing them into a laying position with their head extended at 20 to 30 degrees. And their head is also rotated at a 45-degree angle. So similarly, in the supine head roll test, if they are turned to the right and you're seeing nystagmus when they're turning to the right, it's the right ear that's affected. And in the Dix-Hallpike maneuver, when you turn their head to the right in that 45-degree angle, you're testing that right ear. But if you're having them look to the left and completing the maneuver, you're actually testing the left ear. So that's something to keep in mind. Let me show you a video of testing for the Epley maneuver or Dix-Hallpike. So you have them weigh down quickly. You have their head in that extension. And you're watching for nystagmus. And that's what nystagmus looks like if you haven't seen it before. Okay. So to note also, when you're doing any of those maneuvers, you want to make sure that you're having your hands on the patient because they will be so dizzy. And it just builds trust between the patient and you. You just want to make sure that they're feeling comfortable throughout the maneuver because it's going to provoke any kind of nausea or vomiting that they may have experienced prior. So these are the eye movements that you'll see when you're performing these tests. Posterior canal, it provokes a rotatory upbeating nystagmus. If you're testing the horizontal canal, you'll see a horizontal nystagmus. And then when you're testing if it's the anterior canal, you'll see a downbeating. So you do the Dix-Hallpike for the posterior and anterior canal, and you're doing the supine roll for the horizontal canal. And so the way you tell the difference, if it's the posterior or anterior canal, is when you're looking at that nystagmus. If it's the upbeating, then it's the posterior, which is most common. And if it's downbeating, then it's the anterior canal. Okay, so let's get into some of the treatments. And we're really just going to focus on the treatment for posterior canal BPPV because that's what we have time for. But also it's the most common. So Epley maneuver actually has a 90% success rate. So we'll talk through the maneuver and then I'll show you a video on it. And you just want to make sure that you're starting on the affected side. So when you're performing the Dix-Hallpike, it looks similar to these two pictures, right? And so when you're testing a patient for BPPV and they are positive when you're doing the Dix-Hallpike, you actually probably just want to go through with the maneuver because these patients are often really dizzy. And so you want to get the most bang for your buck when you're doing any kind of maneuvers. And so if you're already provoking any kind of dizziness in the patient, you might as well go through with the maneuver that would help them, right? So the way the Epley maneuver starts is you have the patient face towards the affected side. So let's say that in this picture, the affected side would be the right ear. You're holding the patient's head. You're bringing them down into supine where their neck is extended into that 20 to 30 degree angle. And you're gonna watch for the nystagmus. And so you wait for the nystagmus to occur, you watch the nystagmus, and then you wait for it to end. And that's when I start counting to 30. Other therapists I know, they'll go into extension and after 30 seconds, they'll move forward with the next maneuver. I have been taught from my schooling that the best way to make sure that this maneuver occurs correctly is to watch the nystagmus, wait for the nystagmus to stop, and then count to 30 seconds so that you make sure that that crystal is moving through the pathway that it's supposed to in that posterior canal to get back into the otoconia. So you have them in the extension and then you're waiting for the nystagmus to stop and then they're going to turn their head 90 degree angle. So that's actually 45 degrees to the right and you keep them in that extension. And then similarly, you have them, you're watching for the nystagmus, you wait for it to stop and you count to 30 seconds. So if I ever give this treatment for a patient at home, I'll tell them wait for the symptoms to stop, wait for your dizziness to stop, and then count to 30 seconds. So from that angle, you're going to actually have the patient roll over here, and they're going to be looking down. And the same thing, you're waiting for the nystagmus to stop. And then you count to 30 seconds, and then you'll have them sit up. Okay, so let's actually watch a video on that. So they're turning their head to the right, 45-degree angle, her neck is an extension. So then they're going to be turning their head to the left. She's looking downwards. And then she's going to sit up. All right. So traditionally, you would be helping that patient in the clinic. And so often in the clinic, there will be this little lever where you can lower it down to like that 20 to 30 degree extension, which will be really helpful, especially when it's their first time performing the maneuver. It makes them feel a little bit more comfortable when their head is touching something instead of just being free floating in the air. So this is the scenario that would be the most desired. However, that doesn't always happen in the clinic, right? And also, they probably do not have that treatment table at home. So when you prescribe this treatment, the Epley maneuver, sometimes therapists will say, please perform this 3 times per day until your symptoms are gone for 24 hours. If you want the patient to do this prescription at home, it's helpful if they're going to have a pillow behind their shoulders, their shoulder region here. It helps to get the patient into that 20 to 30 degree angle of neck extension without them feeling like they're insecure, because you don't want them holding their neck in extension with it not being on anything, especially for older patients. You definitely don't want them falling off the bed, things like that when they're performing these kinds of maneuvers, right? So you want them to feel secure if you're going to have them do anything at home. And often working in the emergency department, I would be asked to come down and assess and rule out BPPV. So in the ER, often patients are on something like this, a gurney. If you're lucky, they're on a hospital bed or something like this. So if you're going to be testing and doing the Dix-Hallpike in a hospital setting, you want to make sure that you're taking off the side rails. So we'll first go with this scenario. You want to make sure that you're taking the side rails off of the bed. Often I would take off the foot of the bed here. And I would have the patient sit and look towards the head of the bed. So the feet are on the side and the head is on this side. I would angle this bed. This is the best scenario, really. You would make the bed totally flat, and then you could actually raise this portion and this portion would stay lower. So you could get that 20 to 30 degree angle without having to have them put their neck in extension. So that's really nice. I would really just have them laying down with like their feet up here and their head down here, and they don't have to put their neck in extension at all, and you're getting that 20 to 30 degree angle. And then you can test for BPPV. In this kind of a scenario, it's not as easy. Usually the foot of the bed will come off, and so you can have them perform the maneuver with the bed flat and their head over here, but you want to make sure that you are helping them feel secure and you're really holding their head really well, because it will be off of the edge of the bed to get that 20 to 30 degree extension. And then last but not least, the gurney is often used in the hospital setting. So same thing, you want to make sure it's flat. You don't have as much of a option in how high or how low the bed is. So you might be standing or sitting really low when you're doing this maneuver, but you want to make sure that you're getting that 20 to 30 degree extension. So you're getting the true test. So that's the end of my presentation. Thank you for letting me talk and join you. Are there any questions?
Yeah, thank you so much, ma'am. It was indeed a very nice presentation.
Sure, no problem.
So I'll just check for any questions are there. No. So you have got some responses that it is indeed a great presentation from you and the concepts are very clear. We have got a comment for you, ma'am. And
awesome.
The presentation was really nice, ma'am. Ma'am, can you please tell us again how can we differentially diagnose between the types of vertigos?
Oh, absolutely. I can absolutely go over that. Let me share my screen.
Ma'am, please unmute yourself. Ma'am, can you please unmute yourself? Ma'am, please unmute yourself. Yes.
There it is. Perfect.
Yes.
Got it. Thank you. Sorry.
Yes.
I was trying so hard to unmute myself. Okay, let me go up to this slide here. So there's canalophysis and cupulophysis. So when you're doing the Dix-Hallpike maneuver, when you perform the maneuver and the patient is in supine with their head extended, and the nystagmus are occurring for less than 30 seconds, then that's going to be canalophysis. If the nystagmus are lasting longer than 60 seconds, that's when it's going to be cupulophysis. And keep in mind, canalophysis, it's more common.
Okay.
And then there's just different the different canals that it can be in. So if it's in the anterior canal, or if it's in the anterior or posterior canals, you're going to be performing the Epley maneuver. And that's when you're going to be getting the rotary upbeating or downbeating. So if it's upbeating, then it's the posterior canal. If it's downbeating, then it's the anterior canal. And then when you're performing just the supine roll and you're getting any kind of nystagmus, that lets you know that it's definitely the horizontal canal. But most often it's the posterior canal that's affected.
Okay. Ma'am, there is one more question. Depending upon the classification, how does the physiotherapy treatment exercises change?
Sure. So depending on the canal, so let's say that you have canalophysis. That's going to be performed with the Epley maneuver would be the treatment, or the barbecue roll. We didn't have time to cover that one, but that would be the treatment for canalophysis if it's in the horizontal canal. For cupulophysis, you would be using the Samant maneuver because those otoconia are affixed to the cupula. You want to try and dislodge them from that cupula. And so you're trying to get the adherent deburse off of it. And so that's when you're doing the Samant maneuver, which we didn't get to cover either. But it's more of a forceful maneuver into side lane on one side and then side lane on the other side quickly. Or you're trying to use prolonged positioning that can help as well. So if the idea is if you're in a position long enough, then it will help the otoconia come off of that cupula.
Okay.
So we really only covered the Epley maneuver, but there's 3 others that you could use depending on what canal.
Okay. There is one more question, ma'am, for you. Should the medical treatment and the physiotherapy treatment go hand in hand for vertigo? Or are there any researches regarding it?
I'm sorry, the physiotherapy treatment and which other treatment?
And the medical treatment, the medical line.
Oh, absolutely. I think they should absolutely go hand in hand. I think that the interdisciplinary approach is always the best approach. Whenever you're doing any kind of interventions with a patient, you always want to make sure that you're including the doctor, the nurse. I think everybody has their own outlook and also their own insight into the patient. And when everybody works together, that's when really the patient has the best outcome.
Okay. Ma'am, there is one more question. How to differentiate between VOR and BPPV?
Oh, absolutely. So if the patient has true BPPV, they will have nystagmus in these maneuvers. VOR is something different where, let me bring up the slide of the anatomy, is where when the nerve is the vestibular nerve and the ocular nerve are having difficulty transmitting the signals to the brain. And so that's 2 different ones. The BPPV is like mechanical, something is wrong where the otoconia are out of the utricle and they're in the semicircular canals. But VOR is vestibular. And so that is something like within the brain and the nerves, the nerve conduction. It doesn't have to do with the otoconia being outside of the utricle at all. So those maneuvers should be negative if it's VOR.
Okay. Thank you so much, ma'am.
You're welcome.
So you have really very nicely explained to us regarding BPPV, and on behalf of Krishna Institute of Medical Sciences deemed to be university and Krishna College of Physiotherapy, we express our gratitude towards you for accepting the invitation and delivering your presentation. Thank you so much, ma'am.
Thank you. Thank you so much for having me.
Thank you. So we shall begin with the next session for the day, that is a temporomandibular joint dysfunction and post-operative care, headed by Dr. Srinivas K and Dr. Deepak Annap. I think Dr. Srinivas has joined in. Dr. Srinivas? So please unmute yourself. Sir, Srinivas sir. Yes, sir. Now you are audible. You have unmuted.
Yeah, can you hear me now?
Yes, sir. You are set, sir?
Yep.
Dr. Deepak Khanna? I think he shall join soon. Dr. Anand, are you here? Dr. Anand? Yeah. Srinivas, can we start with the session?
Yeah, please.
Yeah. So I hand over to Dr. Anand for the next session. Dr. Anand, kindly unmute yourself. Yes, sir, you are audible.
Now I am welcoming our honorable resource person, Dr. Srinivas sir. He is an expert in orofacial pain and neurosensory dysfunction of maxillofacial complex and oral mucosal lesions. He is working in Manipal Hospital, Bangalore since 2003. For the past 18 years, he is post-PG experience, and past 25 years since 1997 he is practicing after dental surgery. He has published extensive articles, 27 articles in PubMed journals, and in oral medicine books he has published 3 chapters. He has been a constant continued researcher and participated in systematic reviews projects. He is an expert in oral medicine, oral ulcer and facial clinic, and treated many patients, and it is the first orofacial pain clinic he started in South India in 2003. He had given many lectures, around 50 lectures he has given in medical and dental institutions. He has presented many papers, international conferences, and he is an academic rank holder, second rank holder in RGHS from the starting. Thank you very much, sir. Please join the session.
Am I audible?
Yes, sir, you're audible.
Thank you very much, Dr. Anand, for the kind introduction. A very warm good morning to one and all. First of all, let me thank the organizers for making me a guest faculty for this conference. I always like to be united with all the people belonging to the medical profession. Thank you so much. Greetings from Manipal Hospital. Well, today I am here to talk something about temporomandibular disorders. Now, these temporomandibular disorders has been a source of considerable controversy in the dental community because it's a multifactorial disorder and so many people believe in a lot of concepts of their own. And there are plethora of textbooks on temporomandibular disorders. So I feel it is extremely difficult for me to concise the matter and tell it to you in a small session like this. Whatever it is, I have tried my level best to concise the presentation and finish it in 40 minutes. And whatever I felt is very much necessary for you to understand, I have just put forth in my slides and I will be continuing to do so. Now, what exactly is this? See, in our country, most of the times, even today, the main complaint that brings a patient to a clinician is pain. And when it comes to head and neck region, face, head and neck region, I feel temporomandibular disorder is a major source of pain. Now, before going into the details of this particular temporomandibular disorders, let's discuss in 2 slides the basic anatomy of the temporomandibular joint. Temporomandibular joint is a part and parcel of the masticatory system. This temporomandibular joint is nothing but an articulation between the upper and the lower jaws, and teeth form the contact between the upper and the lower jaws. Now, the condyle of the mandibular bone and the temporal bone, which forms the glenoid fossa, forms the temporomandibular joint. Now, there is a disc. There is a disc just like the spinal bone. We also have a disc in between the condyle and the temporal bone, and it is lined by synovial fluid. And in contrast to other joints, we don't have hyaline cartilage here. We have a fibrocartilaginous tissue. Okay, the disc is biconcave in shape. Posteriorly, the disc is attached to, we'll come to it later. So this is the basics of the temporomandibular joint, the bony components and the disc. Now, when you come to the disc, as I told you, the disc is biconcave in shape. Posteriorly, it is attached to a bilaminar zone. Anteriorly, it is associated with the pterygoid group of the lateral pterygoid muscle. The lateral pterygoid muscle, and laterally, it is reinforced with the temporomandibular ligament. Now, to perform the actions of speaking, eating, and all other like chewing, it is aided by the muscles of mastication. So when you talk about the temporomandibular system, it comprises of the joint, the disc, the ligaments, and mainly the muscles of mastication. I think you all are aware of what exactly are the muscles of mastication. We have the temporalis, we have the lateral pterygoid, we have the medial pterygoid, and we have the accessory muscles, the sternocleidomastoid, trapezius, and the digastric. There are four main muscles, the medial and lateral pterygoid, temporalis, and masseter, and three accessory muscles, the trapezius, sternomastoid, and digastric, which aid in performing the masticatory movements, the chewing, speech, as well as swallowing. Now, this is about the anatomy. So today, whatever we are discussing, the temporomandibular disorders are nothing but the disorders affecting this particular system. Now, the temporomandibular joint disorders, before going to that, in a clinical point of view, what I want you people to recognize is the joint is very, very unique. As physiotherapists, what you people advise to patients on a routine basis is, whenever there is any muscle tear or a ligament tear or anything, most of the times you will be advising rest. You will be advising immobilization, fixation, and so on and so forth. In TM joint, it is not possible because the patient has to, in very rare conditions, we do immobilization, but not on a routine basis, because this is the only joint that performs about 2,500 to 3,000 movements per day. Number one. Number two, this is the only joint in the body that is diarthroidal. That means both the joints are interdependent. They are not independent like other joints in the body. So what do you understand from this is, if there is any pathology affecting one particular joint, it has the effect on the other joint as well. So it has to be collectively treated. And since this joint is performing so many movements per day, you can't expect immediate healing like you expect in other joints, because you are trying to do the healing by different types of treatment modalities. At the same time, patient is using the joint. So the joint is not getting rest to heal. The last but not least uniqueness of this joint is it is a gyngymo-arthroidal joint. Probably this is the only joint in the body that performs two kinds of movements. It performs gliding movements and hinge type of movements. Now these things are necessary when it comes to the treatment point. When I talk about that in that slide, I will let you know. Now, temporomandibular joint disorders are a subgroup of orofacial pain disorders, which can be broadly classified into two for ease of understanding and treating purposes. It is viewed as a syndrome. We can divide this particular disorders into myogenous component and arthrogenous component. In myogenous component, predominantly we are dealing with the pain and dysfunction generated by the masticatory musculature and pathologies relating to the accessory muscles of mastication also. So it is predominantly a muscle generated pain related to the masticatory musculature. When it is arthrogenous TMD, it is a joint generated pain where the disc and the other components of the joint are involved. Now, if you look at the epidemiology of this particular disease, the prevalence is 5 to 40%. But we don't see those many cases in our clinic, do you? We don't see. Because only 2.8 to 22% of these patients will have symptoms severe enough for seeking treatment. That means our human body has got a fantastic functional adaptation capabilities, and that capability is more in the temporomandibular joint. That is the reason, even though there are symptoms and the prevalence rate is high, very less number of patients they seek treatment. In my experience, I would say about 5 to 10% of the population suffer from this particular disease who seek treatment, and only about 3% of the people they go into chronicity. What exactly causes this temporomandibular disorders? Dr. Trupti, am I audible?
Yes, sir, you're audible.
Yeah, if there's anything, please ping me.
Yes, sir, sure.
Well, talking about the etiology, it's a multifactorial disease. There are so many factors that cause dysfunction of the temporomandibular apparatus, the temporomandibular disorder. Psychological disturbances, parafunctional habits, occlusal disharmony, cervical muscle dysfunction, and trauma to the joint and the musculature. These are the things that can cause temporomandibular disorders, either myogenious or arthrogenous. The causes are the same. If the myogenious disorders are left untreated and it goes on for a longer time, it will probably get converted into arthrogenous TMD. Now let us take up one by one and see how exactly this causes temporomandibular disorders. Number one, trauma. Trauma can be of different types. It can be trauma as well as micro trauma. First, let us talk about trauma. Number one, blow to the joint. Dr. Trupti, are you able to see the pointer? I'm sorry. Dr. Trupti, are you there?
Yes, I am here.
Can you see the pointer here? The
Yes,
mouse
sir.
pointer?
Yes, sir. Yes, sir. We can see.
Okay, okay. Thank you. Thank you. Well, a sudden blow to the joint is one kind of a trauma. Whiplash injury, which you people are very much aware of, the acceleration, deceleration injury. Prolonged dental procedures. Sometimes an oral surgeon comes and takes about 2 hours to remove a wisdom tooth, and patient is asked to keep his mouth open for a prolonged time. This is one kind of trauma. And you all know that during endotracheal intubation, general anesthetic procedures, patient's mouth is kept open for a longer time. And while intubating also, the patient's jaws are a kind of pulled. So all these are traumatizing events for the masticatory system, the muscles. This will cause temporomandibular dysfunction. So trauma to the joint. The second thing, all these events, trauma to the bone, the dental procedures, anesthetic procedures, they are all self-limiting. You give them appropriate treatment, they will disappear very soon. But if a patient is having a whiplash injury and then he is getting a temporomandibular disorder, it would be called a post-traumatic temporomandibular disorder. What you need to understand is, in contrast to normal individuals, individuals with a history of whiplash injury have got a poorer prognosis. And they also take more time to respond to the treatment that we conventionally give. Next, let us talk about microtrauma. What does microtrauma do? Microtrauma causes a sustained and repetitious adverse loading of the masticatory system. The major cause of microtrauma is postural imbalance. People, majority of the people who are techies, who are software engineers, they don't have postural balance. They are always having postural imbalance because they are sitting in a forward head posture. Majority of the individuals in today's generation, especially the kids at the ages in between 11 and 20, if you just see them watching television or talking on the phone, they are always in abnormal postures. Most of the times they are lying down, they never sit. Phone bracing is another dirty habit that all of us have these days. We have 2-3 mobile phones and always we are busy chatting in the phone, and most of the times our posture is not good. Last but not the least, unilateral chewing. What is this unilateral chewing? Unilateral chewing is chewing from one side. In most of the Western countries, they have dental insurance and routinely they go for a dental checkup. And whatever problem is there, they get rectified. In India, the first person to interact at dental pain is a medical shop owner. If they have pain, they go to the medical shop first. 2 or 3 attempts they will do. If pain subsides, they will stay there and they will never get it treated unless and until it becomes worse. As a consequence of this, what happens is the tooth where pain is present, patient will stop chewing from that side because there is pain. He will not seek treatment. Instead, he will stop chewing from that side. Because of that, there is adverse loading of the temporomandibular joint. Patient gets into this particular problem. So in Indians, it is a very, very important thing. You have to recognize in your history, you have to ask whether you chew the food on both the sides of the teeth or one side of the teeth. Very, very important. In my practice, I feel a lot of patients have this problem. Now, secondly, how does postural imbalance affect the temporomandibular system? I will just show you and make you understand with a simple picture. Now, this theory also holds good for how cervical vertebral pathology, spondylolysis, spondylolisthesis, spondylitis, and neck muscle dysfunction can cause temporomandibular joint problems. Just concentrate on this picture. I have got two individuals here standing. The first individual is an individual who is in a normal posture. The second picture is an individual who is standing in an abnormal posture. When a person is standing in a normal posture, what we see is there are muscle centers at the neck, chest, lower back, thighs, calf muscle, as well as the toes. Now, what do these muscle centers do? These muscle centers, they oppose each other and maintain a physiological state of equilibrium of all the muscles of the human body from head to toe. From head to toe. If a person's balance is lost, there is postural imbalance, not balance, postural imbalance. If he does not maintain his posture properly, there is a shift of muscle centers and the physiological equilibrium of the muscles is lost. As a result of that, the muscle becomes fatigued. The muscle undergoes spasm. There will be inflammatory changes and patients will start complaining of pain. Now, one important thing that you should recognize is all these muscle centers, they're all in a physiological state equilibrium. If one muscle group gets involved, the next muscle group takes that tension. It also responds to that inflammation. That is the reason why change in posture can cause temporomandibular joint pain. Now, when there is a shift here, equilibrium is lost, it is resulting in pain. I am telling you, there are studies which has proved that temporomandibular joint pain can come as a consequence of low back pain, as a consequence of cervical muscle pain. There are also studies who have proved that wearing high heels also can change the posture and cause temporomandibular disorders. Number two, I also told you about cervical muscle dysfunction. In cervical muscle pathology, what happens is when cervical musculature is under dysfunction, that tension is shared by the masticatory musculature and patient starts feeling the pain. This can be beautifully identified when you examine the patient. When you are touching a trigger point on a neck muscle, normally, if a patient is not having a temporomandibular joint pain, the pain is limited to the neck muscle. But if the masticatory musculatures are involved, when you touch the neck muscle, the trigger point, the pain radiates to the masticatory muscles. That is a classical thing that you can notice in case of a craniocervical dysfunction. And the second thing, why cervical muscle pain causes TMJ pain is, if you look at how the pain is transmitted in the head neck facial area, it is unique. The pain, the nociceptive inputs from the head, neck and face, they are transmitted through nucleus caudalis of the trigeminal nucleus to the cerebral cortex. So what happens when the pain is getting transmitted, there is something called as central summation. Because of that, what happens? Pain in the neck is interpreted in the brain as pain in the jawbone. This is a second reason why patients will feel pain if they have neck muscle pathology. I think it is very clear. So we have covered trauma, we have covered micro trauma, we have covered postural imbalance, we have covered cervical muscle dysfunction. Now let us see. There was a certain study done in, this is just to prove what postural imbalance causes, causes to the temporomandibular joint. There was a certain study conducted in Bangalore in the year 2008 where software engineers were studied. 92 people were included in this study, and you see what happens. They had a prevalence of 82% of neck pain, 75% of them had shoulder pain, and 44% of these people had temporomandibular dysfunction. What they concluded from this study is if a person is sitting in front of the computer for more than 5 hours per day for a period of greater than 5 years, 100% he is definitely getting neck pain, neck dysfunction, shoulder pain, and temporomandibular dysfunction. Now let's talk something about occlusion. This is a very big market. People who argue on occlusion causing temporomandibular joint have a separate market, separate schools of thoughts, and separate training for dentists, so on. It's a very big market and it's very, very, very controversial thing. Now, you as physiotherapists, I feel first you should understand the concept of occlusion. Now, what is occlusion? Occlusion is nothing but when upper and lower teeth meet. The occlusion of upper teeth with the lower teeth is called as occlusion. That is occlusion. When the upper and lower teeth, they collide in a certain way and a certain fashion, that is called as occlusion, right? Majority of us have normal occlusion. Our occlusion can be divided into three major types. No doubt it is called malocclusion because there are little bit of variations. It should not be considered as a disease process. Predominantly in the population, what you see is class 1 malocclusion. What is class 1 malocclusion? The lower jaw is completely encased in between, inside the upper jaw. Always you see that the upper teeth are outside, inner teeth are in, the lower teeth are inside. The lower first molar is in front of the upper first molar. You just remember this, the lower teeth are present inside, the upper teeth are present outside. That is a normal occlusion, class 1 malocclusion. In class 2 malocclusion, what happens is there is a retrognathic mandible. The mandible is little bit behind the normal position. The mandible itself can be behind, or the teeth can be retroclined. It can be either dental or skeletal malocclusion. This is called as class 2. The patient will have a convex profile here. There is something called as class 3 malocclusion, where there is a prognathic mandible. There is a prognathism. The lower jawbone is in the front. You look at the profile of this patient. Now, my dear friends, what I want you to recognize is these malocclusions are the types of occlusal changes where patients seek treatments like braces. The dentist puts braces and does the correction of these things. If the discrepancy is more, they will do a surgical correction. By and large, 80 to 90% of the people, these problems can be corrected with braces. Now, occlusal disharmony means not malocclusion. Don't get confused, because all over the world, there are many people who send their patients for braces for TM joint problems. My dear friends, braces and malocclusion has nothing to do with temporomandibular joint problems. The reason is simple, I will tell you. For this particular malocclusion, you will have to send them for braces, and there is no TM joint problem here, because most of the patients with temporomandibular disorders, they have normal occlusion, class 1 malocclusion. They don't have too much of abnormalities. And second thing is, if you look at the majority of the people with malocclusion, they do not have temporomandibular disorders. People with malocclusion, class 2, class 3 also, they don't have TMDs. And people who are having TMDs, they have normal occlusion. I think it is enough to show that malocclusion, malalignment of teeth, does not cause TMD. Right? There are a group of people who argue that if teeth gets worn out, it is an age-related change. It can be an age-related change. Teeth will start wearing away. It is called attrition. Number one, it can be an age-related change. Number two, it can be because of bruxism. I will come to that. Bruxism is a night grinding habit. So in these individuals, what will happen? There will be a tooth wearing. You can see there is an alteration of the shape of the teeth here. This is called wearing away of tooth structure. Some people argue that if the teeth are worn out, that can cause temporomandibular joint problems. No, it will not happen. I will tell you why. Let us see how much interest has been shown in terms of occlusion and temporomandibular joint over the past 40 years. It is a most controversial topic. There are 2,419 published papers who have related temporomandibular disorders with occlusion, out of which we have 52 randomized controlled trials. My dear friends, the conclusion of these 52 RCTs is the human body accepts and adapts to the occlusal alterations. The explanation is simple. When the person is growing up, when milk teeth are present, the teeth are in a different position. When permanent teeth erupt in the body, the teeth are in a different position. In an adult, the teeth are in a different position. When age changes the shape of the mandible, the maxilla, and the teeth undergo wearing away, it is in a different position. So the body, the masticatory system, has got excellent adaptation capabilities. This cannot result in temporomandibular disorders. So what exactly is occlusal alteration? That we will talk. I think you people have understood that wearing away of teeth structures and malocclusion, malalignment of teeth, will not cause any temporomandibular joint dysfunction. Please understand this. Now, what exactly is occlusal disharmony? Then I have put it as one of the etiological factors. I want your attention here. You are seeing a patient here with normal occlusion. You are seeing there is no space in between the teeth when the patient bites. If a patient is having a decayed tooth, he will go to a dentist for getting a filling done. If a dentist does not do the filling properly and he sees to it that the filling is above the normal height of the tooth, that means there is a high point. The filling is high. When the patient bites, there is a gap in between the teeth. That means only one particular tooth is coming in contact with the other jaw because it is high. This is occlusal disharmony. There is abnormal contact here. Teeth are not touching properly. Only one tooth there will be high. What do we do in this case? We use a bite registration paper and record where exactly it is high. And if you just remove the high point, it will become normal. This high point, if it is not removed, if there are high points in the restorations and dentures, then patient can get temporomandibular dysfunction. This is the meaning of occlusal disharmony. Malaligned teeth will not cause temporomandibular joint dysfunction. Now there is something called as edentullousness. Patients who do not have teeth. What studies have shown? There are few patients who get all their teeth removed, but they don't wear their dentures. They don't go to the dentist for fabrication of dentures. They are called as completely edentulous patients. You can see there are no teeth here. Here, even though there are no teeth, they tend to overclose their mouth. But somehow there will be a functional adaptation. But if some teeth are not present, this is a problematic thing. As I told you, they start chewing on one side, or they start chewing in a fashion which you can't imagine. With whatever teeth are left, they will try and adapt and try eating with the remaining teeth left over. That can cause temporomandibular joint dysfunction. So if there are few teeth missing, we have to send the patient to get an artificial teeth replacement. And I think it is enough to show that what exactly is the role played by occlusion, and we do not think more about this occlusal disharmony. The only thing that you should be worried about is absence of few teeth or recent history of any filling. We need to check whether the filling is properly done or not. Now coming to the most important thing, parafunctional habits. The parafunctional habits are nothing but bruxism. What is bruxism? Bruxism is a patient is clenching his teeth during deep sleep. That is bruxism. What happens in bruxism? Again, it is causing an adverse loading of the joint and the masticatory musculature. That is bruxism. There is something called as day bruxing or day clenching, which most of us do whenever we get tensed. But there are some individuals who keep clenching their teeth without any reason in the daytime. So these are two habits that can result in temporomandibular joint problems, the temporomandibular dysfunction. Bruxism, night clenching their teeth during deep sleep and clenching their teeth during daytime. What does bruxism do? If you just look at this, when the people are bruxing, there is an increase in the muscle activity. And when there is an increase in the muscle activity, there is a changes in the afferents. What I mean by this statement is afferent means the pain carrying nerves. The nociceptive input to the brain changes and there is a bombardment of nucleus caudalis. Now, my dear friends, I think you all should know what is nucleus caudalis. We all are some people who are involved in treating pain. We all have learned about the gate control theory. In gate control theory, what we learn is the gate is substantia gelatinosa of the dorsal root ganglion of the spinal nerve, where pain modulation takes place. Now, for head, neck, and face region, there is something analogous to dorsal root ganglia. The gate is the nucleus caudalis of the trigeminal nerve. So there is a bombardment to the caudalis caused when there is abnormal muscle activity caused by day clenching or clenching their teeth during the night time. That is what is causing pain in bruxism and parafunctional habits. Now this is how it results in temporomandibular joint pain. If you look at the studies, bruxism is very common in temporomandibular disorders. The prevalence of bruxism, no doubt, in general population is about 5%. But if you look at the bruxism prevalence in temporomandibular disorders, it is about 58 to 80%, which is very high. What does it do? It can contribute, it can predispose, it can initiate, or it can perpetuate an existing temporomandibular joint disorder. Now, when dealing with patients with bruxism, you need to remember one particular thing. There are some antipsychotic medicines that can induce bruxism. So if the patient uses a recent history of bruxism, then you just need to take a proper history, and if the patient is on any of these drugs, you'll have to probably ask the psychiatrist to change this particular medicine. That is about bruxism. Psychological factors, very, very, very important. Majority of the individuals suffering from TMD, they have psychological factor, psychological imbalance. Psychological imbalance, it can be depression, it can be anxiety, it can be somatization disorders, whatever. Now, how does this psychological imbalance cause TMD? That is what you need to understand, my friends. There are three reasons for this. Number one, whenever the patient is having a psychological disturbance, it can be a mood disorder, anxiety, depression, somatization, whatever, generally an individual tends to clench his teeth when he gets tensed, is it not? So when he is clenching his teeth, again he is doing declenching. Abnormal adverse loading of the musculature and joints is happening when a person is getting tensed. Number one. Number two, when a person is getting tensed or stressed, overstressed, two hormones are released in the body, adrenaline and steroid hormones. Now, what does this steroid hormone do to the musculature? It depletes the glycogen from the muscle. A muscle which is depleted of glycogen undergoes fatigability very, very easily. It is vulnerable for inflammation. Over and above that, patient is clenching. That is what causes pain. Third reason is hormonal imbalance. There is a hormonal imbalance. That is what I have explained. And last but not the least, there is a central facilitation of pain in psychological patients or psychiatric patients. What is the meaning of central facilitation? I will give you a small example for you to understand. Now let us assume two individuals. One individual is very, very happy. Another individual is very sad. What I do? I slap them with the same hand, with the same power. I am slapping two individuals. I am repeating it again. One individual is very happy person. One individual is extremely sad person. Now, if you look at the pain perception in these two individuals, the person who is very, very sad probably perceives more pain. A person who is very happy probably perceives very less pain. Why does this happen? This happens because there is a central facilitation. Emotional instability plays an important role in perception of the pain in higher centers, especially the cerebral cortex. And it has got a major influence on the gate, the nucleus caudalis. That is why psychological factors are very, very important. And that is how it results in temporomandibular joint disorders. It can be myogenous or arthrogenous or whatever. Comorbidities. This is a very, very important thing that you all should know. Now, temporomandibular joint disorders are one group of disorders. Firstly, it is multifactorial. It is very important for us to diagnose what exactly is the problem, what is the etiological factor. Over and above that, what studies have shown and what we have been seeing in our clinical practices, there are a lot of comorbidities associated with this TM dysfunction. What are the normal comorbidities? Most of these patients have headaches. They have fibromyalgia syndrome, which you people are masters in treating. Neck and cervical dysfunction. Again, you people are masters in treating this. So if the main thing that I'm trying to tell you is why comorbidities are important is, I'll give you an example. If the patient is having a temporomandibular disorder along with a neck dysfunction, if you don't treat the neck dysfunction, the temporomandibular joint pain is not going to disappear. Both the disorders have to be treated concurrently. Otherwise, the patients are not going to respond. Same thing applies to headache. I can give you an example. If the patient is suffering from migraine as well as a temporomandibular joint problem, you'll have to make sure that he is taking a prophylaxis for migraine, something like propranolol or amitriptyline or sumatriptans or whatever the physician prescribes. Concurrently, you should be treating temporomandibular joint disorder. Then only the pain will disappear. Interestingly, of late in the past 10 years, people have started that postulating that even migraine is caused because of temporomandibular joint. I don't know how far it is true, but this is what the studies state. You can look at these studies here. Myogenous temporomandibular disorder is comorbid with headaches. 300 patients were screened, and what they have concluded is the temporomandibular disorder is more likely to have migraine. That means patients who are suffering from TM joint disorders, they are more likely to have migraine. In terms of the patients that we are treating, I would say at least 4 out of 10, they have comorbidities. Why this happens, the explanation or the hypothesis that they have given is again the central facilitation. Central facilitation of the nociceptive input. Nociceptive input means pain carrying sensations from the periphery to the brain. That is nociceptive input. Now, with this, we complete the etiology of the temporomandibular disorders. Let's see what are the clinical features. Most prevalent between 20 to 40 years of age, frequently affects women. Many studies have been done to check this, and they have given the questionnaires And some people, what they feel is they give the reason that women have a lower perception of control and they have a greater perception of distress. That is why they get into TMDs. There is a school of thought that estrogens play a very, very important role in potentiating inflammation, and they mediate the cytokines which are responsible for causation of inflammation. Let's not get into that. I just want you to know that there is a hypothesis that estrogen also plays an important role in causation of inflammation in the temporomandibular joint disorders. That probably may be another cause why females are more affected than males. Secondly, the areas, this is very, very interesting. Pain that patients can present with is unilateral or bilateral. Please remember, it can be always in and around ears, in the temporomandibular joint, anywhere in the masticatory musculature. Pain can be in the temporalis area, digastric area, masseter area, medial pterygoid area, and it can be on the face, it can be on the sinus, it can be on the temples, it can be on the neck, one or both sides. Most of the times it is accompanied by deviation of the jaw, and there will be sounds. The clicking sound, either patient will complain of clicking sound, or when you are examining or auscultating, you can recognize a clicking sound. One important thing that you will have to remember here is most of the patients, especially Indians, what they have is early morning when they wake up, patients who are suffering, especially chronic TMD patients, when they wake up, they have discomfort. First time when they try to open their mouth, they have too much of discomfort in the preauricular region, in the joints, as well as musculature. This is an important point that you can recognize when you are seeing the patients. Now, apart from these general clinical features, for the ease of understanding and ease of treating, we can divide the TMDs into myogynous and arthrogenous, as I told you initially. In myogynous TMD, let's look at this. What is myofascial pain? It's a regional dull pain. What you see is localized tenderness in firm bands of muscle or fascia. There is something called as myositis. In myositis, what happens is there is an increased pain with mandibular movement. When the patient tries to move the mandible, there is pain and it is localized and there is acute pain. In protective muscle splinting, there is severe pain with function but not at rest. There is a limited range of motion when the patient is not trying to open the mouth too much, because when he opens, he knows that it is going to cause pain. Secondly, we'll have to see the arthrogenous component. There are many components of arthrogenous TMDs. I'm not going to discuss everything now. Two main things I'm going to tell: disc displacement without reduction, disc displacement with reduction. What you people need to realize and recognize is myogynous component can be present in arthrogenous component as well. If a patient is suffering from disc displacement with reduction, it does not mean that these patients will not have any muscle generated problems. All the patients can have muscle generated problems. The muscular pathology is common for myogynous as well as arthrogenous patients. Some or the other problem with the muscular component will be associated with arthrogenous TMD also. That is why you have to know what is arthrogenous TMD. Now, please don't go to these details. I'll show you videos with which you can very beautifully understand what is disc displacement. First of all, what is disc displacement? Dr. Trupti?
Yes, sir.
Dr. Trupti?
Yes, sir. We can
Dr.
see.
Trupti?
Yes, sir. Sir, can you hear me?
Can you hear me?
Yeah, I can hear you.
Dr. Trupti?
Sir, I can hear you.
Well, what exactly is displacement? Now, this is a cadaveric picture. What you are seeing here, the video is taken from a section of a cadaver, an autopsy specimen. You can see the condyle here, the part of the mandible. This is the glenoid fossa, the temporal bone, and this is the disc. Okay, the disc is positioned in between both the bones. This is a normal joint. What you need to see here is, Dr. Trupti, can you hear me?
Yes, I can hear you.
Dr. Trupti?
Sir, I can hear you. I can hear.
Yeah. There is no voice coming from the video, right? You can only listen to what I am speaking.
Yes, yes. Only your audio is audible, sir.
Unmute yourself, please.
Sir, I have unmuted myself.
Yeah.
Can you? Yeah. The video audio
Hello?
is. Sir, can you hear me?
Hello?
Hello, sir. Can you hear me?
Yeah, I can hear you now. See,
Yeah.
when I'm playing the video, you can only listen to my voice, right?
Yes, sir.
Okay. So you are seeing a normal joint here. When the joint is moving, you can beautifully see that the disc is also moving along with the joint. First, the joint performs a rotational movement and then a translation movement. You can see that the disc is going all along with the condyle. When the patient is completely opening the mouth, when the patient is trying to close the mouth, now again the disc is in its normal position. This is a normal joint. This is a normal joint. Now, what exactly is disc displacement? You can see the position of the disc here. Normal disc was supposed to be in this place. It has displaced in the anterior direction. This is called anterior disc displacement. In disc displacement with reduction, what happens? Let us see the video and understand. See, patient is trying to open the mouth. The disc is getting pulled. I will show this. Let us see the video and then understand. That will be better. Yeah, this is anterior disc displacement with reduction. Yeah, what you can see is the disc is here. It is anteriorly displaced. This is the condyle. This is the condyle and this is the glenoid fossa. When the patient is trying to rotate the condyle, there is no change happening. But when the patient is trying to open full, during the translatory movement, there is a kind of disturbance. The disc is getting stuck in between and it is getting pulled over. Suddenly there is a pulling. You can watch this. See, when the translatory movement starts, it suddenly gets pulled and then it goes back. Again, there is a reciprocal thing. Same position, it is getting pulled back. It is this pulling over that is heard as a clicking sound when you palpate the temporomandibular joint. Here, why it is called with reduction is, there is a reduction in the disc and the patient is able to open his mouth completely. This happens in disc displacement with reduction. So you can see it again. One particular point, it gets pulled off. That pulling sound is nothing but the click that we hear. And again, when the patient is closing it back, same area, there is a click again, reciprocal click. This is what is called as a reciprocal click. This is what happens in disc displacement with reduction. In disc displacement without reduction, what happens is the displacement is in such a way that it does not allow the patient to open the mouth to the fullest of its extent. Let's see the video. One second. Yes, this is the disc, completely displaced to the anterior region. Look at the position of the disc where it is. This is the condyle, this is the glenoid fossa. Only a small fiber of disc is present in between the two bony structures. Now, when the patient is trying to open, he can only open the mouth partially. After that, there is a lock. The disc is not allowing the patient to open the mouth completely. You can see there is a lock here. You can see there is a lock here. So this is disc displacement without reduction. The mandible is not getting reduced. There is a lock. There is limitation of mouth opening. There is limitation of mouth opening. Now, my dear friends, what we need to recognize here is two distinguishing features between disc displacement with reduction, disc displacement without reduction. Now, in both the conditions, what we see is when the patient is trying to open the mouth, because of the disc displacement, he will have a deviation in his mouth opening. If the disc is anteriorly displaced and it is getting reduced, if it is with reduction, what happens is the mandible deviates while opening and comes back to the midline on maximum opening. And comes back to the midline with maximum opening. Whereas in disc displacement without reduction, patient is not able to open the mouth completely and it is getting deflected. You need to understand the difference between deviation and deflection. In deviation, even though the mandible is deviating while opening the mouth, it comes back to the midline. When you're examining the patient, you can notice this. But whereas in this particular thing, there is only a deflection. There is a deflection of the jawbone and there is no deviation. This is the difference between disc displacement with reduction and without reduction. And the clinical features are also same. Pain, etc. will be there as I have described earlier. But this is what you can see. You can listen to the click. There is a reciprocal click in disc displacement with reduction. When it is without reduction, there is limited mouth opening and there is deflection of the jawbone. There are some newer symptoms reported in temporomandibular disorders. There is a fluid sensation in the ear, stuffed cotton sensation in the ear. People have also described loud noise sensitivity in temporomandibular disorders. And a significant number of patients also complain of tinnitus. Now, coming to the clinical examination, you need to observe the gait, the balance, of course, to see whether the patient is having any vertigo or any other CNS disorders. Most important, the quality of the communication that will enable us to decide whether the patient is psychologically affected. Most important thing, you have to look at the measurements. You'll have to see how much patient is able to protrude and retrude the jaw and perform the lateral movements, and how much mouth opening is present. An average Indian individual has got a mouth opening of roughly around 35 to 45 millimeters, and the lateral movements ranges from about 5 to 8 millimeters, which is the normal range. If that range is disturbed, then you'll have to suspect TM joint problems. You will have to stand in front of the patient and ask the patient to slowly open the mouth. You can feel the joint in the preauricular region. Hold two index fingers, ask the patient to open and close the mouth. Observe the jaw movements. See whether there is any decrease in the mouth opening. Observe whether there is any clicking sound, and see whether there is any deviation or deflection in the mouth opening. Next, you start palpating the masticatory muscles. This is the temporalis near the temple bone. Remember, the temporalis is getting inserted in the coronoid process. One way of palpating the temporalis is here. The second thing what you need to do is, inside the mouth, adjacent to the teeth, put your index finger and go to the posterior region till you reach the coronoid. That is where you palpate the temporalis that is inserted into the coronoid process. You have to palpate the masseter. You have to palpate the digastric muscles. For lateral pterygoid, you'll have to palpate the muscle in action. If you have to activate the lateral pterygoid, you'll have to ask the patient to open the mouth. You restrict the opening. Ask the patient to protrude the mouth. Ask the patient to bite. By this, if the patient is having pain, that means the lateral pterygoid is under dysfunction. This is also an example where if you perform the lateral protrusive movements, the lateral pterygoid on the opposite side is responsible for this movement. So that is in problem. Cervical spine assessment, you people are the masters. I need not talk about this. Examination of neck muscles also you do. And oral cavity needs to be checked if there are any problems. If there are wear facets, you probably have to take history of bruxism. Then occlusion analysis has to be made. Whether there is any recent history of filling, you'll have to find out. Then psychological evaluation is also important. If you are not able to do the psychological evaluation, refer to a clinical psychologist or psychiatrist. You can also take the help of questionnaires. Why I have put this questionnaire here is, it is a questionnaire which is very simple, containing 28 questions that will enable you to decide whether the patient is psychologically affected or not. And this is available in around 16 Indian languages. Now coming to investigations. Now let me tell you, most of the patients, when they are referred, they come with a full mouth X-ray and they say, we have taken OPG, we have taken full mouth X-ray. My dear friends, most of the TMDs, the arthrogenous and myogenous components, what we see is the bones are the last to involve. You will not see any condylar changes in the early stages. Condylar changes are seen only as a late stage. So the gold standard for temporomandibular disorders are MRI. No doubt you'll have to take an X-ray. Why you have to take an X-ray is, there is one important point here. At an early stage, when the patient is having only muscular symptoms, if you see there is a flattening or erosion of the bones, that means you have to suspect some other arthritides like rheumatoid arthritis, and you will have to send the patient for serological investigations for those diseases. If it is a normal myofascial pain or normal arthrogenous TMD, MRI is the gold standard, and what you need to know is getting the patient an MRI done has not proven to be a valuable test for directing treatment, predicting treatment outcome, and determining long-term prognosis. Then when should you do the MRI? You will have to do the MRI when the patient is not responding to conventional treatment, when patient gives a history of chronic TMD, and where is a disc displacement without reduction. Remember one thing, if you want to send a patient for an MRI, you should send them to a center where 3T MRI is done. 3T refers to the capacity of the magnet used in the MRI. 3T is 3 Tesla. More is the Tesla of the MRI machine, more is the spatial resolution of the image that we see. The images of the temporomandibular joint must be very, very clear. They should have a good resolution for us to interpret the images. So that kind of a resolution you will get only for machines which are 3T and above. This is how a 3D MRI image looks like. What's the scenario in Bangalore? When we are treating temporomandibular joint disorders, what are we seeing? Predominant patients are software engineers, techies, people working on their computers. Most of them have stress, and some people are bruxers, and they have a craniocervical problem and cervical muscle dysfunction. The commonest muscle that has got maximum tenderness in this area of India is the temporalis. Temporalis is not at the temporal region, temporalis at the coronoid. When you palpate all the muscles, this is one point where people exhibit maximum tenderness, especially in southern parts of India and Bangalore. That is our observation. And whenever we send the patient for an imaging, the most common findings that we get is either it is no abnormality detected or it is disc displacement with or without reduction. Now, how do we approach these patients? Number one, very, very important, history. This is the key for the diagnosis. Most important, you will have to ask about the pain and the comorbidities. Here itself, you will have to broaden and you will have to try and think over the comorbidities and see what you can do about that. So the history of comorbidities should not be missed at all. Any history of recent dental fillings, very, very important point. Number three, whether the patient is bruxing or not. My dear friends, the patient will not know whether he is bruxing. You will have to ask their family members. They will know because they are in deep sleep. They are doing this clenching only when they are sleeping. So their family members are to be asked whether they are bruxing or not. Chewing pattern, very, very important point I told in Indians, whether they are chewing both the sides or one side to prevent the adverse loading. That has to be asked. And if there is any psychiatric illness, you will have to recognize that. Right? Second thing, there are a lot of perpetuating factors. If the patient is having poor posture, skeletal asymmetry, you need to take care of that. What we have found is patients with allergies, patients with thyroid disease, and patients with diabetes mellitus. They are not giving optimum response for the treatment, and they are taking some time to get some time to get the treatment. I mean, the time taken for them to respond for our treatment is more, especially if their thyroids and diabetes is not under control. And psychological disturbances also. If you don't address them, the response to the treatment is not good or is not as expected by us. So these perpetuating factors are to be kept in mind when you are approaching a patient. Finally, when the patient comes with a complaint of TMD, you do an examination and diagnosis. If you come at a diagnosis of myofascial pain, what you need to do is give them pharmacotherapy for decreasing the inflammation and give them splints. What is a splint? Splint is nothing but something like a mouth guard. The sports guard that people wear while doing martial arts and boxing. A splint is similar to that. I will show you the pictures. You'll have to give the splints and also refer the patient to physiotherapy. Physiotherapy plays an important role in myofascial pain because it decreases the muscle activity and maintains the mobility of the muscles. On the other hand, if the diagnosis is internal derangement, that is the disc displacements, then you'll have to, of course, give pharmacotherapy for decreasing intra-articular inflammation. Again, give them the splint and again send them to physiotherapy because of decreasing the inflammation and maintaining the mobility. What you people should recognize is physiotherapy is important in both the areas. You people can play a major role in treating these disorders. Literature, if everything falls, literature says it is surgical treatment. In my experience in the last 20 years, I have not sent a single patient for a surgical management. Literature says, or it gives a lot of NSAIDs to be prescribed. My favorite is paracetamol, best drug, anti-inflammatory drug, not only antipyretic. 650 milligrams TID for 7 to 10 days will definitely bring down the inflammation. This is the best drug to be given. Muscle relaxants are very, very important in myogenic TMD. My favorite is tizanidine or diazepam. If the patients are severe patients, I give them diazepam straight away. If the symptoms are mild to moderate, we treat them with tizanidine. Both are centrally acting muscle relaxants. Of course, other muscle relaxants can also be used. Most important while managing a patient with TMD, soft diet. You should not allow too much of load on the joint and the muscles. rest to the joint, heat and cold therapy. If fillings are not properly done, that needs to be restored. Paracetamol. Most important in chronic TMDs, there is something called as adjuvant analgesics. TCA stands for tricyclic antidepressants. My dear friends, tricyclic antidepressants are not given here for treating depression. I spoke about the central facilitation. That central facilitation gets corrected by using tricyclic antidepressants. So it is actually a painkiller, an adjuvant analgesic in chronic TMD. Listen to me. Amitriptyline as a tricyclic antidepressant works wonders for chronic TMD. Physiotherapy. These many techniques are used in treating TM joint. I think the next speaker is going to highlight about these things. Passive stretch, spray and stretch, transcutaneous electrical nerve stimulation, therapeutic ultrasound, dry needling, low-level laser therapy, iontophoresis, so on and so forth, neck joint mobilization, functional manipulation of the joints. In my practice, the most commonest physiotherapeutic modes that I practice is ultrasound, therapeutic ultrasound, and dry needling. We have a very good rapport with the physiotherapy department in Manipal Hospital. There is one Mrs. Mahalakshmi who co-works with me and manages my patients in an exemplary manner. Whether it comes to dry needling or ultrasound, the results are very good and patients are very, very happy. Let me tell you. Adjuvant analgesics, as I mentioned, the alternative choice, if the patient is having dryness or any cardiac problem, you can switch on to the adjacent, the other adjuvant analgesics, which belong to the same group, the tricyclic antidepressants. Whenever you are sending the patients home after giving the treatment, one thing that you'll have to remember, there is something called as physiological rest position. I want your attention here. Now, the complexity of the masticatory musculature is such that if a person bites, if the teeth occlude, some muscles are getting contracted. On the contrary, if the patient opens the mouth a little bit, some muscles are getting contracted. So if you want the patient to get maximum rest for his muscles, the teeth have to be maintained such that there is a gap of 4 to 5 millimeters in between upper and lower teeth when the patient is at rest. This is called as physiological rest position. I am repeating it. The teeth should be 4 to 5 millimeters apart and the lips to be closed like this. That is called physiological rest position that enables rest for the masticatory musculature. Along with that, a neutral head posture. How do we achieve this? In the night time, this is achieved by giving splints. In the daytime, a neutral head posture and tongue to be kept in floor of the mouth and the mouth is to be closed. By this, we can achieve a physiological rest position. Now coming to splints, there are three kinds of splints that we use: hard splint, soft splint, and dual laminated splints. Let us not spend more time about this. This is how a soft splint looks. It is flexible. A hard splint looks like this. This is how the patient wears it. Please remember, hard splint is always better. Don't opt for a soft splint. There are various designs of splints. I'm not going to talk about that. There is only one splint that I want you people to know: anterior repositioning splint, or an anterior repositioning appliance. What do we do here? You can see this image here. The disc is displaced in the anterior direction. There is an anteriorly displaced disc. When the patient bites, he bites like this. I told you in normal occlusion, upper teeth are outside, lower teeth are inside. We prepare the appliance in such a way that when the patient bites, he bites like this. That means the lower jaw, the mandible is advanced, and then patient is allowed to bite when he is wearing the splint. What does this do? This facilitates the disc to go back to its place. It is as good as functionally manipulating the jawbone. There are some disadvantages with functional manipulation. Instead of that, you can use this particular splint in treating disc displacements. Now, how does the splint work? It alters the occlusal condition. It changes the condylar position. There is a cognitive awareness to the patient. It gives a placebo effect, and it decreases the motor activity. There is only one contraindication for these splints. It cannot be given in patients suffering from sleep apnea. So splints can be given in patients who are bruxers, patients having arthrogenous disorders, and chronic myogenic temporomandibular joint patients. Now, majority of the studies say splints works wonders for TMDs. Studies also say that physiotherapeutic modalities have a similar success rates when compared to splint. So in my practice, what we do, and what I suggest you people also, if there are no confounding factors like psychiatric problems and bruxism, I think you should start the patient with anti-inflammatories and send them to physiotherapy. If the patient is not responding, then you can switch on to splints, a stepped care model. Start with analgesics and start with anti-inflammatory, home care instructions, rest to the joint, then physiotherapy, and then the splints. This is the best way of management of the patient as far as my knowledge goes. Of course, there are many other modalities. As I told, it is very difficult to cover such a vast topic in such a small time. Behavioral intervention, as I told, very, very important. Now, one thing that I would like to caution is there are some people who do irreversible treatments, aggressive treatments, which is not required. This TMD is temporary and self-limiting. I told you only 3% of the patients will go into chronicity and require aggressive treatments. Finally, what we need to recognize is an oral physician, oral medicine specialist, or a dentist cannot solely treat this condition. We need the physiotherapist, we need the psychiatrist, and we need the orthopedician. All of us has to co-work together to treat this particular disease. To end, I would like to say proper diagnosis is very, very important. You'll have to identify the cause. It is very, very complex to treat. Even though it is like this, most patients will achieve significant reduction. The success rate is 70 to 90% of a non-surgical treatment. If no significant improvement is there, then only we should necessitate surgical treatment. And as far as my knowledge goes as a clinician, we should always opt for a least invasive procedure with the maximum potential. Finally, I want you people to carry home 5 points. Point number 1, temporomandibular disorders are very common. Physiotherapy plays a very, very important role in managing this particular disease. Conservative management gives success most of the times. My request to fellow physiotherapists is try to collaborate and interact with the fellow dentists. Most of the dentists, they do not know that physiotherapists are experts in treating this disease. They can handle the problems associated with the musculature. If you don't go and approach them, you don't tell them about the expertise, they will not come and interact with you. They will not come and interact because there is a chance that they will not know that we can send this patient to physiotherapists. So at least for the physiotherapists who are working in an institution or who are working in corporate hospitals, you can go and talk to your fellow dentists. You can interact with them so that the patients will get benefited and the patients can be managed in a holistic manner. By this, I will end my talk today. Thank you very much for patient listening, and I have taken little more time. I apologize for that. Thank you so much. My acknowledgements to my teachers.
Thank you so much, sir. It was indeed a very nice presentation. We are enlightened with knowledge about TM joints, sir. There are some questions which have come. I shall highlight them, sir.
Yeah, please.
Yeah. So there is one question saying posture will affect TM dysfunction.
One second, madam. One second. Yeah, what is the question?
How posture shall affect TM joint dysfunction?
Well, one second. I showed you that picture.
Yes.
When there is a postural imbalance, the physiological equilibrium between the muscular groups and the muscle centers are lost, which will result in fatigue and spasm of the muscles, and it causes pain. Most commonly, the forward head posture and neck muscle dysfunction are the ones that can cause temporomandibular joint problems.
Okay. So the next question for you is, which splint is used to achieve the physiological rest position?
There is something called as a night guard, right? It's a splint where the particular, there is a splint called night guard. If you ask a dental lab and ask them to fabricate just a night guard that has got minimal thickness, uniform thickness, and a hard splint that will protect the teeth from getting damaged and protect the masticatory musculature from getting an adverse loading. So that kind of a splint is more than sufficient for majority of the patients. Hard splint or hard night guard, you can say.
Okay, sir. So the next question is, you had specified something about filling. So suppose the filling is not good, you need to do the filling. So how does it add to the TM joint dysfunction?
Yeah. See, where I showed you how the teeth occlude. When the patient bites, all the teeth, they intercuspate like this, right? So when a filling is not done properly, if the filling has got a high point, that intercuspation is lost. When that intercuspation is lost, patient is not able to bite in the proper manner. When patient is not biting in proper manner, adverse loading of the musculature and the joint happens. If this continues to happen for a period of 3 to 4 days, he will not only get pain in the tooth, he will also get muscular problems in the temporomandibular system. This is how an abnormal filling can result into temporomandibular joint problem.
Okay.
Sir, thank you very much, sir. Dr. Srinivas, sir. Really,
No mention, sir. My pleasure.
Really, it is a very nice presentation. In fact, we are overwhelmed with your the enlightenment that you have given to us. There is a scope of very much scope of physiotherapists to join hands with a dentist and work in the management of TM joint dysfunction. And really, we are thinking of, as an output of this conference, we will be requesting our dental college dean and the team, and we will be joining with our services with them as an output of this conference.
I'll be very happy, sir.
Yeah. Thank you very much, sir. So I think we are talking the phone. I'm Dr. Varadarajalu, dean of the college.
Oh, yes, sir. Yes.
Yes, sir. Thank you very much, sir.
No mention, sir.
Yes, Trupti madam. Over to Trupti madam.
Thank you, sir. Thank you for your presentation, sir, and accepting the invitation.
My pleasure, Dr. Trupti. Thank you.
Now we shall begin with the next session by Dr. Deepak Anand. Dr. Sandeep Shinde.
Yes.
Over to Sandeep Shinde.
Yes, our next speaker is Dr. Deepak Anand. He is one of the eminent and experienced person in the field of physiotherapy. He has completed his PhD in 2017 and he is having total 18 years of teaching and clinical experience. Now he will enlighten about the physiotherapy management for TM joint dysfunction. So I request Dr. Deepak sir to start with the session.
Hello, Dr. Trupti, can you hear me?
Yes, you are audible.
Okay. First, I would like to thank Dr. Srinivas if he is there before he leave. I just want to thank him because he just in very brief, he covered so many conditions in dental TMJ joint as well as dental, which can be treated by the physiotherapist. And I also like his way of presentation, wherein he described so many evidences. He has given so many evidences for his information, and his key message about working together, that is team, in rehabilitation of this TMJ joint. Thank you, Dr. Srinivas. Now, before I start with my presentation, I would like to thank KIMS University Karad, especially my best friend and my mentor, Dr. G. Varadarajalu sir, Principal KIMS COPT Karad, for inviting me as a speaker on this virtual International Physiotherapy Conference 2020. I also would like to thank my management, Dr. Vittal Rao Vike Patil Foundation, Ahmednagar, and my principal, Dr. Shyam Ganvir sir, for encouraging and supporting me in every professional act performed by me. Thank you very much, sir. And with this, I'll just start with my presentation. Dr. Trupti, can you see the slide? Is it visible to you?
Yes, it is visible.
Okay. So before I begin with this topic, actually, Dr. Vadrajulu sir called me 1 week back and he told me to speak on this topic. And immediately, without any hesitation, I accepted this topic on DMJ dysfunction. Because I'll just tell you the reason. This presentation I would like to dedicate to my two best friends. One friend who explained me without saying any single word about his unbearable TMJ dysfunction during and post-treatment of deadly H&M tumor. Now he is all right and he has recovered from this problem, but still he is suffering with the TMJ dysfunction. That is one of the reasons why I accepted this topic for my presentation. And the second friend who always taught me that old is not always the gold and you should always believe in recent evidences. So in this lecture, I'm just going to talk on what are the recent evidences to manage this TMJ dysfunction. And at some points, I'm going to give some recent references also for my treatment. So whatever I'm going to present in my lecture is not from the old references or old books. It is everything based on the recent evidences. So the topic for my today's presentation is TMJ dysfunction, the post-operative physiotherapy care. But it is not always post-operative the physiotherapy works, but any patient who comes with the TMJ dysfunction even pre-op or immediately after some dental problems or some muscular problems around the jaw can be very well and successfully treated by physiotherapists as told by Dr. Srinivas in his lecture. So the objectives for today's lecture are what are the goals of physiotherapy. So I'm going to tell in short what are the components of physiotherapy evaluation, because whole treatment in physiotherapy management is based on the evaluation part. Whatever positive things we get and whatever investigations we see in our evaluation, we plan the treatment for those patients based on the recent evidences. And the next I'm going to talk in detail on what are the evidences of evidence-based physiotherapy for these temporomandibular dysfunctions. And as my fellow dental friend told, see, these TMJ dysfunctions can be managed in team. It is not a work of single person, and we should work in a team. What happens in foreign countries, like the 2-3 professionals, they come together and they plan for the treatment, which is lacking in India. So as his suggestion, we should talk to dentists and we should convince them for referring these patients, and we should show our skills in managing these temporomandibular dysfunctions. So the role of physiotherapist post-operatively or any dysfunction is, first thing is we should control the pain. Okay, so pain is the first goal of physiotherapist. Then to improve the range of motion, that is a range of motion at the temporomandibular joint. Then to improve the strength of the muscles which are working around the TM joint. Then to improve the extensibility of these muscles, because you know after any TM joint problem, even after any simple surgery of the dental, these muscles around the TM joint, they go in shortening, or the extensibility of these muscles reduces, and which contributes to the lesser range of motion at the joint. And postural education, as the sir said, Srinivas sir said, the posture is main factor which leads to the problems of TMJ joint. And I'll just continue with this postural problem in a few slides. I'm going to tell you how these postural problems can directly affect your TMJ joint unknowingly. Many times it is not known also, and when we land up with some problems or when the symptom starts, and then we come to know that our posture was wrong. So as a therapist, we should always check for these postural problems which can be a factor in TMJ dysfunction. Now, the components of physiotherapy evaluation, I'll just highlight few components, what we do when the patient comes to a therapist, when the patient comes from dentist or from the oncologist or from or some self-referrals. So we first assess the posture. Posture is the important factor. As I said, I'll just show you in the slides how the posture affects. So we must, as a therapist, there are some important postures we must check, whether the first posture, poor posture, which can directly affect your temporomandibular joint, is the forward head posture. Okay, so that is one of the thing which can affect your TM joint. Second is rounded shoulders, then kyphotic posture. So all these postures are affecting your TM joint function or biomechanics. Then a measurement of neck range of motion. Again, see, neck range of motion is also responsible for TM joint function, because if there is shortening of the muscles around the neck, which are directly affecting your TM joint, you must check for neck range of motion. Then measurement, you must check the range of motion at the TM joint as shown in the figure. You can check for the opening of the mouth. It should be around 50 millimeters or 5 centimeters in normal person. It varies from person to person many times, but it should be around 50 millimeters. So there are so many factors, like for example trismus, or the spasm in the muscles of mastications, or intra-articular derailments, which can lead to the restricted range of motion at the TM joint. So the next will be palpation of the structures around the joint. So you should palpate mainly the muscles. You should palpate the joint directly. You should palpate for the bones around the TM joint, for the tenderness, muscles for the trigger point or spasm in the particular muscles, because they are responsible for restriction and the dysfunction at the joint. Then measurement of the strength of the jaw and postural muscles. You all know, because I can see the majority of physiotherapists who have joined this conference, you know that the strength is the important component for any joint, and it maintains the stability in that joint, and it is also responsible for the normal working of that particular joint. If the muscles are weak, the pathomechanics or the normal biomechanics alters, and it can lead to the pain or alteration in the range of motion or alteration in the posture of the head and neck. So all these components you should assess as soon as you get a patient at your clinic or your hospital, and based on this assessment you can go for the treatment of that particular patient. Nowadays, we as a therapist, we use ICF pattern for assessment. ICF is the important component of physiotherapist assessment, because it will tell you specifically which structural impairment is there, which functional impairment is there, and you can plan the treatment based on that assessment too. Now, the first, as I told you, the goal is pain relief. So based on the evidences, there are these main four modalities which are mentioned in almost all the systemic reviews, or as well as randomized control trials. And I have arranged these modalities according to the level of evidences. So on the top is TENS. So transcutaneous electrical nerve stimulation is widely used all over the world for treatment of pain in the TMJ joint. And the TENS is effective not only in the chronic cases but even in the acute cases, and depending on what kind of pain is present, we can choose the type of TENS, and the placement of these electrodes will be directly on the TM joint. It can be given bilaterally, because you must have read TM joint problems are symmetrical in majority of cases, so we can go for TENS without any danger. Means TENS, we can give it for long duration also, like 8 to 10 hours or 24 hours too, and it has a very good effect on relieving pain. As you know, it works on pain gate mechanism. Second is biofeedback. So biofeedback has also proved his effectiveness. Biofeedback, mainly it is helpful when the muscles of mastication, they are in spasm, and for relaxation purpose we can go for biofeedback. By placing the electrodes on that particular muscle, you can just help out the patient to relax those muscles. Then low level laser therapy, you can see in the third photograph down in the corner. The laser therapy, it is effective if there is any derangement in the TM joint which is causing the pain. Laser not only helps to relieve the pain but also helps in healing the structures which are present inside the joint, also around the joint. Then the fourth one is ultrasound, though the evidence is poor for the ultrasound, but in some cases, ultrasound helps in regaining the range of motion by helping to break down the adhesions, as well as to help in reducing pain and swelling around the joint. So the low frequency ultrasounds, they are very effective in treating the TM joint problems. Now, this is the modality which has the evidence, and nowadays so much work is going on not only in India but in US, UK, and Canada. There are so many articles written on the extracorporeal shockwave therapy. See, extracorporeal shockwave therapy, it is almost similar to the ultrasound because it generates the waves, but there are certain differences related to current and frequencies. This modality actually works on the biological modulation inside the tissue. That means it causes new vascularization, that is formation of new vessels, and release of angiogenetic factors. And all these factors, they are responsible for reducing the inflammation. So you all know, in inflammation, like in temporomandibular joint dysfunction, these are the inflammatory factors like cytokines, IL-1, IL-6, and TNF, which are involved in inflammation of the synovium, then destruction of the articular cartilage, then chondrocyte destruction, and these all the things will lead to the pain, then restriction of range of motion at the TM joint. This extracorporeal shockwave diathermy, by working on all these inflammatory products, it reduces the inflammation, causes the healing of the articular cartilage, and reduces the depth of the chondrocytes, thereby causing the regaining the range of motion, pain, and healing of the intra-articular. So extracorporeal shockwave therapy also, there are good evidences nowadays, and many systemic reviews are also coming up showing the excellent evidence. Now, if you can see this cartoon, that's odd. My jaw suddenly feels better. You can see on the back side there are some needles inserted. So this is also one of the modality now getting very popular, and you as a physios, you can see in India too, there are so many people who are practicing trigger point dry needling. Now you know that in TMJ joint, the majority of patient, they comes with trigger points because of abnormal working of the muscles of the mastication. There are trigger points which develops on those particular muscles, and they continuously cause the pain. So there are certain articles which are there which shows the effect of this dry needling on the trigger point. Okay, even in the US, they have accepted this modality because it has a good evidence. And Dr. Jay Shah at NIH, he told in his article that dry needling causes favorable biochemical changes which assist in reducing pain. It also helps in reducing the abnormal EMG activity. As I told, the muscles of mastication, they remains in the spasm and contracted state when your TM joint is affected. So when this dry needling is applied on these muscles, particular muscles, they reduces the activity of that muscle, causing relaxation of the muscles. So many researchers, as I told, 70% of temporomandibular joint cases, there is strong myofascial or muscle component, and this dry needling can be helpful in those patients. Okay. Then the next is after electrotherapy modalities, there are exercises and manual therapy which can help in improving the coordination, muscular coordination. They can help in relaxing the tense muscles. They will help in increasing the especially manual therapy, stretching exercises and active exercises of the mandible TM joint. They can help in regaining the range, and these exercises will be helpful in increasing the muscular strength, which is the force generating capacity required for opening, closing, and all the side to side movement of the TM joint. So whatever exercises I am going to show you now, they are all evidence-based exercises. The first thing is manual therapy. So manual therapy has a very strong evidence for TM joint, and you must have experience also, and you must have treated patient with this. So in manual therapy, the primary goals are to restore the movement, the normal biomechanics of the joint, improve the function and reduce the pain. And you know the manual therapy, it has a physiological effect through the pain gate mechanism, and as well as it has a mechanical effect on the connective tissues around the joint. And out of all manual therapy techniques, the Maitland joint mobilization technique is on the top in evidences. So in manual therapy, first we find out which glides of the TM joint they are affected, and based on that, we can just apply those glide like inferior, anterior glide, posterior glide, and all these glides either they can be given from outside, inside. You can see in the photographs, it is not the time is not sufficient to demonstrate all the glides, but these glides are given based on your assessment, how much is the opening present and which accessory movement of the TM joint is affected. And you know, there are so many evidences they talk about the effectiveness of this glide, like in cases with trismus or in cases with the pain around the joint. So this recent evidence, one of the recent evidence which I got, it talks about the spinal excitability, decreasing the spinal excitability because of the nociception at the affected site, and that will help in reducing pain. Now the second one is intraoral myofascial therapies, like the trigger point therapy, or it is the alternate words used for this are ischemic compression, the pressure release, myotherapy, or acupressure, or digital ischemic pressure. Now in this therapy, as the name says, this is mainly applied on the trigger points of the particular muscle. So in assessment, if you find the trigger point on temporalis, pterygoid, lateral medial pterygoid muscle, you can just apply the digital pressure either with the thumb or the index finger from inside the mouth, and it has a very good effect on decreasing the pain and increasing or restoring the normal length of that particular muscle. There are so many articles nowadays which talks about the intraoral myofascial therapies, and it is found effective in many cases with the TMJ dysfunction. But the first prerequisite for this IMT is you must find out which muscle is affected and the location of the trigger point, because exactly you need to apply your pressure on that particular muscle. Then the stretching exercises, we all know the stretching, it has effect on the connective tissue, and in TMJ dysfunction, the shortening or the reduced extensibility is one of the reason for reduced range of motion. Even sometimes the capsule around the TM joint, it gets contracted and it reduces the mouth opening as well as the side to side movement. So along with the normal stretching exercises, there are certain specific exercise protocols which are nowadays mentioned in many articles. One of that is post isometric stretching. Now what is post isometric stretching? You can see the diagram at the corner, the stretching for post isometric stretching. Now, like you just tell the patient to laterally deviate your mandible, okay, against the resistance. So you don't need to allow the patient, you don't allow the patient to for the movement at TM joint. He just contracting against your palm, and after contraction you just give a push in opposite direction. So it is called as post isometric stretching, and this is very effective, and there are around 5 to 10 articles which I found on post isometric stretching. Sometimes it is called as post isometric relaxation also, and it will help you in stretching the muscles of the mastication or muscles which are around the TM joint. So for every muscle we can give isometric contraction followed by the stretch. Then there are goldfish exercises which you can see. You're just applying the force to pull the TM down. Then there are instruments also which are available in the market, which you can tell the patient to use at home, which will maintain the mouth opening. One of the famous equipment which is available is Terabyte. But the problem is now, I'm just sharing one experience. We are just working on the mouth opening device because we get so many patients with the trismus, as we have a cancer facility at our hospital. So now we are constructing one equipment which will just cost 400 or 500 rupees, and it will help you. The mechanism will be same like Terabyte. Terabyte cost around 15 to 20,000, and it will not be affordable. So even a therapist can work on like the Indian make devices or the custom made devices, which will be affordable to the patient also, and which will be effective also. So along with stretching exercises, we can give this equipment for the patient. He can use at home to maintain the extensibility. So stretching exercises will help in improving extensibility, range, and it will also help in improving your posture of the upper back and neck. Now the relaxation exercises, as I told you many times, it is related to muscle. The TM joint problem, they are related to muscles, or muscles they go in spasm. So you can teach the patient relaxation exercises. You can look at the photographs. These photos are taken from one of the article which showed the effectiveness of these exercises. So exercise is very simple. So you just have to touch your tongue to the roof of mouth just behind the teeth, like this. Okay, so you have to force the teeth against the roof of the mouth, and see, it is very relaxing. Even you can feel. And in the last diagram, you just have to maintain that particular position as long as possible. Okay, so just touching the tip of the tongue just behind the teeth, okay, and maintain that position for some time. And this is very effective method for relaxing the muscles, and it has a good evidence. There are a few RCTs which are done on these relaxation exercises. Then kinesiotaping, my physio friends and colleagues, they are well aware of this. Kinesiotaping is also effective in reducing the pain intensity and improving the range of motion at the TMJ joint. And you can see the method of applying. The tape should start from the TM joint going towards the nose, and one going towards the chin in the direction of muscle fibers. And these are, according to Wing Ting et al., the kinesiotherapy, it can be used as a regular treatment when there is muscle spasm or pain, or when there is difficulty in opening, as it gives the feedback to the person. Okay, so it can be used as a regular treatment, as a stay of treatment, or it can be used as a supplementary treatment for myofascial pain in TMJ joint. Then second is ischemic compression. So like when I am giving IMT from inside, Same way, ischemic compression can be given from outside. Okay, you just have to find out the trigger point and you just have to press it with the help of your thumb, and you have to maintain that pressure on the trigger points for some time, and this will reduce your pain sensation as well as it will release those trigger points which are responsible for pain in the muscle. So kinesiotaping and ischemic compression is also a good treatment option for TMJ dysfunction. Am I audible? Am I audible to all? Hello.
Yes, sir, you're audible.
Okay, thank you very much. I'll just proceed.
Yeah.
Now this is one of the best protocol which you will find on the internet, and on which there are so many articles, and in USA mainly it is commonly followed because the person is also from US who discovered this protocol. I'll not go in detail of all the exercises, but all these exercises in Rocabado 6x6 exercise program. Just remember the name. You can just go back and find out what is it. But this has proved its effectiveness in almost many conditions of TM joint, and it mainly improves the neuromuscular control of the muscles, improves the mobility of the TMJ, cervical spine and upper back posture can be improved, because if you look at the protocol, almost all the components they have given attention. Why it is called as 6:6? Because there are 6 exercises, they are done 6 times, 6 sessions per day for 6 weeks. Okay, so that's why it is called as 6x6 Rocabado exercise program for TMJ dysfunction. So these are the exercises like tongue plugs, control TMJ rotation on opening, mandibular rhythmic stabilization, stabilize head flexion, mainly for the forward head posture, lower cervical retraction like chin tucks, and shoulder girder retraction like bringing the scapula together. So these all 6 exercises, they are very important in range of motion, then the correction of posture and neuromuscular control. So I suggest everyone to check this protocol and start using it when you get a patient. Now craniosacral therapy, it is the one of the latest technique which is used nowadays in many conditions like back pain, neck pain, shoulder pain, cervicogenic headache. There are so many articles, but there are very little bit information given for TMJ joint. The articles are limited on TMJ joint, but work is going on, and you can check. There are so many control trials registered on the website which are working on craniosacral therapy. So craniosacral therapy, according to my knowledge, as I'm not trained in craniosacral therapy, but it is one of the simple massage technique which can be used to enhance the body's own healing capacities. Okay, so by this technique, you can release the tension deep in the body as well as the localized tension. If you give it in the H&M, head, neck and face, it can relieve the tension in that particular area. So it will be, according to the authors, they say that it can help in relieving the fibromyalgia related symptoms, like here in TMJ joint also, all the symptoms, if the muscle is involved, they are similar like a fibromyalgia. So these craniosacral therapy can be helpful to relieve the pain, and it can be helpful to relieving the tension in the muscles of mastication or muscles which works on the TM joint. Now the next is strengthening exercises. So if your TMJ is affected, the muscles around the TMJ because of inhibition or because of disuse, they will go in weakness, and that will reduce the strength of these muscles. So you need to improve the strength. Either you can tell the person to do the self exercises by resisting all the movements, like the opening, closing, or side to side movement, by doing the isometric or isotonic exercises. This strengthening will help you to establish a normal jaw position at rest and when the mouth is open. Now, this is what the Srinivasa has spoke about the posture. He told about whole posture, but I'll just concentrate on forward head posture, which is one of the, I'll say, epidemic nowadays, because you see now so many online lecture, online conferences, mobile use of laptop, or the working styles. You will get almost 4 to 5 people out of 10 people who work on online platforms, they are affected with the forward head posture. But the forward head posture, if you look at the consequences on TMJ joint, it can lead to a worse scenario. Now just take a look at the diagram which is shown on the corner, where the person is in the forward head posture, and you know that the muscles like suprahyoid or sternohyoid, these muscles, they are attached at the sternum, and when there is forward head posture, these muscles, they go in tightness and they will start pulling the mandible down. And with this, there will be more strain on the muscles of the mastication, because they remain in the contracted position to maintain the position of the mandible. So when they are in contracted position, they go in spasm, there are trigger point development. Also the mandible position changes slowly after few years, and it leads to the continuous pain trigger points on the muscles of mastication. Even you can see down the line diagram which is shown in orange, the person is in the forward head posture and it is causing the problem at TM joint. Now, as a therapist, our role comes here. So what we can do, we can just train the person for proper posture, the normal posture, or you can apply the manipulations or mobilizations of the cervical spine. You can strengthen the muscles around the cervical spine which are responsible for forward head posture. You can stretch the muscles which are tight. See, I always tell to my students, when the patient comes to you with one particular condition, never look him locally. Just think the global problem and problem of that particular condition with other joints also or other regions of the body. So forward head posture, when you're getting the patient, you must assess his TM joint also for any problem which this posture has caused on the TM joint. So I want to give the message: treat your cervical spine and relieve your TMJ dysfunction. So it is one of the concern as a physios you must check for. So you can just tell the posture correction, the retraction exercises, they are very effective. The pectoral stretching is effective, and strengthening of the neck muscles, which will reduce this forward head posture. So with this, I'll just end my lecture. I hope I have completed in time. The take home message from my lecture is physiotherapy is an important part of post-operative rehabilitation, or even pre-operative, or any TMJ dysfunction. And if we use evidences, physiotherapy management can play an important role in rehab. So I want to tell each and everyone on this platform, mainly the physiotherapists, just talk to the dentist, just make a good rapport. You just convince them, you just give them knowledge what is physiotherapy and what we can do in TMJ dysfunction. See, this is, though it is not a topic of discussion, we should keep our egos aside and we should work in the team, because no one is expert. as a therapist, we have some limitations. If we talk to these professionals, we can make a good teams, and finally the patient will be at a benefit. With this, these are few references. With this, I'll take a leave. So laughing is the best exercise which we can tell to everyone, and even you people also laugh in a day, at least for some time. It will maintain your mobility at the TM joint. And this beautiful laugh you can bring back to the patients with TMJ disorders if you follow all the evidences and if you assess the patient properly. Thank you very much. I am again thankful to the Krishna Institute of Medical Sciences, Deemed University, and all the organizers for taking this effort to bring all the professionals together, because it is very hectic job to bring everyone on one platform. You all know. Thank you very much. Thank you, Varadarajulu sir and your team, and thank you all the participants. If any question you can ask me right now, if I am able to answer, I'll answer right now, or else I'll answer afterwards. Thank you very much.
Very nice presentation, Dr. Deepak sir. Thank you very much for your valuable presentation, lucid presentation, easily understandable, and really this particular session made all of us to understand that our role that we are going to play with TM joint, even how we are going to integratively working with the dental professionals. Really, Dr. Srinivas and yourself done the utmost justice to the topic, and I think the people have been really benefited out of this, and this session is really useful, sir. Thank you very much. Is there any question, Dr. Trupti?
Yes, sir, we have questions for Deepak, sir. So there is one question. In acute temporomandibular joint pain, how to decide when to commence loading exercises?
Yes, actually in acute condition, main thing is we should find out what is the level of pain and how much a patient can tolerate. So based on that, we can just decide what exercises to be given. Okay, even in acute pain conditions, we have seen in the post-operative TM joint, we have worked with. In acute cases also, we can immediately start if the pain means first we have to give something for pain relief like ice, and then we will start with the loading exercise. But again, it depends on the intensity of pain, as per my knowledge.
So the next question is, does TM joint pain could set into chronic pain syndrome, and how to differentiate it?
Yes, it can be. There are so many cases. You'll see what I said about trigger point. Trigger point is what? It is many times because of the chronic involvement of that particular joint and the muscle. So it can set in the chronic, and many patients, they come the long lasting pain in the TM joint or the muscles. Again, it depends on your assessment. You should find out, is there any fibrous band around the TM joint? Is there any trigger point which is active in the muscle? So chronic pain syndrome, there are so many criteria we should, but the main thing is we should find out the fibrous bands, or we should find out the trigger points and the range of motion by that, and the duration of pain, for how much duration it is lasting. So again, your assessment plays an important role in this.
So the next question is, does taping play an important role like splints in TM joint dysfunction?
Yeah, taping has a very important role, kinesio taping, as I told you. But definitely the evidence is lacking till now. But many people, they are coming up with the randomized control trial. The quality trials are going on. But I feel whatever RCTs I read till now, the taping has an important role, and it can be an alternative to the splinting in few cases, not in all cases, but it will be helpful if you tape the patient.
you, sir. That's all for the session.
Thank you very much, Kriti madam. Thank you, sir. Thank you very much.
Thank you. We all thankful to you, sir. Thank you.
Thank you, everyone. Now we shall start with the scientific paper presentation. I hand over to Dr. Smita Patil for the scientific paper presentation. Thank you.
Good afternoon to one and all. We'll be beginning with the scientific paper presentation shortly. Good afternoon to one and all. Myself, Dr. Smita Patil, Assistant Professor, Krishna College of Physiotherapy. On behalf of organizing team, extend you a velvet welcome to the Virtual International Physiotherapy Conference, Knospe 2020. Knowledge knocks on the door of action. If it receives a reply, it stays, otherwise it departs. So, on this bright day, we are about to begin with our scientific paper presentation. It's my privilege to welcome our respected judges, Dr. Vasavraj Motimat, Associate Professor and Head of Department, Sports Physiotherapy, KLE Institute of Physiotherapy. Sir has working experience of 14 years with 32 publications in national and international journals. He is invited as chairperson, co-chairperson for several conferences. He has held different posts at university like member Board of Studies, member Monitoring Committee of Sports, member NAC Re-Accreditation Committee. We welcome you, sir. Our next judge is Dr. Sridhar, Assistant Professor, Musculoskeletal and Sports Physiotherapy Department, Kempegowda Institute of Physiotherapy. Sir has working experience of 14 years. Our next judge is Dr. Suraj Kanse, Associate Professor, Department of Neurophysiotherapy, KIMS DU Karad, with working experience of 10 years with more than 30 publications in national and international journals. On behalf of organizing committee, I welcome all the three judges to the scientific paper presentation. Motimat sir.
Hello. Yeah, madam, tell me.
Sir, am I audible to you?
Yes.
Sridhar sir. Sridhar sir. Sridhar sir. Hello. Sir. Sir, we are asking to unmute. Okay. Motimat sir, Sridhar sir, and Suraj sir, can we start with the presentation?
Yes, madam, you can start.
Okay, for the presenters.
And madam, one suggestion: if you want us to talk, we should enable our this unmute option.
Yes, sir. Yes, sir.
Trying to reach, but I was blocked.
Yes, sir. Okay.
Okay.
Sir, to all the presenters, you will be having a time limit of 10 minutes. 8 minutes will be your presentation session and 2 minutes will be your question answer session. The marking system will be done by the judges out of 80. So we'll start with the presentation. Presenter number 1.
Am I audible?
You're not audible, madam.
Am I
You're not.
audible?
Yes, yes. Presenter 1.
Am I audible?
Ma'am, your voice is breaking.
Am I audible?
Yes, you are audible, but your voice is breaking.
Okay. Now am I audible clearly?
Yes, yes.
So, happy?
You can start with your presentation, ma'am. Start your screen sharing.
Started. Can you see my screen?
No.
Can you see my screen now?
No, we can't see your screen. तू बोलो ना.
I have started it, ma'am.
You can start with your presentation, ma'am. But your screen PPT presentation is not visible yet.
I have started sharing your screen. You are sharing the screen is coming, ma'am.
Ma'am, stop your screen sharing. Stop your screen sharing. I'll share it from my screen.
I started.
Is it visible?
No. No. Is it visible?
Is it visible now? Is it visible?
It is coming that you have started screen sharing, but I can't see it. Yeah, we can see now.
Is the slide visible?
Title has come. Shall I start?
Yes.
Good afternoon to everyone. The title of the study is Comparison of Muscle Energy Technique and Passive Sleeper Stretch on Glenohumeral Internal Rotation Range of Motion in badminton players between 18 to 30 years of age with glenohumeral internal rotation deficit, a randomized controlled trial. Next slide. Introduction. The glenohumeral joint is a multi-axial ball and socket synovial joint. The joint has a large range of movement compared with all other joints. The range of movement is achieved at the expense of articular congruence, which is compensated by a complex system of static and dynamic soft tissue stabilizers. Altered shoulder mobility has been reported in overhead athletes and is thought to occur due to adaptive structural changes to the joint. Badminton is one of the most popular and widely played sports in the world, and it demands a lot of upper shoulder motions with shoulder in abduction and external rotation. Stretching of posterior shoulder helps in restoring internal rotation loss that occurs due to muscular and
You're not audible, ma'am. You're not audible, ma'am. Motimat sir, is the candidate audible to you?
Yes, madam, she was audible for some extent. Only initial one
I
slide.
guess she has lost her connectivity
Yes, yes.
because we could not find her in participant list.
Okay.
Shall we have the next presenter?
Yes, please.
I request the second presenter to share the slide.
The screen is visible. My voice is audible?
Yes, ma'am.
Okay. Good afternoon, one and all. I would like to start with my presentation, Movement Impairment in Lower Extremity Sports Injuries, a Case Control Study. Introduction, there is a numerous lower extremity injuries which happen each year, which is caused by sports, and the amount of it causes huge in figures. There are common injury sites which include the ankle, knee, and the lower leg. Some injuries result in muscle imbalance, while others may be a result of muscle imbalance. So if there is impaired muscle function, there is joint dysfunction, an altered movement pattern, and ultimately it leads to tissue damage and movement impairment and injury risk. There is a cumulative effect of repetitive stereotype movements and sustained postures, which leads to movement pattern impairment. Now, the movement assessments are the cornerstone of the integrated assessment process to diagnose and to find out the movement pattern impairment, out of which the many tests are available, like the single head squat, the overhead squat. But overhead squat is a test which is very feasible in the clinical setting to find the impaired movement pattern and identify the individuals potentially at risk for the injuries. Need for the study: prevention or early intervention of injuries could be accomplished if some easily administered tests like the overhead squat could predict the risk of developing injuries in athletes. No previous research has investigated the presence or absence of movement impairment associated with injuries in athletes, thus stating a need to identify the presence of movement impairment syndrome in athletes with or without lower extremity injuries, and in turn identifying athletes at risk for developing future injuries. Aim is to investigate the likelihood of movement impairment in athletes with and without lower extremity injuries. Objectives are to find out the presence of movement impairment along with strength and flexibility in athletes with lower extremity injuries. Next is without lower extremity injuries, and to find the difference between the two. Review of literature. Methodology. It was an observational study which was conducted in physiotherapy OPD as well as in stadiums, grounds in and around the city. Athletes, both male and female from the age group of 18 to 40 years involved in either recreational or competitive sports were taken. Cases were the athletes, those who had injuries pertaining to their lower back and their lower limb in the past 3 months. And we had taken controls as matched to the cases with respect to their age, gender, and sport without an injury in the past 3 months. Injury was defined as any mishap occurring during the scheduled games or practice that caused an athlete to miss a subsequent game or practice session. The duration was 18 months. We excluded individuals who had conditions which could result in decreased range of motion at the neck, back, and the shoulder. We used two Sony HDR AS100V video cameras, one live view remote, 2 tripods, and the Keynote software. Sample size was calculated to be 135 each in cases and control with a total of 270. Initially, an ethical clearance was taken and the athletes were later approached through the authorities and coaches. An informed consent was taken from those who were willing to participate. A thorough musculoskeletal assessment was done to diagnose the injury, and later the cases were divided as to the individuals were divided as to cases and control. Once divided, an overhead squat assessment was done to check for the presence of movement impairment. For the overhead squat, instructions were given, demonstration was done, practice squats were done, and the individual was asked to perform a squat with the hands raised and to perform a squat as to reflect sitting on a chair. The participants were analyzed from the anterior and the lateral views simultaneously with the video cameras, which were fixed at the height of the umbilicus, and they were synced using live view remote. Markers were placed on the bony prominences. Outcome assessment was done in context of overhead squat kinematics, which included the lateral view for dorsiflexion, knee flexion, hip flexion, and shoulder flexion angles. And for the enter view, the toe out, the knee distance, the shoulder distance. Manual assessment was done for muscle strength and muscle length assessment. This is how the Keynote graded the angles and the distance measurements. We found that the cases and the control, there was no significant difference as to the age. It was almost 21 to 20 years on an average. With regards to muscle length and strength, there was only difference in the left IT band and the strength of the dorsiflexors between the cases and control. Rest, there was no difference. In context of past lower limb and trunk injuries, there was no difference, but highest being the knee injuries, but most of them had no injuries. In context of presence of lower limb injuries in case of cases, again, top, the knee, lower back, and the ankle. Associated injuries, majority were none, but followed by neck and shoulder. Considering the level of sport, it was same for both the cases and control. When we measured the overhead squat measurements for the angles and the distance discussed previously, there was no statistically significant difference which was noted for both the cases and control. In context of trunk lean, we observed that majority had forward lean, followed by none, and one had rounding of the back. With context of weight shift, while performing an overhead squat, majority had weight shift to the left, followed by right, and followed by no weight shift. We also found the cases with maximum of knee injuries followed by ankle, hamstring, and shin splint. Similarly, a study observing 162 gymnasts observed that based on anatomical location that the ankle and knee top the list. A review article also indicated the knee and the lower leg were topping in the list. We had a maximum of previous injuries at the ankle and knee, but no statistical difference between cases and control. However, a study did suggest that there is an association between previous injury history and the likelihood of sustaining new injuries, whereas another retrospective case control study did not find any relevance. We observed that movement impairment, that is, the forward lean, was noted in cases and control. A study which was studied by Bishop et al. Found that there was a hip hinge strategy in case of back squat performance, that is pushing the hip backwards to complete the task, and the movement is almost similar to the overhead squat. When examining the soccer player, the tightness of the hamstrings and quadriceps were observed. However, there was no association in context of adductors and calf muscles in case of cases and control. Another prospective examination on 47 professional players examined no difference in cases of adductor and adductor muscles in cases and control. We observed no significant difference in flexibility measures of hamstring, quadriceps, adductors, or calf in context of cases and control. I would conclude that movement impairment was observed in both cases and control, as cases are athletes with injuries and control with similar movement impairment. They have equal chances of developing injuries in future if repetitive movements are reinforced on the impaired movement patterns. Thank you.
Thank you, madam. Sridhar sir, any questions? Motimat sir, any questions?
No questions.
Sridhar sir, any questions? Thank you, madam, for the wonderful presentation.
Thank you so much.
We'll have the next presenter number 3.
Good afternoon. Am I audible, please?
Yes, sir.
Okay, I would like to share my screen with your permission.
Yes, sir.
Yes. Okay, so is my screen visible now?
Yes, sir, it is.
Yes, so thank you. Good afternoon to all the viewers. I would like to first of all thank the organizers for arranging this conference and giving us an opportunity to present our research work. I would like to present a short overview of the existing literature about the recent trends in myofascial release therapy. What exactly is this? Is this something new, or is it kind of an old wine in a new bottle which was being practiced in the name of physiotherapy? And I'm sure all of us would kind of relate to it. So the objectives of today's short presentation are, we'll just see an overview about what the fascia is, what is the volume of the research which has been done on myofascia and myofascial release. We will review the traditional approaches for myofascial release and also see a few more tools and the new current concepts which are being practiced. So what is the fascia? Yes, we are all aware it is a connective tissue which is spread all across the body, and it lines all the organs inside our body, helps to give a kind of a skeletal framework. The fascia is a very strong structure. It has a tensile strength of about 2000 pounds per square inch. That's almost equal to the force of a panda bear sitting on you. So the fascia is supposed to be that strong. So it is basically a connective tissue, a thread of, or a meshwork of a thread of fibers made of collagen, which connect the skin to the underlying superficial fascia through the facial threads, which in turn is connected to the deeper fascia. So the entire body and all the organs inside are kind of embedded in this entire fascial network, which is existing throughout the body. And without this facial network, without the fascia system, the entire body would just kind of crumple up, the entire skeletal structure will collapse. So the fascia, the collagen, which makes up the fascia, kind of helps give or provide the body the basic shape and the structure to the entire skeletal system and the whole body. Now, what about the available research? A lot of studies have already been done and published. If we do a quick search on Google Scholar of myofascial release, we find more than 30,000 articles present right from 1970s till current recent 2020s. The number of publications and the volume has recently increased in the past 2 decades. If we talk about PubMed, quick search on myofascial release shows up 519 articles. However, if we see the number of meta-analysis and the RCTs are relatively so less in number, so we need more level 1 and level 2 evidence on the fascia and the myofascial release techniques and all the different approaches. We have a lot of evidence level 3 and down, but more work needs to be done when we talk of research in terms of level 1 and level 2 evidence in terms of meta-analysis and RCTs. So what are the existing approaches to myofascial release? We have our traditional hands-on approaches, which we will just see, and then certain newer, or I would like to call them as interdisciplinary approaches because we have been adopting them. We'll see what they are. So traditional hands-on, I'm sure all of us are aware, all the students are aware, and all physios are already practicing this. We have the cross-hand technique, we have the longitudinal approach, a transverse approach, a compression. So basically all the manual therapy approaches, whatever we do with the hands in terms of myofascial release, these are all known to physios. It basically helps to relieve or alleviate the symptoms, any kind of pain or arising because of the facial restrictions, because of the trigger points. They can be well treated out with manual approaches. A lot of taping approaches are available for myofascia. Again, we can use rigid tape. The example over here shown is a muscle offloading technique where the rigid tape, brown tape is used to offload the muscle, which helps in relieving the symptoms. Kinesiotaping can be used to offload the fascia again. So the different techniques of the tape, they have their own principles by which they help in releasing the fascia. For taping, it's very important to remember that it's not the tape in itself which is effective, but the way the tape is applied, which will lead to the desired effects. So the tapes need to be applied as per the principles in a logical way, only then the taping would be effective. We have a lot of devices available for treating the fascia. We have foam rollers. Foam rollers can be used for for self-release by the patients and as they were on their own at homes. Celiacs or deep compression devices are available. We have mechanized devices like Theraguns and many vibrators now, which kind of would help in achieving the desired results as well. A lot of new approaches are developing or are being adopted by physiotherapists. We have instrument-assisted soft tissue mobilization. We have dry needling, which is being adopted from acupuncture, although acupuncture and dry needling are different. But yes, dry needling with our physiotherapeutic approaches is now commonly used by physiotherapists. We are having cupping, which is used. Cupping is again very effective, both static as well as dynamic cupping. It helps in releasing the fascia and the facial adhesions which are there. So all these tools, when used in a holistic, integrated way, provide much more beneficial effects to the patients. Now, a lot of research is coming up, as I mentioned, but more research needs to be done on these approaches. So kind of summarize MFR, yes, it's an integral component of physiotherapy and manual therapy practice. A lot of work is being done, as I had mentioned in the earlier slides, but there is lack of level 1 and level 2 evidences, which would help to strengthen the efficacies of these treatment approaches in a more rigid research perspective way. And these also provide ample scope for future research projects to be conducted by fellow physios and students as well. So it's a relatively new approach in terms of integrating the existing approaches with the newer concepts, and a lot more can be done. So with this, I end my presentation. If there are any questions, I'll be happy to take them.
Thank you, sir, for your presentation.
Thank you.
Motimat sir, do you have any questions?
Sir, no questions. This session was informative. Thank you so much.
Sridhar sir, do we have any questions?
No questions, ma'am.
Thank you, sir. Thank you for your wonderful presentation.
Thank you, sir. Thank you, ma'am.
Our next presenter, presenter number 4. Do we have online presenter number 4? We don't have presenter number 4 online. So we'll be moving on with the next presentation. Presenter number 5. अजून कनेक्ट नाही केलं. So presenter number 5 is having some connectivity issue. So we'll move on with our next presentation, presenter number 6.
Yes, very good afternoon, ma'am. Am I audible for you?
Yes.
Should I start the screen share?
Yes, you can start.
Is my screen is visible, ma'am?
Yes, sir, it is visible.
Should I start, madam?
Yes, your time starts now.
So very good afternoon, respected judges, organizing team, and all the delegates present here. Today's topic for my presentation is depression in teachers because of cyberbullying who are working in COVID-19 pandemic, and my presenter ID is ICK06. So the introduction is during this current pandemic situation, as we all know that we all are suffering, whole world is unfortunately forced unfortunately forced to be in the indoor because of this pandemic. Various sectors have been affected, and out of which education sector has been affected greatly, as there are more than 6 months have been taken by the corona pandemic. So after that, school, colleges, and the tuition teachers have been started taking online lecture, thereby resuming the curriculum. As we all know that in current scenario, Google Classroom, Google Meet, and the Zoom are being used for the educational by the education institutes. But because of that, the one-to-one interaction which have been done in the traditional teaching method is not done. So according to UNICEF, cyberbullying is a type of harassment with the use of digital technologies. So it is a huge disrespect to the teachers who are taking substantial efforts in teaching students even during this gloomy time of pandemic. Myriad of these scenarios have been seen by these two teachers, like screen scratching by the candidates, scribbling. Students create anonymous IDs, they pass comments while switching off the cameras, they create nuisance in the group chat as well, they make the needless sound, as we all know that the link can be shared with the anyone, so students add their anonymous friend and create mischief in the class. These are the scenarios have been reviewed by the multiple teachers. They are facing cyberbullying by the students. So the need for my study is depression is a common problem in most of the teachers of various faculties, which has to be assessed. The second need for studies, teachers play a very vital role in building future of the students. So there should be a proper assessment criteria has been set by the institutions to keep a check on the depression. Next is cyberbullying by the students may have adverse effect on the teachers, which may include depression, anxiety issues, loss of self-esteem, lack of interest, and associated health issues. These issues later come up with a major health problem to the teachers. So, and obviously there are paucity of the research work done and less number of the data is present related to depression in the teachers working in this pandemic situation. The aim of my study is to study the rate of depression in the teachers because of cyberbullying who are working in COVID-19 pandemic. And the objective for my study is to estimate the prevalence of depression in the teachers who are working in COVID-19 pandemic. And next is to find out the level of mental depression in the teachers who manage their everyday life along with the working from home. These are the literature reviews. So hypothesis for my study is, according to null hypothesis, there is no significant association of depression in the teachers working in COVID-19 pandemic, and alternate hypothesis proved that there is a significant association of depression in the teachers working in COVID-19 pandemic. The methodologies are, the study was observational type of study and with the simple simple randomized sampling method having the 200 sample size with the with having duration of study of 3 months. Inclusion criteria are teacher who are taking lectures via the online platform. All the genders are included in the study with the age group of 25 to 60 years. Subjects who are willing to give consent, and the exclusion criteria is subjects who are taking antidepressants, subjects who are having teaching experience of less than 1 year, subjects who are having age greater than 60 years, and obviously not who all are not willing to participate. The outcome measure which I have used for my study is patient health questionnaire, which is having a 9 questions form. Procedure after completing the ethical clearance, the PH2, that is patient health questionnaire, and the personal information form are shared with the subjects. These are the data collection instrument were implemented by the researchers in the teachers. To the teachers who are willing to share the information, that teachers are informed how to answer the questionnaire during the questionnaire session with the help of telephone and messaging. It will take approximately 10 to 15 minutes to complete the form for each teacher. After completing the questionnaire, participant will send the form to researcher, and obviously a special attention is given so that the form will be restricted to one entry per participant by enabling the option in the Google Form setting. The number of the teachers that completed the questionnaire were observed to be 200, and InStat software and the help of statistician has been taken to complete the statistical analysis. The finding from my study is, according to gender distribution, there are total 117 males and 83 females are present in the study, and according to age distribution, there are total 88 subjects with the age group of 25 to 34, and with the next is 59 subjects are present with the age group of 35 to 44, and next is 45 subjects are present with the age group of 45 to 54, and 8 subjects were present with the age group of 55 to 60. So according to marital status, there are total 66 subjects who are single and 134 subjects are married. That according to teaching experience, 78 subjects having teaching experience of 1 to 6 years, 74 subjects with a teaching experience of 6 to 10 years, 33 subjects having teaching experience of 11 to 15 years, 5 subjects having teaching experience of 16 to 20 years, 4 subjects were present with a teaching experience of 21 to 25 years, and 6 subjects were present having teaching experience of 26 and more. So this is a patient health questionnaire, which there are total 9 questions have been framed depending on the activity of daily living, like eating, sleeping, watching TV, and reading newspaper. So this is the interpretation of the patient health questionnaire, in which there are total 4 scores have been given, like 0 to 4, 5 to 14, 15 to 19, and 20 or higher. So 0 to 4 suggests that the patient may not need depression treatment. There are total 67 candidates who fall under the 0 to 4 scoring. There are total 74 candidates who fall under the 5 to 14, that suggests that mild major depressive disorders. There are total 33 candidates who fall under 15 to 19, suggesting that moderate major depressive disorder wants treatment for depression or using antidepressants or psychotherapy or combination of both. And there are total 26 candidates who fall under 20 or higher, suggesting that severe major depressive disorder. So result and interpretation, as there are total 200 samples have been taken, 83 males and 117 females are present in the study. We have 88 subject age with the age group of 25 to 34, that's suggesting that 44% of the total sample size, 59 subjects having age group of 35 to 44, which is having 29% of the total sample size, 45 subjects of 45 to 54, which is 22.5% of total sample size, and 8 subjects of the age group of 55 to 60, which is 4% of total sample size. And according to outcome measure, that is patient health questionnaire, 67 subjects fall under the 0 to 4, suggesting that 33.5% of the total sample size. Next is 74 subjects who fall under 5 to 14, that is mild major depressive disorder, suggesting that 37% of the total population, that sample size, and 33 subjects who fall under 15 to 90, suggesting moderate to major depressive disorder, suggesting that is 16.5% of total sample size, and 26 subjects who fall under 20 or higher, suggesting severe major depressive disorder, that is 13% of total sample size. Discussion.
As to 1 minute for your presentation.
The research, the act will conclude. When the research was concluded with the aim to study the prevalence of depression in the teachers who are working in pandemic situation. As we all know, depression is a mood disorder. So thus, in the teacher who are working in continuously, depression has to be assessed by the proper consultation has to be done. Teaching faculty is one of the most neglected profession in the terms of need financial support, etc. And we have so in this research, subject has been subjects who are teaching profession are taken into the study with the help of e-form. The result of the study states that the subjects are suffering from mild to moderate symptom, and if proper consultation is not given, it will hamper their life. So I will conclude my study by saying that in this study, we have find out that during this present COVID pandemic, the teachers who are taking online lectures are suffering from depression, and some are on the verge of depression because of teachers who are of young age group. Okay, I conclude my study saying that alternate hypothesis has been proven. These are the limitation, suggestion, and references. Thank you so much.
Thank you for your presentation.
So I need to stop.
You stop your screen sharing.
Yes, that's what I'm doing, ma'am. The option is stop. I can't see the option, ma'am.
Motimat sir, do we have any questions? Motimat sir, do we have any questions?
Yes. I want to know the reliability of the tool, assessment tool which was used, and if it was there, then in what age group was it used? Because now in your this, we have from 0 to 33 years of experience you have taken.
Yes, sir. The reliability, sir, actually I have checked the reliability. As such, globally the reliability is not accepted, but the reliability is 0.001, and the age group is 21 to 60 years of experience.
And experience wise, you have taken all senior teachers also and junior teachers.
Yes, sir.
Freshers. So there is going to be a lot of difference. And if it is about online teaching, it would have been more appropriate if online teaching mode was tested more on the senior teachers who are not well versed with the gadgets. Right?
Yes,
and
sir.
these newcomers, and your title suggested about bullying, and your questionnaires were related to depression.
Yes, sir.
I don't think all these it is that common to trouble a teacher to this extent. But anyhow, sticking to the research, I still would suggest that if the group was more uniform, new teachers and old teachers were compared like this, or if it was only new teachers, yes. So
yes,
that is the only thing. And about the reliability, when we are using a tool which is less reliable.
Yes, sir.
Okay.
So I will do the changes
How
in
legitimate is it to name them with something of this disorder?
Sir, there are multiple reviews.
Yes.
Yes, sir. Can I say, sir?
Yes, no problem.
Yes, sir. Sir, actually, there are multiple reviews shared by the teacher. Like starting में, sir, it was like the students are creating mischief, like they are abusing the teachers, kind of thing. Has the multiple reviews has been shared by the teachers, and there one incident also.
No, it is about assessment tool.
Yes, sir.
It is about the assessment tool that you have used, the questionnaire.
Yes, sir.
And the age group that you have chosen. When my simple question is, when I am choosing a tool that is less reliable.
Okay, sir.
So, okay, and tagging somebody with a minimum or maximum moderate kind of depressive illness kind of thing, which is related to pandemic or the professional thing.
Yes, sir.
Okay. Yes. Thank you so much.
Changes.
Yes. Not
Sir.
a problem.
Thank you so
Thank
much.
you.
Thank you, sir. Sridhar sir, do we have any questions?
Yeah, just like what Motimat sir said, there should be some difference between the new teacher and the teacher with experience. That's it. There should be some difference.
Actually,
Right?
sir, I have taken this questionnaire because there are less number of teachers who are senior. So that's why I prefer this questionnaire for my study. As you can say, as you say that there are the age gap. So obviously I need to change the, I will have to change my study.
Thank you, sir.
Okay. Okay.
We'll move on with the next presentation. Presenter number 7. Presenter number 7.
Yes, good afternoon, everyone. Can I start my presentation?
Just a
Ma'am,
second.
yes.
You can start your screen sharing.
Yes, ma'am, but I am not able to it. On my screen, ma'am, it is written you cannot start your video because the host had stopped it.
Just a second.
Okay, okay, ma'am. Good afternoon, everyone. I'm starting with my presentation. I'm sharing the screen. Am I audible, ma'am?
Yes, yes.
Yes. So, good afternoon, everyone. My topic of today's presentation
Please keep your video off.
to effect of. Yes, ma'am.
Please keep your video off.
Okay, ma'am. I will keep video off. Yes, ma'am. Yes. So, ma'am, my screen is. Can you able to see the screen?
Yes, yes.
Yes. So I'm starting my presentation. My presentation topic is the effect of core stability strategies on balance and fatigue in multiple sclerosis patient. So basically multiple sclerosis, you know, there is always an autoimmune disease characterized by inflammation, selective demyelination, and the gliosis, which can lead to a disability and also impair the quality of life. In clinical manifestation include the vestibular problem, postural, intestinal tremor, trunk muscle weakness, ataxia, along with fatigue, impaired balance, and impaired sensation. These are along with some visual impairment. So a higher risk of fall can be seen in patients with multiple sclerosis perform more than a single task or which demands cognitive as well as the motor skill while the walking. So balance is getting affected. The fatigue in the multiple sclerosis is different from the healthy individuals. It is defined as the abnormal sense of tiredness or lack of energy, degree of effort or level of disability that significantly interfere with the routine physical and intellectual function. Core stability, dual tasking, and sensory strategies exercise program includes the exercise which target the factors of importance in maintaining the balance during activities, as activation of trunk muscle is important for balance, and the core stability training is also very important. So need of the study, the balance is one of the affected balance disorder is most of the frequent symptoms in multiple sclerosis, so which leads to the abnormal postural stability and increase the risk of fall. Imbalance with difficulty in coordination of body segments during the movements during the transition phase from between the movement and during the upright posture. Fatigue is the most common disability symptoms in multiple sclerosis. From the initial stages of the disease, a physical deconditioning is also observed because of the fatigue. As a result, training of core muscles along with the sensory strategies may help to improve the strength of the surrounding muscles and in turns reduce the fatigue and improve the balance in multiple sclerosis. So aim of the study to study the effect of core stability, dual tasking, and the sensory strategies on balance and the fatigue in multiple sclerosis patient, To study the effect of core stability, dual tasking, and sensory strategies exercise program on the balance in multiple sclerosis patient using Berg balance scale, and to study the effect of exercises on fatigue by using modified fatigue impact scale. So null hypothesis, there will be no effect of core stability, dual tasking, and sensory strategies on balance and the fatigue in multiple sclerosis patient. And H1, there will be the effect of core stability, dual tasking, and sensory strategies exercise program on the balance in multiple sclerosis, or there will be the effect of core stability, dual tasking, sensory strategy exercise program on fatigue in multiple sclerosis patient. The study design, it is the experimental study. The duration is total 6 month duration. Target population, we are targeting the relapse and remitting type of multiple sclerosis patient. The sampling method is simple random sampling using the coin test. Sample size 30, and sample study setup is the rehabilitation centers in and around Pune. Outcome measures, we are going with for assessing the balance, Berg balance scale, and for the assessing the fatigue, we go for the fatigue modified fatigue impact scale. So major criteria, inclusion criteria, patient with multiple sclerosis since 1 to 2 years, both males and females, and above the age of 20 years we are included. And also in that we have the expanded disability status score, which is less than 5 or equal to 5, Berg balance scale more than 20, dynamic gait index more than 19, and minimental scale minimum score is more than 24. Exclusion criteria, patient not willing to participate in musculoskeletal disorder, recent surgical history, or acute exacerbation of MS symptoms in past 6 months. We are excluded from the study. The permission has been taken from the institutional ethical committee, and the survey was carried on 50 individuals of relapse and remitting multiple sclerosis. Out of that, the randomized control trial study has been done on the 30 patients according to the inclusion exclusion criteria, and the patient was divided into the group A and group B, 15 in each group. The group A is the experimental group and group B is the control group. Group A was given the core stability, dual tasking, and sensory strategies for the 45 minutes per session, twice in a week for 6 weeks. This is the 5 minutes warm up, 15 minutes of core stability, 10 minutes of dual tasking exercise, and 10 minutes of sensory strategies, and 5 minutes of cool down exercises. Group B, which again 45 minutes twice a week for the conventional type of exercises, which include the warm up, 15 minutes of supine sidling, quadruped sitting standing exercise with 10 repetition, 15 minutes of strengthening or balance standing exercise, and the 5 minutes of cool down include the Mitchell and Jacobson relaxation technique. And after 6 weeks, again, we are assessed with the balance with the Berg balance scale and fatigue with modified fatigue impact scale. These are my review of literature. Statistical analysis has been done though using the Microsoft Excel 2007 and Instat software with the level of significance is set at 5%. These are the age-wise, this is the gender-wise distribution between the graph group A and the group B. This is the experimental group in which you can see that there is a more significant improvement in the Berg balance scale, and also there is a significantly reduce in the modified fatigue impact scale. In the control group also shows the significant improvement, but in the experimental group, there is a more significant improvement as compared to the control group in both Berg balance scale as well as the modified fatigue impact scale. The discussion, the role of sensory and motor control is more important than the role of strength and endurance of the trunk muscles. The decreased trunk stability in patient with multiple sclerosis as compared to healthy individual. Trunks were noted when the standing with the further increase by adding the dual task and sensory disturbances evokes the difficulty in balance, control in quiet standing, and increased postural sway. The deep abdominal muscle have to be found to be assist in stabilization of the supine and play in the important role in the postural control. The study was supported by Cataneo et al., which shows that there is a larger improvement in Berg balance scale for the combined motor and the sensory strategies than compared to solely the motor exercise. So challenging exercise that promote the sensory compensation seems to have an impact on dynamic and static balance and reduce the risk of fall. Also, to prevent the fall, we require to stabilize the center of mass by central integration of input from visual as well as the vestibular sensory system. And this study is supported by Marie-Lucia Gandolfia, says that the balance control is a complex skill, involves the integration of incoming sensory information from the somatosensory visual and vestibular system. That's why the sensory strategy is helpful for the improve the balance. The patient will
Last 1 minute for the presentation.
Yes, ma'am. Reduce the performance and muscle show the characteristic of disuse, reduce muscle fiber size and shift in proportion from type 1 fibers toward the type 2 fibers. Also, suboptimal central neural triad leads to the incomplete activation of muscles, and that leads to the fatigue to such a patient. And along with that, they concluded that there is a more significant effect of core stability, dual tasking and sensory strategies on the balance and reducing the fatigue. And the limitations, small sample size, advanced equipment not used for assessing the balance, and future scope, we can consider the intrinsic and extrinsic factor for balance. These are my references. Thank you.
Thank you, sir.
Thank you, ma'am.
Sridhar sir, do we have any questions?
No questions, ma'am.
Motimat sir, any questions? Motimat sir, any questions?
Yes.
Yes, sir. Yes, sir.
Yeah, thank you. Sir, it is about staging, the selection criteria.
Yes, sir.
You have taken the type of multiple sclerosis where you have mentioned.
Yes.
Relapse
yes,
and remittent, right?
Yes, sir. Yes, sir.
So, is that going in hand, like where there is a chances of recovery?
Yes, sir.
Which is falling in line with the treatment. So,
yes, sir.
It would have been more appropriate if there was a control group where no treatment was given.
Okay, sir. But here, for the multiple sclerosis, we cannot stop the patient for going through the treatment. So whatever treatment going on, we are continue with the treatment, and also we adding this our core stability, dual tasking, and the sensory strategy protocol in that.
Okay.
Yes. Okay, sir.
Yes. Thank you, sir.
Yes. Thank you, sir. Thank you so much. Ma'am, your voice is not audible. Trupti, ma'am.
We have our next presenter number 8.
Ma'am, Dr. Nilesh Andare also sharing my same screen from my laptop.
Okay, okay, sir.
Okay. Thank you, ma'am.
Hello. Yes, ma'am. Nilesh here, ma'am.
Yes, sir.
Yeah, I'm just sharing my PPT, ma'am. Hello, ma'am. Just a minute, ma'am. I think so. I shared the same PPT. Ma'am, my PPT is visible to you?
PPT is not visible. Only the screen, what you had opened prior, it is visible.
Okay, just ma'am. Hello, ma'am. Now PPT is visible to you?
Yes, sir, it is visible.
Okay, yes, ma'am. Shall I start, ma'am?
Yes, your time starts now.
Yes. Good afternoon. All my topic of presentation. Today's topic of presentation is effect of speed, agility, and quickness. That will be the SIQ training on the performance of the young Indian kabaddi players, which is a randomized control trial. Uh, yeah, introduction. The fitness is probably the most important overall determinants of the population health. Unfortunately, may extract a cost in the form of the activity-related injuries. Injuries are most common in the different sport if there is a no training or poor training practices or improper type of practices has been activated. The kabaddi is the traditional game played by the Indians in India in different situations. In that we have the most probably the player has to be referred as a rider who is crossing the one on the run to the opposite side of the team of the half of the court and tag out the many as of the defenders as possible and come back to the in the his own court. From this, it can be understood that the game of the kabaddi is a predominantly an anaerobic sports. Player most of the time move in the sideways and have to keep the center of gravity as low as possible. SUK training is the speed, agility, and quickness training. This method of training aims to improve the athlete's multidirectional movement by programming their neuromuscular system. It also helps to improve their lateral linear horizontal movements and the ground reaction force as well as the brain signal efficiency and the motor skills. The need for the study is it is traditionally as the uh, kabaddi players need a strength in the lower extremities. Resistance training was most probably the prescribed one. As the game has evolved around the years, so has it has been demanding by the players and their need to adapt the different terrains indoor or outdoor in different situations. The game demands agility, muscular coordination, breath holding capacity, quick response, and a great deal of presence of mind, which leads to the different training program for the better outcome on the field. As the present scenario requires more better performance in the competitive world, and there is a need to be improving the all aspects of the performance. Hence, the need for the study. The aim of the study is mostly to find out the effect of the SOK training on the performance in young Indian kabaddi players. And objective of the studies are to study the effect of the speed, agility, and quickness training on the agility using the T test. And the second objective is to study the SOK training on endurance using the yo-yo test, yo-yo endurance test. The hypothesis for the study is there will be the no effect of the SOK training on the performance in young Indian kabaddi players, and alternative hypothesis will be there will be the effect of the SOK training on the performance in young Indian kabaddi players. These are my review of literatures. Materials and the methodology. The study design is the experimental type of study design using the agility t test and the yo test to measure the parameters of the agility and endurance in young Indian kabaddi players in and around the Pune city, India. And participants who are total 60 competitive kabaddi players has from the different kabaddi institutions participated with minimum 1 year of experience playing at the different levels and age between the 18 to 30 years of group. These are the sampling techniques. Mostly the target population which we have included. These are the Indian kabaddi players between the age group of 18 to 30. Players was assessed for the agility and endurance using the from the different kabaddi clubs in and around the Pune. Study design was the experimental study in which we have the randomized control trial. Sampling method is the simple random method in which the total 60 samples was collected. The half samples was gone to the SUK training and half was given for the conventional training program group. Most probably the materials used for the study is the cones, measuring tapes, ladder, stopwatch, audio players with the yo-yo test and the audio files. Inclusion criteria for the studies in the age group of mostly 18 to 30 years, which is the adult age group, with the both the genders are included in the study, and subjects who are willing to participate will be the included in the study. Exclusion criteria for this study is the patient who has recent injuries, patient who have undergone the recent surgery within a last year for the lower limb as well as the spine regions also. These are the outcome measures for the my study is the agility. For to calculate the agility, T test has been used, and for the endurance, yo-yo test has been performed with the players. procedure for this thing, permission was taken from the concerned institutional ethical committee, and the various kabaddi clubs will be the approach across the Pune city. The aim and objective of the research was to be explained to the players, and they're willing to be participate what be included, because some of the participants was not completed the training program because of the some their practices or their playing activities in the study. That's why total 44 players are only included, and their written consent also was obtained from the players. Parameters such as the agility, like a T-test and endurance CO test, will be the major prior to the training. A pilot study will be the conducted, and events will be the result. These are the examples while doing the mostly SQ training in the ladder training, how we are going to give these things. The SQ program design with this thing, which include the 10 minutes of warm up with the uh, different ladder this and cold this activity which we have given, and the cool down period for the 5 minutes. Total 35 minutes of program has been included in their everyday curriculum. Post training, the parameters of the agility and endurance must be taken by agility test and the yo-yo test. Then comparison was done of the pre and post analysis using the statistical analysis. For that, we have used the Microsoft Excel 2007 and Instant by pair t-test to compare the pre and post value within the group, and unpaired t-test to compare the pre and post data between the groups. The result for the study is most probably the experimental group has a 22 players, and the control has been given a 22 players with the gender-wide distribution. The agility show in the agility, it shows that it will be have the p-value more significant than the control group in the experimental group than the control group. And endurance has the for the endurance purpose, the yo-yo test performance has been better in the both the groups. This is the distribution of subject according to the agility. The above graph mostly interpret that the comparison, the post interventional experimental group has a significant improvement in the agility than the control group, as well as in the distribution of the subjects according to the interest. It shows that there is the post intervention experimental group and the control group has significant improvement in the endurance with the both the groups. Discussion for this thing, post training is the physical, technical and moral intellectual
Last 1 minute.
participation. Yes, ma'am. Of an athlete with the help of physical exercise. The purpose of this training program is to produce the metabolic, physiological, and psychological adaptation to allow the first person to achieve the top levels of performance. Mostly, this helps to improve the this exercise helps to improve the speed and neuromuscular coordination with the least degree of fatigue possibility. The Mohammed Abbas and Alin in 2018, the study has shown that the improvement in the different physical variables and the performance level in the kabaddi play in the different types of playing activities. It has shown that there is the result has been taken account by the trainers in order to better understand and implication of this accept of training sessions and the lessons. The SOK training helps in improve the normally neuromuscular activities also, and the quickness also in the directions. These studies helps in the mostly the quick acceleration and deceleration, which is helpful in the and always as well as the forward and side to side movements and balance, which helps in the kabaddi activities. Yes, the central nervous system sends messages to the muscle motor units, which works together to the muscle fibers and making the muscles more stronger, which helps in the performance of the kabaddi players. The conclusion of this study, the present study concluded that significant improvement in the both agility and endurance who underwent the speed, agility, and quickness training. These are the limitation for the study was given only for the particular time of period for a month period, which can be given for a longer duration for the improve the normally players performance. The future study, this training can be utilized in the different types of sport activities also. These are my references. Thank you.
Thank you so much. Any
Yes,
questions?
thank you, ma'am.
Yes. Sir, are there any questions?
No questions.
Okay, ma'am.
Both
Thank
of
you,
you?
ma'am. Yes.
Any questions?
Yes, dear. Sunil.
Shall we move further if there are no any questions? Okay, thank you, sir.
Okay, thank you, ma'am. Thank you, sir.
We shall move to the next presenter, presenter number 9. Presenter number 9, are you there? Presenter number 9. I repeat, presenter number 9, are you there?
Ma'am, am I audible?
Yeah, you are audible. You
Yes,
can.
good afternoon. Yes, can I share my screen?
Yes.
Ma'am, screen is visible?
No.
Ma'am, now screen is visible?
Yes, it is visible.
Yes. Good afternoon, ma'am and sir. My
Can we
topic.
slide share? Slide show. You can start now. Your time starts now.
Good afternoon, ma'am and sir. My topic for presentation is prevalence of diabetes mellitus and its association with musculoskeletal pain among the adult slum dwellers. The population in India has an increased susceptibility of diabetes mellitus. Diabetes mellitus is a multisystem syndrome characterized by persistent hyperglycemia that has both acute and chronic biochemical and anatomical sequelae. The comorbid chronic pain is very common in type 2 diabetes, diabetic neuropathy due to presence of musculoskeletal condition associated with the prolonged hyperglycemia. The alarming increase in the prevalence of diabetes globally has made it a major public health and economic problem. The second highest number of people with diabetes in the world currently living in India, that is 69.2 million, and these numbers are expected to increase 123.5 million by 2040. The need for study is diabetes is an iceberg disease, although increase in both the prevalence and incidence of type 2 diabetes has occurred globally. Currently, the number of cases of diabetes worldwide is estimated to be around 150 million. The number is predicted to be doubled by 2025, a prevalence rate of about 5.4%, with the greatest numbers of cases being expected in India and China. Previously, it was considered a disease of the middle age and elderly. Recently, the type 2 diabetes has accelerated in all the groups and is now being seen in younger age group, including adolescents, especially in high-risk population. Therefore, the need was felt to screen the slum population residing in the vicinity of the tertiary healthcare center. The aim of study is to find out the prevalence of diabetes mellitus and its association with musculoskeletal pain among the slum dwellers. The objective is to estimate the prevalence of diabetes mellitus among the slum dwellers by using the glucometer to find out the association between the diabetes mellitus and the musculoskeletal pain by standardized Nordic musculoskeletal questionnaire. These are the reviews. The null hypothesis suggests that diabetes mellitus is not associated with the musculoskeletal pain among the slum population. The alternate hypothesis, the diabetes mellitus is associated with the musculoskeletal pain among the slum population. The materials and methodology used in my study is the type of study, observational study, convenient sampling. The sample size is 800 population. Duration of study is 2 years. The material which is used, that is glucometer, strip, disposal needle, weighing machine, and measuring tape for the height. In inclusion criteria, the 18 years and above, both genders were included. Individual present at home at the time of the door-to-door survey, willing for screening. In exclusion criteria, cardiovascular condition, type 1 diabetes mellitus, congenital anomaly, pregnant woman, gestational diabetes, recent history of GIT, recent musculoskeletal trauma, that is fracture, and any injury. The outcome measures the measurement of random capillary blood glucose level, the intensity of pain by numerical pain rating scale, and Nordic musculoskeletal pain questionnaire. Now, the procedure, observational study was conducted to know the prevalence of diabetes mellitus and its association with musculoskeletal pain among the slum dwellers. Across observational study was carried in the field practice of the tertiary healthcare center. Approximately the 200 houses were surveyed to get the estimated sample size of the 800 population. The Gram Panchayat layout located in the vicinity of the tertiary healthcare center visited with the details of the address as per census of the 2011. To complete the survey, the help of the medical social worker and the pathology technician was requested. The glucometer recording was recorded, and the Nordic musculoskeleton questionnaire was given for the marking. And then after the Nordic musculoskeleton questionnaire, the numerical pen rating scale was given to the diabetic patient. All the participants were explained about the importance of the physiotherapy in the diabetic care, and data was collected as per the procedure, and then it was analyzed. So the graph and table shows in the first pie diagram, there is a total population of the 800 in which we have just distributed into three groups. That is a group 1 according to random capillary blood glucose level. In group 1, that is 79 to 160 mg per dl. That in group 2, 161 to 200 mg per dl, and group 3 is more 200 mg per dl. But in group 1, there is 251 subjects is falling under the group 1, whereas the 217 subjects falling under the group 2 and 332 subjects is falling under the group 3. In which we got the 271 confirmed diagnosis cases during the survey. Out of that, the 85 subjects is falling under the group 1, 97 is falling under the group 2, and in group 3, 89 subjects is falling under the group 3. So we got the 9.28 the prevalence rate during the survey. That the pie diagram shows the diabetic and non-diabetic population, in which the diabetic population there is a 34%, that is 271 is confirmed diagnosis cases, and whereas the 579 is a non-diabetic cases. The Nordic musculoskeleton pain questionnaire numerical pain rating scale marked by the diabetes patient, in which the group 1, the Nordic musculoskeleton questionnaire is marked answer. They have responded to yes, that is 57 subjects, and 28 subjects responded to no. And whereas the group 2, the 68 subjects responded to yes, and 29 subjects responded to no. In group 3, the 53 subjects responded to yes, and 36 subjects responded to no. In numerical pain rating scale, that is the overall mean, that is a 4.7. In the numerical pain rating scale, that is on the group 2, that is 5.1, and in group 3, that is a 4.3. So the total number of subjects, that is the subjects who have responded to yes is 178, whereas 99 subjects responded for the no. The result shows the random capillary blood glucose level was used to divide a survey population 800 into three groups. The group 1 were ranging between the 79 to 160 mg per dl in the terms of RGBL, that is random capillary blood glucose level. The group 2 is 161 to 200 mg per dl. In group 3 is more than 200 mg per dl. The group 1 having the 251 subjects, group 2 having the 217, and group 3 having a 332 subjects. Observation drawn the attention towards the known
Last 1 minute.
diabetes among the slum population, whereas the prevalence we got the 9.28 out of the 800 slum dwellers. The 271 is falling under the diabetic group, and the 529 falling under the non-diabetic group. The Nordic musculoskeleton questionnaire is marked by 178 they responded to yes, and 97 responded to no. In the present study, the prevalence of diabetes mellitus is found to be 9.28 of 149 subjects, in which there is a male and 122 were the female. In which the Nordic musculoskeleton questionnaire is marked by the 178 subjects. In group 1, the 57 subjects is responded yes. In group 2, 68, and in group 3 is 53. The numerical pen rating scale were under the 3 group, but group 2 shows the higher pen intensity. So the conclusion of the study is individual with a confirmed diagnosis is at a high risk of musculoskeletal symptom. I concluded that the alternate hypothesis has been proven, therefore abort the study, so that the study end up with the note that the diabetes affects the musculoskeletal pain.
Thank you.
Thank you.
Any questions?
No questions.
No questions. No questions.
Okay, thank you so much.
Thank you so much, ma'am.
Yeah. We'll move on to the next presenter, presenter number 11. Presenter number 11.
Hello, am I audible?
Yes, you're audible, sir.
Yeah, okay. Good afternoon, one and all present over there, respected judges and the organizing committee, and one of all who is doing this in. Yes, yes, yeah. Is my PPT visible to you all?
Yes, your PPT is visible. Yeah. Okay. Your time starts now.
Yeah. So the title of my study is a study to assess the effectiveness of ergonomic interventions on neck and shoulder pain among the college students as a preliminary observational study analysis. So introduction, as we all know that the neck and the shoulder pain is defined as a pain which is lasting for a longer a day in an anatomical distribution, which is bounded by the occiput and to the lower edges of the scapula. And where there are various researchers which has done, and there is a prevalence of neck and shoulder pain, which is about, in general population, it is about 65%. But in a study which is conducted about in 2016 in Lahore, it states that the neck and the shoulder pain the prevalence is about 56%. And the main causes of the neck and the shoulder pain is that the neck and the shoulders has the structures which supports the head. So it makes like the 1/7 of the body weight is supported over these structures. So as the students who are there, as I am conducting the research on the students, so these students develop a posture like a poor posture imbalance usually adapts in this posture. So due to this, what happens, there is a much triggering factors which causes the pain over the neck and the shoulder pain. So that is why the prevalence, as we see that the prevalence is more common in this population. So during the past few decades, the exercise-oriented interventions or ergonomic interventions have been used widely, and the experience of several institute-based rehabilitation programs have shown the value in the reduction of the neck and the shoulder pain. So there are much researches was done in many of the populations, such as office workers and all. And there were like rehabilitation programs, like workplace interventions have been done. But the quality of the research in the field of college students still remains unexplored. Hence, there is a need for ergonomic interventions on the neck and the shoulder pain among the college students. So the objective of my study was to assess the effectiveness of ergonomic interventions on the neck and the shoulder pain among the college students. So then the inclusion criteria was college students with neck and the shoulder pain, which age ranging from about 18 and above, and students of all age gender was included in my study. And exclusion criteria was recent surgeries around the neck and the shoulders, and with acute neck or shoulder trauma or systemic disorders like rheumatoid arthritis or any inflammatory disorder were excluded from the study. And the procedure was like ethical clearance was obtained from the institutional ethical committee. And as my study is a preliminary study, about 42 subjects were the original the sample size calculated. So among which I have been included the 20 participants because it's an ongoing study. So among the 20 participants who were there, so I have given them the informed consent form, and as well as a pro forma of the exercise program were in order, as well as some postural correction advices were also given to them. And neck and shoulder pain intensity was calculated using the NPRS. As I avoided the VAS because VAS scale is like we are a 10 centimeter scale, and it's usually it's a time consuming, and the children are much literated, so it is better to use that the NPRS, that is the numerical pain rating scale. So other outcome scale which I was used was like the neck disability index and the SPADI scale. And the mobility was using the cervical range of motion assessment. The mobility was assessed by universal cervical range of motion goniometer. So the participants were taught free range of motion exercise for neck and strengthening exercises for the neck and the shoulder and the neck muscles, and some self-stretching exercise, which the students has to complete it for 4 weeks, and a logbook was given to them so that I can get a assurance that the students have been doing these exercises at their respective places. And postural correction ergonomics were also taught to the students. The students were requested to do the exercise for 4 weeks. So the study approved by the institutional committee, and students were recruited from the respective college, and the students were screened for the inclusion and exclusion criteria, and the written consent form was signed by the accepting participant, and the procedures was well explained, and the pro forma which was there, the exercise pro forma was given to the students, and the demographic data were obtained prior to the exercises. And then the subjects were assessed for neck and shoulder pain and functional disability using the outcomes such as the NPRS, the neck disability index, and the shoulder pain and disability index, as well as the cervical range of motion for mobility by using the universal goniometer. So the questionnaire with the exercise instruction was also given to the participants, and the subjects were reassessed after 4 weeks, and then the analyzing of the data analysis was done. As it is a preliminary, so only 20 subjects were recruited and the 20 subjects were analyzed for the study. And the statistical analysis and results, various statistical methods such as mean, standard deviation, and paired t-test was used for the pre and the post intervention analysis. And the data was statistically analyzed by using paired t-test after the analysis. So parameters like pre and post treatment were analyzed, and they were, as among these 20 students, there were highly significant changes seen with the respect to the pain, disability, and cervical range of motion. So after the statistical analysis, this study strongly, because as the 20 students which were there, as they were assessed after this, so it emphasized that so they were highly significant in all the factors like pain, as well as disability, and as well as the cervical range of motion in the mobility also. So this study so according to these findings, I state that the study strongly emphasized that adopting ergonomic intervention for subjects with neck and shoulder pain among college students has a significant effect in reducing pain and disability, and also helps in improving the cervical range of motion as compared to the pre-interventional period. So the conclusion is like it can be concluded that the ergonomic exercise have a positive effect on neck and shoulder pain. These are my references.
Thank you so much.
Yes, ma'am.
Any questions from the judges?
No questions.
No questions.
Okay. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, ma'am.
We shall move to the next presenter number 12. Presenter number 12.
Yes, ma'am. Good afternoon.
Please share your screen.
Yes. Is my screen visible?
No, not yet. Your screen is looking blank.
Now it is visible?
No.
Just wait. I will try once again. Now is it visible?
No, madam. It is showing double click to enter the full screen mode.
Just a second.
Yeah,
Now
now
is it visible?
yeah.
Yes. Okay.
Put it on the slideshow mode.
Yes.
So your time starts now.
Yes. Good afternoon, one and all. For the topic for my presentation was dry needling, a panacea for myofascial trigger point, a case study. For introduction, as we all know that myofascial trigger point is a hyper irritable spot in the skeletal muscle. It causes the muscle flex. It reduces the muscle flexibility, causes muscle imbalances, which also causes the postural imbalance. Dry needling is a new and effective arsenal for treatment of myofascial trigger point, which could instantly deactivate the trigger point. Mostly the dry needling is indicated when there is a restriction in range of motion due to the muscle contraction. It is incorporated into a treatment plan where myofascial trigger points are present, and which may lead to impairment in the body structure, pain, and functional limitations. Also, dry needling is effective and efficient technique for the trigger points. It is low in risk to benefit ratio. It is less expensive and it is portable anywhere. The aims and objectives. Aims was to study the effect of dry needling in the treatment of myofascial trigger point on trapezius muscle. Objective was first objective to study the effect of dry needling on pain in the treatment of myofascial trigger point by pressure algometer in trapezius muscle. Second one is that to study the effect of dry needling on width of the muscle and size of the trigger point on ultrasonography in the treatment of myofascial trigger point in the trapezius muscle. And the third one is to study the effect of dry needling on cervical range of motion by goniometer in the treatment of trigger point in the trapezius muscle. Material used was dry needles, 40 to 50 mm, as it depends on the patient muscle girth. We use the different types of needle. Treatment couch, as the patient is in prone lying position, the treatment couch is important. Data collection sheet to record the pre and post data for the same patient. Consent form, hand gloves, sterilizers, and cotton. If there is a oozing of blood, then cotton will be used, and the needle disposable bottle. So material and methodology. A 24-year-old female reported to the physiotherapy OPD. She is having a chronic posterior neck pain. On the evaluation, the active myofascial trigger point was detected on palpation with the help of the finger pad, and on examination, it has shown the positive germ sign. So after that, she is included into my study. For the baseline data for the neck ROM, pain pressure threshold, and neck disability index, and the size of the trigger point and muscle width on USG was recorded pre-treatment and post-treatment. That means on the after the 9th session, that means on 21 days was recorded. During the for the treatment, the patient was treated with the dry needling, where the 40 mm filiform needle was used, and each treatment lasts for 5 minutes on alternate for 3 days. During the treatment session, each session the vitamin C tablets was given to fasten the tissue healing, and after the treatment session, icing and stretching exercises was given to avoid the muscle soreness. So this is the position for the treatment. Now this is the pre-treatment USG, in which the muscle size D1 is the muscle size, which shows it is at 12.1 mm before the treatment, and the trigger point size was 1.2 mm for the treatment. And this is the post-treatment USG after 9 session. That means after 21 days, the trigger point size was reduced. It got 0.7 mm, and the muscle width was 4.9 mm. So my main outcome was ultrasonography. So the muscle width on USG pre-treatment is what 12.1 mm, and post-treatment is got 4.9 mm. Trigger point size was pre-treatment is 1.2 and post-treatment is 0.7. Due to the decrease in the trigger point size, the muscle width also got decreases after the treatment. The pressure algometer pre-treatment is about 1.3 kg, and after the treatment it got 2 kgs. Neck disability index pre-treated it was 23%, and after the treatment it got 5%. The next outcome was range of motion for cervical. Then pre-treatment left cervical rotation was 60 degree, and after the treatment it got 90. That means the full range achieved after the treatment. Right cervical rotation pre-treatment is for 80, and after the treatment it got 90. Same, that means full range was achieved. Left cervical flexion was 35 pre-treatment, and after the treatment it got 45. And right cervical flexion 30. After the treatment it got 45. So the result was there is a significant increase in cervical range of motion, flexion and extension. Along with there is a decrease in pain and decrease in the size of trigger point was observed after the 9th session. Conclusion: dry needling therapy proved to be effective in the treatment of trigger point in chronic trapezitis. Thus, it improves the muscle integrity and work efficiency. And also, this study can be done in the large scale. So, my references for the same is this. Thank you.
Thank you. Any questions?
These nine sessions of dry needling.
Yes, sir.
Were performed over how many days?
Sir, it is given for alternate days for 3 weeks.
3 weeks.
Yes.
Okay. Yes. Thank you.
Yeah. Thank you, sir.
So, what was the duration for post-treatment? Like you showed ultrasound, the scan, no?
Yes,
so pre
ultrasound.
and post.
Yes.
Pre and post. Yeah.
Pre-treatment was taken before the giving the treatment, and post on 21 day after the 9th session on 21 day.
Okay. Totally 21 days, is it?
Yes, yes.
Okay. Okay.
Yeah.
Thank you so much.
Thank you, ma'am. Thank you, sir.
We shall move on to the next presenter number 13.
Ma'am.
Yes.
Yes, ma'am. Presenter number 13.
Yes.
So, ma'am, I'm sharing the screen now.
Yes, please.
Ma'am, is it visible?
No. Yeah, now it is visible.
Now it is visible. Okay, ma'am.
Can you put it on the shares? Yeah.
Yes, ma'am.
Okay, so your time starts now.
Yes. Good afternoon, respected dignitaries. So today my presentation of case series is on dry needling for the hamstring trigger points. So as an introduction, it is mainly in the recreational footballers. In football players, it has been found that there are chances of high risk of injuries which affect the team performance, and it is found that at professional level, in average, at least 1 or 2 injuries are happening per session while they are practicing or while they are playing, which occurs during the game. The most common injuries which are occurring in the football players is the hamstring strain followed by the sprain. And it has been found that, or it is found that in the football players, we can consider the football players as the any kind of that is recreational football players. The lower limb injuries are common, which contributes 67.7% of total injuries. And if we are going in the specification, then specifically in the lower limb, the common sites are thigh, knee, and the lower leg. So dry needling is popular technique for the muscular pain and the associated dysfunction. Dry needling is a useful treatment of various musculoskeletal conditions, specifically for improvement of the functional ability. So because of the dry needling, there will be breaking of the, or because of the dry needling, the reflexive disruption of the taut muscular bands of trigger point, and there is breaking of the taut muscular band, and there will be allowance of normalization of the range of motion, as it is much required in the football players, as it is much required to have the good range of motion at the knee, and muscle should work in fine way. So because of that, it is much helpful, the dry needling is much helpful for the release of the muscle, for normalization of the range. Lot of literature is available about the physiological effects of the dry needling and effects on the muscular physiology. As it is in the literature, it is proven that after receiving the twitch response while doing the dry needling, and after receiving the twitch response, it is much effective in the cases of the trigger point. But the effect of dry needling on the sports performance are relatively unexplored. So this is the origin of my study, or this is the origin of my study, that's in the sports performance it is unexplored. So let's coming down to my aim is to evaluate the effectiveness of dry needling for hamstring trigger points and its effect on the agility and the pain threshold on the trigger point. So methodology, this series of 4 case studies explore the effects of dry needling on trigger point pain and agility of recreational football players. The trigger point and pain threshold for the hamstring muscle was assessed by the pressure algometer, and dry needling was performed. After assessing the pressure algometer, the dry needling was performed on the trigger points of the hamstring muscle on which the athletes were complaining of pain. Trigger point was released by the dry needling for 30 seconds, and before and after the pressure algometric measurements and the Illinois agility test was achieved, and after dry needling, after 30 second of dry needling on the trigger point of hamstring. Again, the assessment was done for the pain threshold and the illness agility test. So this is the pain threshold assessment by using the pressure algometer, as the position will be in the prone and there will be assessment for the pressure, pain pressure threshold. Then this is the illness agility test for the person, for the athlete who came with the pain, and this will be the dry needling technique for the hamstring trigger point. So the maximum point where the patient or the injured athlete is having pain, that was taken, and then the dry needling for the 30 seconds was performed. Now as a result, on average the pain threshold, as it is case of 4 recreational footballers, on average the pain threshold was improved from 2.5 kgs to 3.3 kgs, and the performance on the agility test improved from the 22.02 seconds on an average to 18.74 seconds as per the scoring criteria of the LNS test. Now coming down to the conclusion, so my study, my case series after intervention, it is having conclusion that from the finding of this case, we can see the dry needling is effective in improving the agility of the athletes and reduction in the pain due to which is caused due to the trigger point on the hamstring. Now, recommendation: further studies needs to be conducted with the scientific rigor to explore the true efficacy of dry needling on a larger population for the different conditions. So, thank you. Yes, so that was my conclusion, and my number is ICK 13. Thank you.
You are commenting on physiological parameters, whereas
yes, sir,
you have worked on anatomical changes, because your criteria for selection was trigger points which you could palpate.
Yes, sir.
Yes. So, and
Yes,
you're
sir.
commenting on physiological. So that is how I feel something that the outcome measure, if it was chosen, where you could see or quantify the anatomical changes also.
Okay, sir.
Then
Yes, sir.
there was a possibility that there is the effect that you have caused with dry needling has led to these anatomical changes, which were noted before starting the treatment, and there was change after treatment.
Okay, sir. Yes.
Yes. Thank you.
Yes. Thank you, sir.
Thank you so much. We move on to the next presenter. Presenter number 14. Presenter number 14. Presenter number 14, are you there? Presenter number 14. Okay, let's move on to the next. Presenter number 15.
Yes, ma'am.
Yeah. You can start your screen.
Ma'am, is it visible?
Yes, it is visible.
Ma'am, can I start?
Just a minute. Yeah, you can start now.
Good afternoon, everyone. My presentation topic is perception of patients about the telerehabilitation during the time of pandemic. So in the introduction, tele-rehabilitation is the ability to provide a distance service support through evaluation and intervention to persons who are disabled through the medium of internet. So successful rehabilitation depends on the severity of the condition, the rehabilitation team skills, and the cooperation of the patients and their families. So the patient's perception of care of quality refers to the patient's view of the services received and the result of the treatment, and should be monitored to assess the delivery and the quality of the healthcare. So in today's times, when the whole world is in the attack of COVID, patients with neurological dysfunctions who need long-term rehabilitation are deprived of the physiotherapy in this COVID era. So these patient groups could benefit from the system that allows a health professional to provide support through distances. So providing a high quality care and at the same time ensuring the satisfaction of the patient is a challenge the healthcare organization usually face. So this study was conducted to understand the patient's perception about the telerehabilitation to ensure the quality of care. So the aim of my study was to determine the perception of patients about the telerehabilitation during the times of pandemic. So in the methodology, the study was a descriptive study conducted in the neurophysiotherapy OPD. Total 30 patients were included in the study who came for regular physiotherapy treatment. All the patients were given a demonstration session in the first session, which was followed by a follow-up session after 15 days, where the patient had to perform all the exercises shown in the demonstration session. So the total duration of the session was 45 minutes, and the patient could contact the therapist between the demonstration session and the follow-up session in case if the patient had any difficulty. And at the end of the 3-month session, an interview session was conducted to know the perception of the patient about the telerehabilitation. So in the questionnaire, the questions that were asked to the patient were, is the telerehabilitation on the virtual platform helpful to the patient during the lockdown period? Does the telerehabilitation improve the condition of the patient? How much exercises does the patient understand shown during the telerehabilitation session? And does the telerehabilitation session meet with the expectations of the patient? If it meets, then what are the benefits that the patient saw during the telerehabilitation? What difficulties did the patient face during the telerehabilitation session? How would the patient comment on the duration of the telerehabilitation session? And would the patient like to replace the OPD visit with the telerehabilitation and the home exercise session? And then at the last, the patient was asked to rate the therapist interaction with the patient on a scale of 0 to 10. So the result of the study showed that about 80% of the patients said that they understood the exercise session. They understood the exercises had beneficial effects and were satisfied with the duration and the frequency of the telerehabilitation. 66% of the patients reported that they would like to continue telerehabilitation post-lockdown, and 40% of the patients reported that they faced difficulty due to the network issues during the telerehabilitation, and most of the patients reported that telerehabilitation was economical and reduced the cost of transportation. So in the conclusion, it can be concluded that telerehabilitation is a beneficial way of rehabilitation and can be practiced on a regular basis as a way of rehabilitation based on the patient's view. Thank you.
Thank you so much. Any questions? Any questions, sir?
What method this for this questionnaire set of questionnaire?
Sorry, sir.
Were this set of questions validated?
Yes, sir. So the inter-rater reliability was found out to be 0.89, and the internal consistency coefficient used was 0.81.
Okay, thank you.
Thank you, sir.
Any more questions? Okay. We shall move on to the next presenter, presenter number 16. Presenter number 16.
Yes, yes, ma'am.
Yeah, share your screen. Your time starts now. Start.
Yes, good afternoon, one and all. So my study topic is trunk muscle activation in initial 10-degree abduction of the shoulder in erect sitting position in patients with spinal cord injury. So the introduction, spinal cord injury is a traumatic event with loss of sense and the movement of the body part below the level of lesion. So spinal cord injury affects the normal sensory, motor or autonomic function, and so ultimately impacts the patient's physical, psychological, as well as social well-being. So the primary goal in spinal cord injury patients is the control of upper body muscles in the sitting position, because the below the level of lesion, all the muscles get affected. In India, approximately 1.5 million people live with the spinal cord injury, and there are several studies which have used surface EMG to check the trunk muscle activation. The reliability of surface EMG is 0.86 to 0.99. Analysis of recruitment of muscle fiber during the contraction is measured by the root mean square value of the EMG. So the trunk muscle synergies help to improve the functional independence of the paraplegics, that is spinal cord injury patients. So the aim of this study was to measure the trunk muscle activation at the 10-degree abduction of the shoulder in erect sitting position in patients with spinal cord injury. And the objectives of the study were to measure the trunk muscle activation from the dominant as well as non-dominant side at the 10-degree abduction. And second objective was to compare the trunk muscle activation between the males and the females. So the methodology study design was observational study. Study setting was Department of Neurophysiotherapy. Study population was spinal cord injury patients. Sample size was 21, and the sampling technique was purposive sampling technique. Inclusion criteria and exclusion criteria for the participants. Inclusion criteria: patients diagnosed with the traumatic spinal cord injury, and the patients having static sitting balance for minimum of 20 seconds. Exclusion criteria were age more than or equal to 60 years, subjects who were not willing to participate, subjects having other neurological disorders and other comorbid conditions. So the recruitment was done while giving the information about the study to the participants. Then screening was done according to the inclusion criteria. Informed consent was obtained from the patients mostly in the written format. Then after that, demographic data and Asia score of all the participants were obtained. So participants who were participated in this study were asked to sit on a chair, height adjustable chair, where participants should have 90 degree hip flexion and the knee flexion, and foot should be fully supported on the floor. And after that, the electrode placement of the surface EMG was done on the 1 by 1 muscle. So the electrode placement for erector spinae was 2.5 centimeter lateral to the spinous process of T3, T9, and L3. So at the 3 levels of erector spinae, the RMS value was recorded. Then oblique external abdominis muscle, that is OA, the bulkiest part of muscle belly was used for the electrode placement. Then the latissimus dorsi, 3.5 centimeter quadrilateral to the inferior angle of scapula. Trapezius, that is upper part of the trapezius muscle, bulkiest part of the muscle belly. Then serratus anterior on the muscle part originating from the 5th rib. Then pectoralis major, middle of the cranial part of pars sternocostalis. So these are showing the electrode placement of the muscle. Figure A represents the placement for the upper trapezius. Then B represents the erector spinae at T3 level. C represents the erector spinae at L3 level. D represents a latissimus dorsi placement. E represents the placement for the pectoralis major. And F represents the serratus anterior. So before applying the electrode, the skin was cleaned with the sterlia where the electrodes to be placed. And then RMS value for all the muscles were recorded for each activity, that is 10-degree abduction of the shoulder. 3 trials were taken and the mean value of 3 trials were documented for the results. So the results were analyzed and a non-parametric test, that is Wilcoxon match pair test, was used for the comparison between males and the females. So table 2 represents mean and standard deviation of the demographic data of spinal cord injury subjects. Age represented in the years. Mean age was 37.33 plus or minus 81. Gender, male to female ratio, where 14 were male and 7 were females. Dominant hand, most of the participants had right hand dominant. That is, the ratio right to left was 20:1. And the level of injury, T6, 1 participant, T8, 1 participant, T9, 2 participants were having T9 injury. Then T10, 2, T11, 1, T12, 7, L1, 3, and L2, 4 participants. So the first graph represents the depiction of RMS value of dominant as well as non-dominant side trunk muscles at the 10-degree abduction of the shoulder in erect sitting position in the spinal cord injury patients. So in this diagram, we can see that the highest activation from both the sides, that is the dominant as well as non-dominant side, was seen in the latissimus dorsi, serratus anterior, and pectoralis major muscle. When we check for the dominant differently and the non-dominant side differently, we can see that on the dominant side, which is the right side, represented by the red mark, the most activated muscle was serratus anterior, and after that the activated muscle was latissimus dorsi and pectoralis major, and the least activated muscle was oblique abdominal muscle. While on the non-dominant side, the highest activation was seen in the pectoralis major and the upper trapezius muscle. Then graph 2 represents the comparison of trunk muscle activation between the males and the females of dominant side at the shoulder abduction in patients with spinal cord injury. Here we can see that there are equal distribution, that is 4 muscles have shown the more activation in the males and the 4 muscles have shown the more activation in the females. So the more activation in the males was seen in the erector spinae at T9 level, then oblique abdominal muscle, pectoralis major muscle, and erector spinae at T3 level. While graph 3 represents the comparison of trunk muscle activation between the male and female on non-dominant side, where the females have shown more activation at the trapezius, erector spinae, latissimus dorsi, and the oblique abdominal muscle. So in the discussion, the main objective of study was described for the EMG recruitment, and majority of the muscle were studied where the latissimus dorsi, serratus anterior, and pectoralis major have shown greater activity. So there we have seen that the non-postural muscles have played more role in the activity of the sitting balance. So the higher study was done by the Wang YJ in 2016, where higher muscular demand was seen in high-level SCI people because of lack of strength in erector spinae and multifidus muscle, which is a cause for use of non-postural muscle. But another study said that so these are the limitations where small sample size was present due to, and also the comparison between the level of lesion was not there. And the study concluded that non-postural muscles which were used in the SCI were latissimus dorsi, serratus anterior, pectoralis major, and OA. So this is a significance that these muscles should be trained in the rehabilitation of the spinal cord injury patients. These are the references. Thank you.
Thank you so much. Any questions from the judges?
No. No questions, madam.
Thank you.
Thank you. We shall move on to the next presenter, presenter number 17.
Yes.
Your
Good
time
afternoon,
starts
everyone.
now.
Am I audible?
Yes. Your time
Good
starts
afternoon,
now.
everyone. Today's my topic of presentation is behavior of edge reflex in the individuals with spinal cord injury over a period of time. It is an observational study. So the content of this study is the introduction, aim, methodology, result, discussion, conclusion, and references. So in introduction, spinal cord injury. What is spinal cord injury? It is an insult to the spinal cord which causes loss of motor activity and sensations below the level of injury. So the incidences of spinal cord injury have been recorded that 13 individuals per million to 163 individuals per million have been affected every year worldwide, globally. As we all know, it is a devastating injury. So the functional recovery is the main, like the patients with spinal cord injury needs to be functionally recovered to perform their daily activity and to improve the quality of life. So by the 3 month of injury, the functional recovery starts and it reaches to a plateau by the period of 9 months of injury. And more of injury may, like recovery may occur to 12 to 18 months post injury. So here it reflects, it is a monosynaptic reflex activity which measures like monosynaptic activity, and it provides a spinal cord neuromodulatory process, a window towards it. Like we can get a gross idea whether the monosynaptic activity is, how does it affect the personal functional activity. So P. et al. Conducted a study where he concluded that the alteration in spinal reflexes activity in SCI individuals, which depends upon the severity of the SCI, but not the level of the SCI. So these findings can contribute to a better understanding of spinal reflexes excitability regulation and could serve as the electrophysiological measures of therapeutic intervention. So the aim of the study was to observe the reflexive changes in individuals with spinal cord injury at 3, 6, and 9 months of post-injury. So the methodology, the study design, it is an observational study. The study sample, it included the 10 SCI sample who was, like the level of injury was thoracic level. And the outcome measure that was used was the edge reflex amplitude. 10 edge reflex amplitude was elicited from the patients. And the sampling technique was purposive sampling technique. So the inclusion and the exclusion criteria. The inclusion criteria was the participants between age of 18 to 60 years were included into the study. The etiology of trauma, vascular or the orthopedic pathology was included, and the individuals taking the physiotherapy treatment on daily basis. The exclusion criteria was the patient with any other neurological or the psychological like disorder was excluded from the study, and the participants who were not willing to participate. So the procedure, the participants were in prone lying position and the area was clean with the spirit to avoid the hair resistance, and the test soles edge reflex were elicited from the right leg at 3rd, 6th, and 9th month of injury. So the electrode placement was done according to the standardized method, and then the reflex was elicited. The statistical analysis, the descriptive statistics was obtained, and the normality of the data was checked using the KS normality test, and the within comparison was done by Friedman's test, and post-hoc analysis was done by using Dunn's multiple comparison test. So in result, so this table depicts the general characteristics of the participants. So the age in years, it was the mean and the standard deviation, the 31 plus or minus 5.03. The gender, the sex were male and 4 were female in the study. The level of injury, like the T5, 1 participant was there, T6 level 2 participant was there, T11 level 4 participants were there, and T12 level 3 participants were there. And accordingly, Asia grade was also taken, where Asia grade A, we have 5 participants, grade B, it was 3, and C, it was 2. So as I said before, the H reflex was elicited. So this is the graph which represents the x-axis is the month of the timeline where the H reflex is elicited, and the y-axis depicts the amplitude of the H reflex, which is in millivolt. So here we can see that the reflexive changes that has occurred over the period of time, like The amplitude has increased gradually at 3rd, 6th, and 9th month, where the mean and the SD at 3 months was 0.41 plus or minus 0.14. It increased to 1.68 plus or minus 2.94, and gradually at the post 9 month of injury, it was 2.97 plus or minus 3.62. So we got the significant improvement that the p-value was less than 0.001, and here, hence it was proved that the reflexive changes, like the amplitude that of H reflex increased gradually. So in discussion, as we all know, spinal cord injury leads to the depressed activity of the below the level of injury, and as soon as the patient is landed up with the spinal cord injury, like insult to the spinal cord, it results to a spinal shock. The spinal shock, it can last from days to several weeks. So the typical symptoms for like spinal shock is areflexia, and the system is depressed. Like there is no bladder and bowel control below level of injury. And the first sign that the patient is out of spinal shock is that the spasticity, like the presence of spasticity, the initiation, the muscle tone changes are seen. As well as there is the reflexive changes that the bulbocavernous reflex also appears. So during spinal shock, many electrophysiological studies vindicate supraspinal segmental inhibition, which results of presynaptic inhibition and block monosynaptic and synaptic reflex arc. So by that time, the spinal neuron gradually regains their excitability over the period of time. It could be the mechanism could be the neuroplasticity, where the neural organization within the spinal cord occurs, and it leads to the improved excitability, or the reflexive changes are seen over the period of time. So the conclusion of my study was the present finding of the study reveals that there is a gradual increase in H reflex amplitude in individuals post-injury. Therefore, the spinal neuron gradually regains the excitability, and recovery takes place over the period of time. So these were the references. Thank you.
Thank you so much. Any questions? Any questions from the judges?
No questions.
Okay. We shall begin with the next presenter, presenter number 18. Presenter number 18. Presenter number 18.
Hello. Hello. Can you hear me?
Yes, sir, we can hear you.
Yes, yes.
Please share your screen.
Yes.
Okay, sir, you can start now. Your time starts now.
Yes. Good afternoon, everyone. My topic is challenges and opportunities for breast cancer survivorship care in India during COVID-19 pandemic, a systematic review. COVID-19 is globally the largest and deadliest pandemic of 21st century. India is facing worst pandemics since post-independence. The COVID-19 pandemic has adversely affected the world. This pandemic has resulted in disruption of the day-to-day life of all the cancer survivors. In current situation, anyone can get COVID-19. People already having cancer and cancer survivors may be at greater risk of health complications because of cancer and cancer-related treatments can attribute to weakened immune systems. Many healthcare organizations from the past several decades helping the breast cancer survivors, a mainstream effort of healthcare system is to provide care for all the pandemic. The healthcare system is not fully prepared to deliver appropriate and quality care to non-COVID patients. The structural barriers to care are result in pitiable conditions, particularly for survivors living in rural area. So in this study, there are some selected COVID-19 Indian resources are available for cancer patients, survivors, and healthcare providers. So these are e-content which are available, such as central and state government agencies, Government of India, Ministry of Health and Family Welfare, National Program for Prevention and Control of Cancer in Diabetes Cardiovascular Diseases, National Cancer Control Program, National Institute of Cancer Prevention. So these are the central and state government run agencies, and some trust and non-government agencies such as Tata Trust, Indian Cancer Society, Cancer Aid and Research Foundations. So these are the list of some of the non-governmental organizations who are having the resources, e-content and telemedicine facilities for cancer survivors, which is available in our country. Need for the study. In this current scenario, the limited evidence regarding the impact of COVID-19 on cancer survivors. As this pandemic continues, the scientific evidence are expected regarding more specific recommendations and guidelines for survivorship care. Immediate effects are required to addressing the needs of breast cancer survivors at the present time. The development and implementation of policies for survivorship care, it is essential to implement interventions and policy for breast cancer survivors to mitigate the effects of this pandemic. In this study, systematic review, the current guidelines, standard operating procedures, healthcare policies by Indian central government, state public health departments, non-governmental organizations, cancer treatment and research centers were analyzed by data abstraction sheet. The following main concerns of breast cancer survivors were considered. These concerns are mainly associated with survivorship care, and if neglected due to COVID-19 pandemic can cause significant downward spiral, reducing physical functioning and worsening the symptoms related to fatigue, which increase the risk of developing other diseases and reduce life expectancy of this vulnerable population. So the current status of healthcare resources, opportunities for healthcare system, and challenges faced by breast cancer survivors were analyzed. So first question of this systematic review is what is the impact of COVID-19 pandemic on general health of breast cancer survivors? So after reviewing our data, COVID-19 gravely affects the older and persons with pre-existing comorbidities, including cancer, and may be at higher risk for serious and life-threatening medical complications. So all the breast cancer survivors who are taking treatment or are survivors are at higher risk than the general population. So these are the physiological changes in the breast cancer survivors which can lead to the decrease in physical functioning, decreased immune function. So is a list: decrease in muscle mass, decreased muscle strength, power, decreased pulmonary function, cardiac function, decreased bone health, decreased immune function. So these are some of the physiological changes in breast cancer survivors due to inactivity. And this will again worsen their functional status. Second question that we analyze is what are the specific health needs for breast cancer survivors to stay healthy? So the implementation of high quality survivorship care can be challenging, including services of multi-speciality and multidisciplinary healthcare professionals with necessary expertise. Allocation of high quality patient-centered care is continuously required for elimination of healthcare disparities in breast cancer survivors. So these are the health needs. So this table includes the health needs of breast cancer survivors to stay healthy: regular follow-up and medical checkup, availability and life-saving drugs like antihypertensive, antiplatelets, availability of beds in case of health emergency, access to multi-speciality, multidisciplinary healthcare professionals, regular involvement in breast cancer support group, availability of recommended diet, regular follow-up with physiotherapists, access to facilities of exercise and physical fitness, access to meditation and yoga facilities. So these are the specific health needs. All these health needs are adversely affected due to lockdown and pandemic situation. third question that we analyzed, what are the physical and psychological challenges for breast cancer survivors during COVID-19 pandemic? The physical and psychological challenges for breast cancer survivors are illustrated in this table. These are the depression, physical symptoms such as fatigue, insomnia, the body's image disruption, treatment-related anxieties, depression, existed concern regarding mortality, impaired sexual functioning, and musculoskeletal problems, general legs pain, arthralgia, myalgia, lymphedema, neuropathy, skin rash, or weight problems, weight gain, arm problems, decreased range of motion, arm swelling. So these are the physical and psychological challenges for breast cancer survivors during this pandemic. Fourth question, we analyze what resources are available to address the concerns of breast cancer survivors during this pandemic. So we have got limited resources, and e-contents and tele facilities are available for the financially strong and urban people. And there is again problem for rural people. The need of the hour is utilization of available resources. So opportunity, what opportunities we all have during COVID-19 pandemic, that resources must be made available to address the concerns of breast cancer survivors during COVID-19 pandemic. So breast cancer support group in district hospital is the opportunity. Appointment of coordinators such as primary health care center, telephone, mobile helpline, telemedicine options, development of community-based cancer survivorship model. So this is very important. Development of community-based cancer survivorship model. Remote monitoring of patient-reported outcomes, use of information and communication technology. So this will again enhance the cancer survivorship care. If you are addressing all these opportunities, you are focusing and working on this, definitely
1 minute,
will
sir.
help in improving survivorship care. So COVID-19 has almost totally affected all the horizons of survivorship care, and we are finding out the opportunities which are available to improve the survivorship care. So let's join organized community-based cancer survivorship model to address challenges of survivorship care to ensure that no breast cancer survivor is lost in transition. So this is the conclusion. So all these findings will help us to tackle with the adverse situation during and after COVID-19 era, and breast cancer survivors face the challenge during the pre-COVID era. So these are the conclusions of our study. These are my references. Thank you.
Thank you, sir. Any questions from the judges? Any questions from the judges?
No questions.
Okay, sir. We shall move to the next presenter, presenter number 1. Presenter number 1. Presenter number 1, Dr. Kiran, last call for you. Are you there? Presenter number 1. Please stop the screen share. Presenter number 18, please stop the screen share.
Ma'am, you have not yet logged in, ma'am. We'll take the next presenter. You'll be logged in till that time. We don't have time.
Presenter number 4. Presenter number 4. Last call for presenter number 4.
Must be arranged for the market. People is there.
Presenter number 4. We'll move on to the next presenter, presenter number 5. Presenter number 5.
Yes, ma'am.
You can start your screen share, madam.
Yes, ma'am. Yes, ma'am, it is visible.
Yes.
Good afternoon. Can I
Your
start?
time starts now. Start.
Good afternoon, everyone. Today's my topic for presentation is effectiveness of Swiss ball exercises versus conventional back exercises with low back pain in multiparous women. The introduction: back pain is very common human phenomenon. A prize mankind has to pay their straight posture. According to the research, almost 80% of individuals will experience back pain at some time during their life. Low back pain can inhibit an individual from leading an active lifestyle. This is because the back becomes conditioning through the lack of use, cumulative effect of repetitive minor injuries, and natural processes of aging. So fortunately, in 70% of these, it subsides within a month, but it is as many as 70% of these in women, pain recurs. For women younger than 45 years, low back pain represents the most common cause of disability than in person age older than 45 years. The core muscle strengthening exercises has had been promoted as a protective regime, as a form of rehabilitation, as a performances improving program for various lumbar spine and musculoskeletal injuries. A multiparous woman. Multiparous woman has given birth more than once in a woman after the childbirth started the low back pain. The Swiss ball exercises can improve the muscle strength and endurance. Training with Swiss ball can help improving back pain and preventing pain in the futures. So as the muscle groups, tone, strength and endurance are improved, as the flexibility and the balance will improve. So aim of my study to study the effectiveness of Swiss ball exercises versus conventional back exercises for low back pain in the multiparous woman. So need for study, low back pain is more common in women, mostly it is more common in multiparous women because the physical changes after the childbirth. In multiparous women, muscle weakness, muscle instability, alignment of body structure changes after the pregnancy, after the delivery of the baby. So there is a need to study Swiss ball exercises and conventional back exercises in low back pain with multiparous women. Objectives to study the effectiveness of conventional back exercises in multiparous women with low back pain, to study the effectiveness of Swiss ball exercises in multiparous women with low back pain, and to compare the effect of conventional back exercises versus Swiss ball exercises in multiparous women with low back pain. The source of data, it is community department, Krishna College of Physiotherapy, Karad. Type of study, it is a comparative experimental study. Sampling method is randomization sampling. Sample size is 30. Duration of study is 5 months. So inclusion criteria for my study: the female participants willing to participate in the study, age group between 30 to 50 years, patient diagnosed with clinically low backache with multiparous women. Exclusion criteria for this study is subject under analgesics, spinal or disc pathologies, patient with specific low back pain. The outcome measure being used, that is visual analog scale. The VAS scale is a valid subjective measure for acute and chronic pain. Score are recommended by making a handwritten mark on 10 centimeter line that represents a continue between no pain, and 0 is no pain and 10 represents a worst pain. The second outcome measure is modified accessory low back pain disability questionnaire. In this questionnaire has been designed to give your therapist information as to how your back pain has affected your ability to manage in everyday life. The procedure of study: the subject diagnosed with low back pain, volunteered participate in the study were selected as a subject. Each of the subjects were screened as per the inclusion and exclusion criteria, and they were briefly divided into two groups. The total number is 30 subjects. They are divided into randomization sampling method. In group A, the study done with 15 subjects, and group B, 15 subjects. The exercises are given for 4 weeks. The group A is treated with conventional back exercises, and group B is treated with Swiss ball exercises. The pre-treatment outcome measure for pain intensity and functional disability was done with visual analog scale and modified oscillatory disability questionnaire score. The result of my study: the pre-interventional visual analog scale score for group A was 7.6, whereas the post-interventional score for visual analog scale is 4. The pre-interventional score for group B was 7.6, whereas the post-interventional score was 1.8. The pre-interventional modified obstetric disability questionnaire score for group A is 55.6, whereas post-intervention the score was 22. So in pre-intervention modified obstetric disability questionnaire score group for B was 51.8, and post-intervention the score was 66. So thus from the above studies it is concluded that patient of group B showed faster and significant improvement as compared to the group A. Discussion: low backache is considered the third highest problem faced by the population worldwide. Since there is a change in the lifestyle due to competing professions, people tend to ignore their spine health. Lack of self-care and awareness of the exercises has given a rise to this population. Thus, intervention in an order to relieve the pain was made, as well as strengthening of the muscle are also done with exercises. Conclusion: present study concludes that significant relief of pain in group A and group B, but the group B was faster relief of pain and significant clinical statistical improvement, and also disability score was improved, and thus the facilitating the outcomes. The limitation of my study is older age group could not be involved. Only one condition is evaluated and lack of time. Suggestions: the study should be conducted with large number of sample, larger area of study. Study should be conducted with objective scales for pain and functional disability. Can be done on specific acute low back pain patients. These are my references. Thank you.
Thank you so much, madam. Any questions from the judges? Any questions?
No questions. No questions.
Thank you, sir. Is presenter number 1 here? Presenter number 1?
Yes, yes.
Please, you're audible.
Hello.
You're
Yes,
audible.
am I audible?
Yes, please share your screen, madam.
Yes, I am. You cannot start share while the other participant is sharing.
Just a
It is
minute.
coming later.
Presenter number 5, please stop your screen share. Presenter number 5. Try it, madam, now. It shall.
Yes, ma'am. Can you see it? Can you see the screen?
Yes, we can see, madam.
Yeah. The topic of my presentation is comparison of muscle energy technique and passive sleeper stretch. In glenohumeral internal rotation, range of motion in badminton, players between 18 to 30 years of age with glenohumeral internal rotation deficit are randomized control trial. Introduction: joint is a axial ball and joint. This joint has a large range of motion compared with all other joints. The range of motion is achieved at the expense of articular congruency, which is compensated by a complex system of static and dynamic soft tissue. It has been proven that a single application of MET for glenohumeral joint horizontal abductors in baseball players resulted in increased glenohumeral horizontal adduction and internal rotation range of motion. Need of study: there is smashing or throwing activity in overhead sports, which puts undue stress on the shoulder. Badminton is one such sport which requires considerable over shoulder movement with shoulder in abduction and external rotation. With shoulder in abduction and external range of motion. The extreme demands of overhead activity results in altered glenohumeral joint mobility and flexibility. These have been linked to adaptive structural changes to the joint, which are posterior shoulder tightness and altered glenohumeral joint range of motion. The aim of my study is to compare the effect of muscle energy technique and passive slipper stretch on glenohumeral internal rotation range of motion in badminton players between 18 to 30 years of age with glenohumeral rotation deficit. Primary objective was to compare the effect of MET technique and passive slipper stretch on glenohumeral internal rotation glenohumeral internal rotation deficit after 2 weeks of intervention. Secondary objective was to study the effect of MET on glenohumeral internal rotation range of motion and effect of passive slipper stretch on glenohumeral internal range of motion. Research question is there any difference in the effect of MET and passive slipper stretch on glenohumeral internal rotation range of motion in badminton players with glenohumeral internal rotation deficit? Study design was a randomized controlled trial. Badminton club players were taken between the age group of 18 to 30 years of age, and 64 was the sample size. Glenohumeral internal rotation was the outcome measure. Inclusion criteria was more than or equal to 10 degrees of glenohumeral internal rotation deficit of the dominant shoulder with complete external rotation range of motion. Regular practice of badminton sport more than at least 1 year. Badminton players between 18 to 30 years of age, both the genders. Exclusion criteria: injury and past surgery, surgical history of shoulder symptoms requiring medical treatment in the last 1 year, shoulder pain at the time of study. Intervention: 2 groups were taken. Group A was MET and group 2 was passive slipper stretch. MET to the glenohumeral joint external rotators were given. Position was supine line with shoulder and elbow 90 degrees abduction and flexion respectively. Post isometric relaxation technique was used. The examiner passively moved the humerus into external rotation until first barrier of motion was reached. The subject was then instructed to perform 7 seconds of isometric contraction with 25 maximum effort in the direction of external rotation against the force provided by the examiner, and this was followed by 30 seconds of active assisted stretch. Subject was then instructed to relax and a new movement barrier was then engaged to the examiner. 3 repetitions in sets each session with 4 such sessions in a week on alternate days for 2 weeks were performed. Group B was given passive slipper stretch to the dominant glenohumeral joint. Position was sideline on the dominant hand with shoulder and elbow in 90 degrees of flexion with lateral border of scapula positioned firmly against the treatment table. Examiner passively internally rotated subject's shoulder by grasping the distal forearm and moving the arm towards the treatment table. Stretch was held constant at the end range of motion for 30 seconds by examiner and then repeated with 30 seconds rest between stretching episodes. 3 repetitions in each session and 4 such sessions in a week on alternate days for 2 weeks were performed. Subjects were assessed for glenohumeral internal range of motion at the end of first and second week. Data was analyzed in statistical software. Within group comparison of pre and post intervention changes in range of motion was compared with paired t-test between the group was compared using unpaired t-test. Repeated measured ANOVA was performed to account for comparison between observations on the same person at different points of time. P-value less than 0.5 was considered significant. Variables were independent variables MET, passive slipper stretch, and dependent variables were glenohumeral internal rotation of motion. This is the graphical representation showing subjects in two groups according to age. Then this is the distribution of subjects in two groups by gender, female and male. Then this is the comparison of pre-intervention graphical representation showing pre-intervention and post-intervention. Pre-intervention, the value is 5.75 and second week it is 71.75, which means it is showing a significant difference, improvement in the range. Then this is a graphical representation showing comparison of pre-intervention to post-intervention, mean value of internal rotation in sleepers stretch group, group 2. The pre-intervention value was 60.28, which improved to 69.09 in the at the end of the intervention second week. This is the internal rotation range of motion, sleeper stage. Pre-intervention, the value was 60.28 first week. After intervention, first week it was 64.44, and at the end of second week it was 68.78. So it shows a gradual improvement in range of motion. This is the comparison between group A and group B, which is the primary objective of the study. Group A MET and group B sleeper stretch, which shows that MET has a significant more improvement than passive sleeper stretch. Now the discussion is a comparative study was done between 18 to 30 years of group, which shows that effectiveness of MET and passive sleeper stretch post 2 weeks of intervention.
Last 1 minute,
study,
madam.
Internal rotation. Yeah, it shows that MET has a significant improvement in internal rotation than the stretch. So this very significant improvement in glenohumeral flexibility after sleeper stretch and a scapular stabilization, and the MET was attributed to inhibiting Golgi tendon reflex. This reflex is believed to be activated during isometric contraction of muscle. Thus, the conclusion of the study is that MET and passive sleeper stretch improve glenohumeral internal rotation, but MET proves to be more beneficial than passive sleeper stretch. Limitation is follow-up was difficult and use of treatment intervention in asymptomatic badminton players could not be done. Strength is individual participants did not had any discomfort, and it was convenient for the same setup. Thank you. Yeah, thank you.
Any questions from the judges? Any questions?
No questions.
Thank you, sir. With this, we end our scientific paper presentation. For the scientific paper presentation, Dr. Basavraj Motimat and Dr. Shridas and Dr. Suraj Kanse for judging the session. Now we shall move on to the next session of our presentations. Our next session, I request the presenter to please mute. Before starting with the afternoon session, I request the scientific paper presentation members to please log out of the panelists so that we can begin. Thank you so much. So here we are with the afternoon session of the presentation of arthritic knee. We have with us Dr. Sunny Google, the national speaker, and Dr. Brad, the international speaker. Welcome to you both. We shall begin with the medical aspect first, followed by the physiotherapy aspect. So I request Dr. Sunny Google, who is a consultant orthoplasty and orthoscopy surgeon, specialist knee surgeon in Sancheti Institute for Orthopaedic and Rehabilitation, Pune, to start with his session. Can you unmute yourself, sir?
Yeah, thank you. Thank you, Drupti, for a kind introduction. And it's a wonderful podium where I'll be presenting few of my thoughts, and really nice to see the gathering here in today afternoon post lunch session. I'll just quickly share my presentation. Yeah. Is it visible properly? Yes. Yeah. So I'm really happy to be back to my alma mater, and I really have nostalgic moments now, and really getting goosebumps to be to my back to my college where I studied my graduation MBBS from at Krishna Institute of Medical Sciences, Karad, and it's a proud thing for me to be presenting some of my work that we are doing in front of this august audience. So I'll be speaking on arthritic knee advances in the recent times. And as Shruti said, I am being practicing knee surgery at Sancheti Hospital for last 10 years. And it's really a proud moment for me right now. So recently we concluded the World Arthritis Day, which was on 12th of October. And this day is a very special day in the terms that the World Arthritic Foundation takes efforts to evaluate what they have done in the past 1 year, and really aims and targets newer and newer ways to reach to people and get a theme and start with the treatment parts for arthritic patients. So this year's theme was "Don't delay, connect today." So whoever have arthritis should not hide themselves, rather come in front, open up with the doctors, and get yourself sorted out. So as all we know, osteoarthritis is a degenerative joint disease, and it's very common in the developing countries because of the lifestyle. It is very common cause of disability and also adds to a lot of morbidity to the patients. In India, the prevalence, as per the Lancet study, was around 5.5% in the urban population and in 3.3% in the rural population. That's really high for the Indian population that we have. So in shortly, to go through the pathogenesis, the osteoarthritis is a condition where the normal articular cartilage of the knee joint shows wear and tear signs, and then it's like a mixture of enzymatic destruction with mechanical degradation of the articular cartilage. And as we know, this all the inflammatory cascades begins, and the synovial hypertrophies, it erodes the articular cartilage, first the superficial layers, then the deeper layers, and the bone is exposed. So this is a process of mechanical degradation with enzymatic degradation, and ultimately it lands up with a severe advanced arthritis. This gradual destruction of the articular cartilage takes place over in stage-wise fashion. So it's not that every person will land up with an advanced arthritis on day one itself. He should have had some symptoms in the past, and this is how the grading of the staging of arthritis is there. Stage 1, we say that it's minimal changes. Stage 2, minor to moderate changes. Stage 3 is like there is erosion of the cartilage in focal areas, and stage 4 is global erosion of the cartilage. So this progressive joint arthritis, as we can see in this X-rays, has progressed in the same patient from stage 1, where it relatively appear as a normal knee X-ray, to minor thinning of the joint space, to formation of osteophytes, and decrease significant degrees of joint space, to an obvious valgus deformity with complete erosion of the lateral condyle. And this is the picture of the patient, which shows that the normal articular cartilage, healthy cartilage, which looks shining and glistening, turns out to be a rough and eroded one. And this picture denotes the arthroscopic image of the articular cartilage, which showing gross destruction. So histological changes are depicted in this slide, which shows that the normal articular cartilage shows erosions and infiltration of the polymorphonuclear cells and inflammatory cells into the cartilage substance, and which leads to further erosion and weakness of the deeper layers of the cartilage. So in order to classify the ONE on an X-ray, we all are aware of the Skelegren and Lawrence classification, which grades the knee in 4 grades, which is grade 1, which is doubtful, relatively normal X-ray; grade 2, which is minimal, shows mild to moderate joint space narrowing; with grade 3 being more than 50% of the joint space involved; and with grade 4, more, it's like gross destruction of the cartilage with joint subluxation or minimal translation of the joints. So after we have seen this, after we have come to the diagnosis of knee arthritis, we should explore what all possible treatment options we have. And to my surprise, and to everyone's surprise, as of date, there are hell number of treatment options available to treat arthritis, right from stage 1 to stage 4. And we really need to be aware of all these in order to treat the patients with knee arthritis. So there are non-pharmacological therapy options which all our physiotherapy colleagues would be aware of. Then there are pharmacological therapy options which is again play a bigger and important role in the treatment of knee arthritis. And then ultimately it's the surgical treatment which also has a role to play in treatment of knee arthritis. So it's not that every patient would fit in a specific area. Every patient should have had tried either of these options at some point of time during their journey of knee arthritis. So based on these variable treatment options available, there is something known as the evidence-based guidelines for treatment of knee arthritis. And these all bodies all over the world, the AOS, the Euler, the NHS, the ORCI, the Australian Academy of Orthopaedic Surgeons, everyone has come up with their own guidelines and recommendations for treatment of knee arthritis. And we standardly follow the AAOS guidelines, which tell us that which treatment as of now is an evidence-based treatment for treatment of knee arthritis in which stage. So in order to proceed further, I would just like to present three important scenarios which we commonly face when we handle these patients of knee arthritis. It could be a first presentation to an orthopedic surgeon. It could be a first presentation to a general practitioner. It could be to a medicine specialist. It could be to a physiotherapist directly. So everyone needs to be aware of these important scenarios that we come across. First scenario would be an early OA patient who is around 45 years of age, symptoms in last 6 months, mild minimal pain or discomfort in day-to-day activities, and have some mild symptoms. Second case is a moderate OA, which is 56 years old male with around more than 2 years of symptoms, with restricted ambulation, restricted activities, gait and quality of life, daily activities are affected. And third patient is a patient with severe OA who is having around more than 65 years of age, more than 10 years of symptoms, not able to walk at all, wheelchair dependent or ambulatory with the help of walker support. So all these are the various scenarios where I would segregate my patients with early OA, moderate OA, and severe OA. And based on the staging and based on the medical condition of the patient, I would advise my treatment options. So case one is that patient which we were talking about is a thin built patient who is around 45 years of age, pain in both knees. If you see x-ray wise, there is mild to moderate destruction of the joint space, and patient has mild difficulty in walking but is able to manage all her day-to-day activities. And this patient, if you see her walk, you really feel that her gait is not at all altered and she is really walking well. So these patients, there is no role of surgical treatment options. The operative treatment doesn't come into picture, and they really benefit well with the non-surgical treatment options in the form of bracing, intra-articular therapy, pharmacological therapy, and non-pharmacological therapy like the physiotherapy modalities that we follow for treatment of knee arthritis. To begin further, it's that the second case that we are talking about, or the second scenario, is commonly a 56 or 50 to 60 years old patient who is having symptoms more than 2 years. And X-ray wise, you can see that there is really a gross destruction of the joint space. Patient has restricted activities and is not able to move around and do his day-to-day lifestyle, and it's really bothering him when he's carrying out his day-to-day lifestyle. And these patients, these are borderline patients who have to be chosen widely. If you see his left knee while walking has around mild to moderate arthritis, and you can see there is a varus deformity appearing over there when he walks to and fro. And these patients will definitely benefit to a certain extent with minimal amount of medications, intra-articular injections, and bracing for a short period of time. But these are the patients where we have to consider some surgical treatment options, and they really have a role to play in this patient. We will be seeing them all in details a little later on in my presentation. The next case scenario, it's pretty obvious. These patients are either non-ambulatory or they are wheelchair bound and they are really not able to walk. You can see there is gross bowing of the legs and there is destruction of the joint space. There is subluxation of the knee joint, and these patients really have challenges in their day-to-day lifestyle. And this is no brainer that this patient is obviously going to need a surgical treatment. Medical management is not going to help over here. Even to a certain extent, if I ask the patient to do some physiotherapy exercises, she'll not be able to do so because of the knee arthritis and the crippling deformity she has. So here definitely knee replacement has a role to play in such type of patients. But do everyone have to wait till the stage 3 comes, or she comes into the third case scenario and then get knee replacement done, is a matter of concern nowadays, and we should discuss this over a period of time. So the recent trends, there have been lots of resources being possibly explored for treatment of knee arthritis, like how medical management can control it, what are the newer medicines that are available to control the degradation of the articular cartilage. So focus has been now on, first is to prevent the cartilage destruction, and second is to control this cartilage changes that are happening. So this is the recent area of where the principles of treatment are being employed on. And to my surprise, there are certain treatment options which are now recently being lot of spoken of. Is to prevent cartilage damage is the oral treatment with collagen peptides. There are a lot of phytomedicines are available. There are a lot of nutraceuticals like modification in food and lifestyle which can help in prevention of progression of knee arthritis. Viscosupplementation is coming up with a bigger role in treatment of knee arthritis. And ultimately genetics, there are a lot of genetic studies which are going on to find out which patient would be suffering from knee arthritis, how to anticipate them, how to see what is going to benefit to them. And the second option is to control the cartilage damage. We are having PRP as a bigger role now. Stem cell therapy, if everyone would be hearing about this round the clock, stem cell treatment for knee arthritis. And then lastly, the genetics. So these recent trends have been used now in order to see how we can do better in the early stages of knee arthritis and control them from progressing to a further advanced stage. So coming to the non-pharmacological therapy here, my physiotherapy colleagues would have a role to play. And I would really say that this is no single man's job. It's like a holistic team approach, which should be employed for treatment of knee arthritis. Single orthopedic surgeon or a single rheumatologist cannot treat this patient, and it has to be a joint venture between all of us. So to begin with the non-pharmacological therapy options, bracing has an important role to play. There are various types of braces available: the varus knee brace, the valgus knee brace, the offloader brace. Depending on the type of the deformity, depending on the obesity pattern of the patient, this type of braces can be offered to the patient in mild to moderate stages, and they really have a role to play in initial phases before the joint space is eroded completely. Simple hinge knee brace or a simple kneecap can also be advocated to these patients, and it helps to a certain extent to prevent the inflammation in the joint. It compresses the joint, it reduces frequent effusions in the joint, and it has a role to play to a certain extent, but no definitive role for treatment in early stages. So these various types of knee braces can be used now, which are largely available in the market and should be used judiciously in all these patients. Foot deformities, we see a lot of patients with having compensatory deformities in their foot and ankle joints. In when they have a varus or a valgus deformity in the knee joint, they have a compensatory varus or valgus in the ankle joint. And really, to my surprise, even I was surprised to see some of my patients benefit with a mild shoe footwear modification, which giving a lateral shoe raise. I could just correct the angulation of the ankle, and automatically it offloaded the medial compartment of the knee joint, and patient started feeling symptomatically better. And this is spoken about in the AOS guidelines about there is no conclusive evidence about the treatment of the footwear modification, but yes, it has a role to play in treatment of knee arthritis. Coming to the next part, that is the pharmacologicals in treatment of ONE. I'm not going to speak about the physiotherapy modalities for treatment of ONE because of all of our colleagues would be aware of that. But I would say exercise, lifestyle change, knee rehab is a very important part of knee arthritis in whatever stage the patient is, right from stage 1, stage 2 to stage 3 and stage 4 as well. So because of without a good muscle strength, the knee joint cannot function properly. So that's the biggest important thing that we know. And flexion deformity is the part that is very importantly to be corrected in these patients. And correction of just flexion deformity itself will have certain important bearings on treatment of knee arthritis in patients having mild to moderate arthritis. Coming to the pharmacologicals in treatment of ONE, there are various groups of drugs that are being used. We must be aware of the steroids being used, chondroprotectives being used, and they have a specific role in specific stages of knee arthritis. Certain medicines prevent further degeneration of articular cartilage, certain medicines will prevent inflammation in the joints happening, and certain medicines will prevent the periarticular bone damage. NSAIDs and opioids should be used judiciously in treatment of knee arthritis, and they are the first line drugs initially, because in order to initiate any treatment, either a physiotherapy exercise or any surgical treatment, first and most important thing the patient will want is the relief of pain, and that can be very well given with these medications, and they have to be used judiciously, the opioids as well as NSAIDs, depending on their medical history, whether the patient is having diabetic, hypertensive, or pre-existing kidney and renal damage dysfunction, and to be used judiciously. Either you can be using them in transdermal patches, local application gels, or oral pills. So either of them can be used in these patients. The newer medicine that I was talking about is type 2 collagen. This is a game changer in patients with mild to moderate knee arthritis, and it has shown significant significant changes in these patients in aspect to it reduces the hypersensitivity and the inflammatory response to the of the inflammatory cells into the joint, and it really helps to restore the articular cartilage in its good integrity and good strength. The contraprotectives that we all spoke about or we people speak about is glucosamine, chondroitin sulfate, oral hyaluronic acid. Though these are a part of a mixture or these are part of a mixed therapy, AAOS guidelines doesn't recommend the use of these in treatment of knee arthritis. But yes, to a certain extent, if the patient is feeling better and improvement in the pain, and if this medicine can take care of the knee pain without giving an analgesic, then I would definitely opt for this type of therapy in certain group of patients. These medicines are the precursors for glucosamine which are the major component of the joint cartilage, and they prevent degradation of the further cartilage. Lot of phytomedicines are being spoken about in last 5 years, which includes Boswellia serrata, curcumina, montana, vitamina somnifera. So all these medicines have certain phytochemicals in them which inhibit the inflammatory markers in the knee joint, and that is how they prevent the good cartilage from being degraded to a further level. And to my surprise, if a patient is off a painkiller or a steroid and is on these medicines and is feeling better, these are to be used in patients with knee arthritis. Genomics is emerging up as a major role. Like I spoke about that, we are able to identify which genes are responsible for osteoarthritis in these patients, and if there is a serious familial predisposition, especially inflammatory arthritis or osteoarthritis, we can find out by doing a genetic mapping of these patients whether they are going to be predisposed to having an arthritis in a later stage, and they can take adequate care in their early stages. As well as these patients, we can predict the response of the treatment on these patients. So genetic based analysis and treatment, like what would help in this patient, we don't want the patient to be unnecessarily loaded with a lot of medicines, so prescribing the best fitting drug to these patients, prescribing the right dosage, minimizing the toxicities and adverse reactions, and increasing the efficacy of the drug are certain principles on which this genetic treatment is emerging up. Coming up to the repair strategies that we use nowadays for treatment of knee arthritis are intraarticular injectable therapies. They can be in form of steroids, viscosupplementation, PRP injections, BMAC injections. Everyone has its own role to play. Certain cartilage regenerative procedures have been tried, but not with an excellent outcome in global destruction of the joint cartilage. But they have a role to play in focal defects in patients with having traumatic knee injuries. So intraarticular therapies or intraarticular injections combined with manipulation of the knee joint. My mentor and my professor, Dr. K. Sancheti, used to always teach us that don't leave a patient with a flexion deformity. So always correct the flexion deformity by doing a manipulation, gentle manipulation under anesthesia. You break the adhesions of the posterior capsule, stretch out the posterior tightness, and give a good knee extension to this patient. And they show magic. Next 6 months, 10 months, this patient is going to be very happy, walking well. So it is in select patients where these type of treatments would work. The corticosteroid role is being cheaper and being widely used for intraarticular injections, but I would say should not be tried more than twice in a year in patients, but it has a very important role. There are a lot of studies which compare corticosteroids with placebo treatment for knee arthritis, and it has shown that corticosteroids help magically in these patients with knee arthritis. Other biologics or orthobiologic or preparations which will restore the damaged cartilage or prevent further destruction of the cartilage are the PRP injections, the bone marrow aspirate concentrates, and the stem cell therapy, which is coming up nowadays in a bigger way. So PRP is nothing but a platelet-rich plasma. So you centrifuge the patient's own blood, remove the red blood cells, and remove the plasma, and use that platelet-rich buffy coat, which is the white coating in the between, and that is injected into the knee joint. And these have a lot of healing potential. They have a lot of growth factors, endothelial growth factors, VGF, TGF, and all these factors, they help in the healing response of the articular cartilage. So like we are injecting concentrated healing response into the joint, and this PRP can be leukocyte rich or leukocyte pure, depending on the technology that you are using. And it has a role to play in certain patients with mild to moderate knee arthritis. Bone marrow aspirate concentrate. This is the simplest form of injection into the joint, which we aspirate from directly, not from the blood, but directly from the bone marrow, and we derive this mesenchymal stem cells or the bone marrow stem cells. And these stem cells have a capacity to redifferentiate into the chondrocytes and the chondroblast, and they will lay a good cartilage in the knee joint. Clinical role is yet to be established, but certain phase 2 and phase 3 clinical trials are going on in this part of the treatment, and is showing to a certain extent good effect in certain group of patients. Coming to the repair strategies, like focal cartilage defects, where the relatively surrounding cartilages should be good, and these focal defects can be covered with the help of this gel based or glue based pasting on the knee, on that focal area, which will cover the defect and eventually form a good nice layer of fiber cartilage, not though the hyaline cartilage. Oats have been tried in certain patients, but not with an excellent outcome. We try to stitch the cartilage from a non-weight bearing zone into a weight bearing zone where the erosion is there, and it has shown to have good healing response, but in traumatic patients with having traumatic knee injuries and not with degenerative knee arthritis. Mosaic-plasty involves multiple pegs which are punched into the damaged area from the non-weight bearing area of the patient's own knee joint, and this is a single stage procedure, have been showing good response in patients with knee arthritis. Coming to the last part of my talk, which is the surgical treatment, and here we have a good role to play along with my physiotherapy colleagues, because unless until they rehabilitate them, these patients are not going to do better. So these are the various surgical treatment options that we have, like arthroscopic lavage and debridement, high tibial osteotomy, patellofemoral arthroplasty, unicondylar knee replacement, and then ultimately total knee replacement. I would not reserve total knee replacement as a last option or should be tried only after all other have failed, but it should be used judiciously in patients who really need them, and not just delay till the stage 4 comes and the patient has a crippled deformity and then only she comes for a knee replacement. So arthroscopy has a major role to play. Removal of this removal of these loose bodies or these locking episodes into the joint can be helpful in certain group of patients, because these loose bodies, they frequently cause mechanical locking episodes to the joint and frequent synovitis and effusion in these patients. So other area that is very important is the medial meniscus root tears. So patients with mild to moderate arthritis or early beginning of arthritis, they usually have a post-traumatic history, and here the damage to the articular cartilage or damage to the articular cartilage is based on damage to the meniscus, which is a loop, which is like a weight shear loading force between the femur and the femur and tibia. And this meniscus, when it is torn from its root, it gets extruded from the joint, leading to further causing irritation amongst the femur and the tibial cartilage and getting it to worn out further. So repair of this root, as shown in this picture, has really an important role to play in prevention of further damage to the articular cartilage. Excision of the torn parts of meniscus. These patients will usually benefit to a tremendous extent because they have mild to moderate symptoms, and symptoms are more because of a degenerative meniscus tear. So excising these meniscus have a role to play, but though meniscus preservation is an important thing, and I have never done a total meniscectomy ever in any of these patients. So as much as possible, you try to retain and repair, but if whichever is a damaged portion which is in the white zone, we tend to excise it completely. Other cartilage repair procedures, like the abrasion chondroplasty, we don't want this damaged and fibrillated cartilage to be there in the joint, because these loose cartilage fragments are going to eventually fissure out into the good area of the cartilage and is going to widen the area of joint damage. So this cartilage is fashioned, we remove this loose fibrillated fragments, and this is how we convert a unstable cartilage to a relatively stable cartilage. And if this area is bone depth, like a bone is exposed, then we tend to do microfractures. This is a very important tool, because these microfractures bleed and form a scar tissue over this damaged portion and form a good fibrocartilage to show excellent response in patients with knee arthritis. Our physiotherapy colleagues need to know that these patients should not be made to walk full weight bearing immediately, so they need to be kept non-weight bearing till the fibrocartilage is formed, and then later on they can be made to walk partial weight bearing and then to total weight bearing. High tibial osteotomy is one area of my interest, and I really like this surgery a lot because in mild to moderate patients of knee arthritis, correction of the mechanical alignment or the mechanical malalignment is the main important reason where the arthritis is going to progress further. And if you correct this mechanical malalignment to a neutral alignment, these patients can really get 10 years and 15 years in their life before they go on to a knee replacement surgery. So there are select indications of high tibial osteotomy. It should be a specific compartment involvement. Patient should not be very obese. The mia band should be less. There should be no gross instabilities of the knee joint. And these patients, based on the patient's requirement, various type of implants or various types of fixators or devices can be used for converting a mal-aligned leg to a well-aligned leg. So I would just quote an example. This patient was operated for an high tibial osteotomy almost 18 years ago by Professor Senior K. Sancheti sir. And this patient turned up for a knee replacement for the opposite knee, but was very happy for osteotomy done leg and absolutely had no symptoms. We can see the perfect neutral alignment we maintain while the opposite leg is going into a varus deformity. Certain other select patients where they have mild to moderate deformity, short, stubby female patients who have mild varus deformities and mild beginning of symptoms. They are in 40, 50 years of age. They are really, HTO has a role to play, and it really prevents further degradation of the cartilage for at least 10 years. We have good research and good evidence-based papers which show that the 10 to 15 year survival is almost 80 to 90%. So these patients can again not be made to walk full weight bearing, and they have to be partial weight bearing for a couple of days, couple of weeks, and then to advanced weight bearing, and then to further knee rehabilitation. And they really have to use assisted devices. So that's the very painful part of this procedure, that you cannot immediately rehabilitate to the normalcy. There is a certain patch which you have to be patient with, and then you can get a good outcome. Coming to the next surgical treatment, and which is being popularly spoken now, is unicondylar knee replacement. This is gaining a lot of popularity, but the indications are very, very select and cannot be generalized to any patient having medial or lateral knee arthritis. So very specific anteromedial knee arthritis, the ACL ligament should be intact, the patellofemoral joint should not be affected, the lateral compartment should be good. And these are the select patients where you can do unicondylar knee replacement. It is just involving changing the articular areas of the medial compartment or the lateral compartment, or nowadays a lot of research is going on for bicondylar knee replacement. Like you just retain all the ligaments, the collaterals, the cruciate, and just change the medial compartment and the lateral compartment. So a case example where this young patient, 52 years old, relatively younger patient with mild to moderate symptoms with little bit of malalignment, and we can see there is an erosion of the medial compartment with bone on bone appearance, and this patient tend to do on very well after unicondylar knee replacement on both the knee joints. Another area which is being spoken about is patellofemoral knee plane, and our physiotherapy colleagues really have worked a lot in this aspect, in terms of taping, in terms of VMO strengthening, in terms of cord strengthening, and they really show a tremendous improvement in these patients in early stages. But when it tends on to go on to an advanced arthritis, which is seen in this type of picture with a complete erosion of the patella and the articular cartilage, there the articular surface resurfacing of the patellar component and the trochlea has a role to play in this patient, where the relatively other joint is very good. After we have discussed this all, I would come to the final solution. I would not say this is the only solution, but a final solution, which is a total knee replacement. Again, the indications, it's not, you don't wait till the knee gets burnt out completely and then do a knee replacement, because by then you have already set in to have ligamentous instabilities, and should be done in patients who will benefit because of knee replacement, where the pain is very significant, not getting relieved because of daily medications, the walking distance is affected, cannot go out of the house, patient is household ambulatory, the activities of daily living are affected, and patient is crippled because of the knee pain. This lady is no brainer, because she's not able to walk well. You can see that she's walking with a waddling gait, bilateral Trendelenburg gait, and obvious varus deformity. And I would not really wait till this stage is reached, but this patient really in India, they turn up late because of the financial constraints or because of social constraint, and these patients tend to benefit very well with knee replacement surgery, and their quality of life is extremely changed after knee replacement, like how she was not able to walk, and if you see in this video, she's really able to walk well after a knee replacement surgery. So Weinstein deformities is what we commonly see in patients with rheumatoid arthritis. One side is varus deformity, one side is valgus deformity. And these patients, you can see she needs two people to hold her or a walker to walk. And after doing a total knee replacement in these patients, they really tend to show an excellent outcome. So this is a great video of this patient showing that she's able to really walk confidently and very well, which she was not able to do initially earlier. Nowadays lot is being spoken about the artificial intelligence in all fields, not only orthopedic surgery but all fields, and orthopedic surgery is no exception, where there's artificial intelligence is creeping in. And robotic assisted knee replacement surgery, with the use of artificial intelligence we can improve the precision of our knee surgery, and this has the role to play. But I will just take this with a pinch of salt, and robot cannot replace a surgeon operating a knee. So robotic assisted knee surgery is definitely an era which has to be explored. And I would just say that many new technologies and advances are being introduced, but we need to be wise to use them. Everything new may not always be good. And I would say that we should not be the last one to use this technology, but we should not be the first one also. But once it is time proven and tasted, we should be using it in our day-to-day approach. So I would go on for a multimodality approach for knee arthritis pain, with change of lifestyle, with a good exercises, good rehab, certain part of with medications, with certain patients benefiting from intraarticular injectables, certain patients benefiting from biologic therapy. And then ultimately, if this doesn't help, I would go to the peak of the pyramid, where I would offer a surgical treatment into these patients, where knee replacement would be the choice of treatment, where my severe arthritis is there. So it's ultimately a team approach, or it's a teamwork between orthopedics, the physiotherapy, the rehab person, the socialist. So everyone has a role to play in these patients, and we all need to buck up our shoes and help this patient with knee arthritis. So here I end my talk, and I really thank you all for your kind and patient listening. I take this opportunity to thank Professor Varad Rajulu, who is the principal of a physiotherapy college at Krishna, Karad. I would special thanks to Dr. Trupti Yadav and Dr. Neeraj Athwale, who introduced me to this program, and other organizers of this virtual CME. It is really a nostalgic moment for me. I am just going to share some of my pictures where I was back in 2007 in Karad, and this was my convocation then. So after my graduation, we had the first convocation at Karad, and it is really a moment of pride for me to be a part of this institute. I thank you all, and I end my presentation over here.
Sir, thank you very much, sir, for your lucid presentation. I'm Dr. Varadarajan, sir.
Hello, sir.
Yeah. So we might have met sometime when you are here in our college.
Yes, yes.
Yeah. It's really very useful talk, and definitely all physiotherapists will be got the good idea about the management of knee arthritis.
Sure.
Sir, from my side, just I would like to ask you one question.
Yes.
At the earliest, when do you refer patients for physiotherapy management, sir, in your
sorry, sir?
physiotherapy care for physiotherapy reference?
Sir, every patient would have a physiotherapy reference right from first visit to the hospital, because this patient in India, we have a tendency to see this patient little later. They would be treating with some home remedy, some home therapy for 6 months, and they would have wasted their cords completely till the time they reach to the hospital. So in my practice, the physiotherapy has a role to play in each and every patient right from the first session itself. So from day one only, I'll be sending the patient for a good rehab, understanding of the physiotherapy exercises, and I would rather not just send them once. I would ask them to visit the physiotherapist at least once in 10 days or once in a week's time, so that to understand what they are doing right and what they are doing wrong. Most of the times the patient once learned exercise, they'll do that for lifetime, and usually they'll do it wrong. So I would ask them to come at least once in a week or once in 10 days initially, and in certain patients who have gross deformities, I'll ask them to go on for a supervised rehab daily for at least 2 weeks time in my initial practice.
Okay, thank you very much, sir.
Thank you.
Over to Tripti. Any questions are there?
Yes, sir. Thank you, sir, for your presentation. We have questions over here for you.
Yeah, sure.
Would you prefer corticosteroids over PRP?
Yeah, in my private practice, I would certainly prefer steroids over PRP. There are two advantages to it. One, it's being cost effective, not very expensive, and I've seen inflammatory response in certain patients with where PRP was injected. So there, I'm little more skeptical. I'm not very pro for PRP injections, but I'll certainly prefer steroid injections into the knee joint.
Okay. After the PRP is done, what do you suggest? Non-weight bearing for 1 week or continue as weight bearing immediately?
Evidence base shows no difference between immediate weight bearing and delayed weight bearing. But if I'm injecting a substance into the joint, I would want it to stay there, and I don't want it to be eroded or washed out with the effusions happening. So I would keep my patients for non-weight bearing for around 2 weeks time, 3 weeks time, and then once they have settled with that initial PRP phase, then I'll ask them to weight bear gradually. But yeah, 2 weeks in my choice, it would be 2 weeks of non-weight bearing.
Okay. The nature of lifestyle in India. So how do you load management in acute stage of flared knee in case of osteoarthritis?
Yeah, so lifestyle, like it's even if you give me a choice to eat my food, I'll be sitting on the floor and eating my food. So lifestyle is in India, it's like we have a lot of customs and traditions with us. So, but if a patient is having an acute flared knee or an acute effusion into the knee joint with a mild to moderate arthritis, I'll definitely warn this patient that now till date you have lived your life like how you wanted. Now live your life how your knee wants it to be. So restrict your activities, modify your lifestyle, change activities. When there is a flight of stairs and when there is a lift, use a lift. Don't squat, sit cross-legged. Don't use Indian toilet. Go for a Western toilet. So that will offload your knee in, and the axial loading and the torque bending. These are two forces which cause damage in these day-to-day lifestyle activities. So I'll definitely warn these patients not to do these activities, and I'll give them a choice. If they really want to desperately do it, they can do it for a couple of days and get their fingers burned, and then come to that I should not do this.
Sir, can you just tell us what is the rate of flexion deformity after the total knee replacement and what are the causes for it?
Yeah, post knee replacement total flexion deformity, most common cause is inadequate correction intraoperatively. So patient had a preoperative flexion deformity which was not properly corrected intraoperatively, and then there is a persistent flexion deformity postoperatively. That is the most common cause. The very rarely the causes will be that the patient, or other important cause would be that the patient has neglected the physiotherapy, and for relaxation of his hamstring he has kept in a flex posture where the leg goes in external rotation and the knee goes in flexion, and this patient tends to come up with flexion deformities at a later stage. So it is a terrible deformity post knee replacement. This patient, the cords is not does not act efficiently on the knee joint. The knee doesn't lock in extension in the stance phase, and they have their biomechanics of the leg completely altered if they are walking with a flexion deformity. So my threshold to accept a flexion deformity post knee replacement is 0. I would not accept a flexion deformity. I would either get them to rehab, I'll get them to the theater, I'll do manipulation anesthesia, I'll cast them in full extension. So I would accept compromise on flexion, but I'll not accept compromise on full knee extension at times.
Thank you, sir. Thank you for your presentation from the organizing team of Knospe 2020. We shall move on to the next presenter, Dr. Brad Avery. Okay. So let me introduce our next presenter for the day, the last presenter of today. Dr. Brad Avery is an accredited occupational therapist working within private practice and within industry as an occupational rehabilitation consultant. Previous guest lecturer and tutor at Latrobe University School of Physiotherapy, Melbourne. He is a highly experienced and recognized occupational physiotherapist with a special interest in lower limb biomechanics and rehabilitation. Today, Dr. Brad shall enlighten us on the biomechanical considerations in the management of degenerated knees. Welcome you, sir.
Thank you very much for the introduction, and thank you for the invitation to present to you from the other side of the world here today. Let me just get set up through here. Sorry, I'm just trying to share my screen there.
Yes, sir.
Okay, so from a biomechanical perspective, look, here in Australia, we would manage things very similar to what you are in India, perhaps intervene surgically a little bit earlier before the mass destruction of a knee from a grade 3 to grade 4. But we certainly focus very heavily upon the biomechanics and how we may be able to influence the biomechanics at an early stage to try and prevent the development of osteoarthritis. As Sunny was saying, that osteoarthritis is the most common joint-related condition in the world, the knee joint being the most common large joint to be involved. Approximately worldwide, about 1 in every 3 of the elderly population, with the chronological age the greatest independent risk factor, although it's interrelated rather than independent. Knee biomechanics, it's a simple hinge joint. Unfortunately, that simple hinge joint has 3 unique compartments with 6 planes of movement. The big element in regards to what Sunny was talking about with that fixed flexion deformity is the impact that it has upon the screw home mechanism, which plays an important part in terms of that maximal stability and terminal extension. And for those who need a reminder, it's just in the last 20 degrees of terminal extension in an open kinematic chain, that's the external rotation of the tibia by about 15 degrees, and through closed kinematic chain, the femur internally rotates by about 15 degrees. And this is really a reflection of the elongated medial femoral condyle together with the anterior tibial gliding that occurs with the tensioning of the posterior cruciate as it moves into extension. To unlock, sorry, I'll go back there. To unlock, obviously, the popliteus has the role in the open kinematic chain, and the hip external rotators play the important part in terms of a closed kinematic chain, and that becomes very relevant when we look at the patellofemoral joint later on. In terms of the forces going through the knee joint, certainly an important part is the mechanical axis, which goes from the center of the femoral head through the center of the knee down to the talus. There's usually about a 6-degree angle of variance between the anatomical and the mechanical axis, with the anatomical axis going up through the shaft of the femur. The important parts of that is that the center of the tibiofemoral force lies medial to the center of the joint by about 4 to 8 millimeters. And that even increases further both with knee flexion as well as with individuals who have a wider pelvis or smaller height. It causes a greater deviation from that. And what the relevance of that is that that medial orientation of the tibiofemoral force produces a knee adduction moment or a varus force, which known as the CAM, and that can mean that you can get up to 2.5 times the actual direct force through the medial compartment through the articular zones as you can through the lateral compartment. The relevance of this in terms of it is the significance that has upon the ground reaction force. That in walking, you have about up to 1.8 times your body weight and ground reaction force through initial contact, and then again at the end of stance. It drops through because of the vertical translation of the trunk through mid-stance to about 80% of body weight. But again, in ascending stairs, running, it can go up to between 3 to 6 times, or in deep squat, some measurements occur up to about 20 times body weight at some of the articular surfaces. So we're talking about huge amounts of forces going through the articular tissue that can certainly cause some of that mechanical stress. So as Sunny was saying earlier, the pathogenesis of OA really predominantly affects the articular cartilage with associated changes through the subchondral bone. The subchondral changes have certainly become a much greater level of interest in terms of being the source of symptoms to the knee pain, particularly considering that the articular cartilage lacks nerves, lacks lymphatic vessels, has very little blood supply. The structure of the articular cartilage is one of the interesting topics in terms of the role that the chondrocytes particularly have in terms of assembling and organizing the collagen fibers, the proteoglycans and the remainder of the tissue. And it's certainly the fact that the chondrocytes are very sensitive to variances in load, particularly high load above body weight, that has an effect upon both the function of the chondrocytes as well as the function of the matrix and the structure of the matrix itself. So Hanjik, who's an orthopedic specialist over in Holland, kind of identified a group of 5 different biomechanical factors or overloads that disrupt the homeostasis of the articular cartilage. And they hypothesized in their study that essentially these 5 elements contribute to or predispose to the continuing degradation of the cartilage. They applied differently to the 3 different compartments because of the individual biomechanical considerations at play there. Now, in terms of the malalignment, what we're talking about is the variance in that mechanical axis that we just laid earlier. Normally, a 6-degree angle between the anatomical axis and the mechanical axis, with that center of the tibiofemoral force being on that medial 4 to 8 mils from the medial of the joint line. Now, the cam force, if you have a 4 to 6% increase in the varus alignment, that can result in up to a 20% increase in the compartmental load. And when we're talking about actions such as running with up to 6 times increase in the vertical ground reaction force, when you've got an additional 20% on that, that can certainly cause significant contact stress through the articular surfaces. This is then further amplified if you have someone who's got a BMI above 25. That certainly dynamically contributes to both an increase in that cam force, but then again, in terms of an increase in the contact stress. The varus deformity that you saw so prevalently in Sunny's videos and presentations is certainly the most common malalignment, making up about 3/4 of the variances from a neutral position. From a statistical perspective, that varus definement is associated with an immediate increase in functional decline, with a 3 to 4-fold increase in the risk of structural disease progression than if you had a neutral knee. So a lot of the attention worldwide is about how we address this varus deformity or malalignment prior to the event of any radiographical kind of changes. Now, obviously, as we saw again, as the disease, the knee arthritis progresses, you certainly get an increase in the laxity of the lateral structures. You get creep deformation of the lateral collateral ligaments. You get weakening up of some of the other structures. You get a reduction in the height of the medial compartment, and that contributes to a greater cam force going on, and then further progression of the knee arthritis. So can we affect this knee alignment is one of the big questions. So one of my colleagues here in Melbourne, Professor Kim Burnell, who's a prominent physiotherapist and researcher and head of one of the schools of physiotherapy here, looked at this very question in a lot of her research, and they hypothesized in a study done in 2014 that looked at neuromuscular retraining and strengthening versus quadriceps strengthening. Now, quadriceps strengthening has been demonstrated in most forms of knee arthritis to be beneficial in terms of both managing pain and function, although the evidence supports that just pure quadriceps strengthening isn't sufficient to be able to alter or mitigate the cam forces going on, or to be able to delay the progression of structural osteoarthritis. So they hypothesized that by focusing upon trying to correct the trunk malalignment, combined with the reducing the cam moment or through the varus force, that they would reduce that cam force during gait, and that obviously, hopefully, reduce both the pain and function, but as well as improving the prognosis in the long term. So if you look at it from a structural perspective, then certainly maintaining an optimal kind of trunk and lower limb alignment during early contact and late stance, together with the position of your VL and your quadriceps, your lateral gastroc, your TFL combined with ITB, your lateral hamstrings and your adductors are in a closed kinematic change, well kind of positioned at least to be able to try and reduce that varus moment that goes on. Now, the results of the study, although it being a strong study from a power perspective, showed that both the neuromuscular and quadriceps strengthening improved pain and function in moderate to severe medial compartment osteoarthritis patients. And that would, from our classification of what we generally use here in Australia, would be more of the grade 2, bordering upon grade 3 of what Sunny presented earlier. But of significance, neither of those groups demonstrated any significant reduction in the cam moment during the gait. Now, one of the things that does have a little bit of evidence behind it in terms of reducing this cam force, which is so prevalent, is the role of some of the, if you want, some of the adjuncts to treatment being footwear. That Kim Bennell, who wrote this paper, she worked together with ASICS Footwear Company to be able to develop a OA specific runner that has a different density of foam within the medial aspect of the sole itself, and that has a lateral degree of wedging through there. And this has the impact, and it's been shown clinically to be able to try and at the initial point of contact with people who walk, to be able to transfer the weight into a everted position, and then reduce that cam moment. So it is available here in Australia as a footwear option, but it's not widely used at this stage. The other elements are certainly in terms of the lateral wedging. Part of the issue is in terms of the impact that lateral wedging does have upon other structures, such as an increased risk of having to develop issues with the Achilles tendinopathies, and also increasing the load upon the midfoot structures itself. That in turn can contribute to issues with the patellofemoral joint, which we'll get into later on. The OA braces have certainly provide a valgus force, counterforce to them, that certainly can be highly effective at reducing that cam moment. The issue being that they are quite prohibitively expensive, but they're also quite bulky and difficult to be able to try and tolerate. And they're certainly less effective with people with high body mass indexes. And unfortunately, the high body mass index tends to be correlate with the more severe disease, where you may look at using one of the OA unloaded braces. One of the studies in terms of the use looked at the reduction in tolerance to the brace, and up to about 52% of people who use those braces stopped using them after a 6-month process, despite the improvements in pain and function. Now, the second element of the earlier study that I spoke about, the Dutch kind of group, was the impact upon the meniscal loss. Now, any substantial loss, either through direct injury or surgery of the meniscal tissue, causes a substantial elevated risk of secondary OA. Research points to about a 14-factor increase in the risk of developing secondary structural OA from matched controls without those meniscal. Now, that's whether through surgical removal or through direct injury. In extension, the medial meniscus transmits about 50% of the load through, and lateral meniscus a little higher, and both of those at 90 degrees of flexion, up to about 85% of the load is transmitted through meniscus. So obviously, when you remove meniscal tissue, particularly through that mid-third, which is sometimes necessary, ideally we'd like to preserve it as much as possible. It has a big impact upon the actual ground reaction force or tibial femoral force that goes through it. Removing that central third reduces the contact area by only about 10%, but it increases that peak contact stress by about 65%. So from a biomechanical perspective, even though it's only a small change, it does have a dramatic impact upon the ability of the cartilage to be able to cope with the stresses going through it. Now, this is one element which is gaining much greater traction here in Australia, with certainly the use of PRPs, and with levels up to about 5 times higher concentration of platelets. We're starting to use it here as a little bit more of a Hail Mary approach, in terms of with minimal potential side effects, where there is elements of low-level disease. We're looking at research that's showing improvements in terms of both pain and function. However, there is very little evidence at the moment that it will actually contribute to an improvement in the progress of the disease itself. That we're seeing about a 6-month improvement in symptoms. Here at the moment, we have the protocols. Generally, we do 3 injections about 2 weeks apart, non-weight bearing or modified weight bearing for about 5 to 7 days after each. As Sunny said, to be able to reduce the shearing force, to be able to stop the clearance of the product from within the areas. They're hoping, obviously, that it has a role in some form of regenerative or improving the homeostasis of the tissue. but at the moment, the jury's still out in terms of its long-term benefits. Cartilage lesions, either predominantly through trauma. There is a difference in terms of the evidence behind both partial and full thickness defects. There is actually limited evidence that the partial defects that you see on MRIs or through arthroscopes actually contribute to a progression through to structural OA. But certainly the full thickness defects predispose the need to a premature OA, as well as being symptomatic through both the subchondral bone and the periarticular structures. The difficulties in terms of the prevalence of those full thickness tears, there was a good study here in Australia that showed with knee arthroscopes, about 20% of the knee arthroscopes across all ages demonstrated these full thickness defects. Now, here in Australia, the incidence of arthroscopes over the age of 65 has decreased markedly over the last 5 to 10 years since the public funding was removed, because of the evidence points to over the 65 age group that the benefits behind the arthroscopes diminish quite dramatically. They also point to some of the studies showing that about 40% of knee patients who undergo MRIs demonstrate full thickness defects. Now, the presence of the defect is less important than the actual size of it. That there seems to be a critical defect size of about 10 millimeters. After that 10 millimeters, they've measured that there's certainly an increase in the rim stress around the margins of that defect, which then contributes to further kind of degradation of the surrounding tissue. You essentially kind of remove the stability of that tissue, and you increase the likelihood of having further structural changes. It is partly location dependent, but generally the 10 mil size is about the right margin. The next element is in terms of certainly the joint instability or laxity. Now, Melbourne here in Australia, with AFL football and netball being such strong sports, we are considered pretty much the ACL capital per head of capital of anywhere in the world, which is not a great title to be able to have. So essentially with that joint instability or laxity, it has the effect of shifting that centrally located load-bearing area towards the periphery, and therefore loads up other areas of articular cartilage. The ACL instability is certainly the most common, and unfortunately there's that's a strong causal link between ACL rupture and early onset of OA. So the research behind ACL reconstruction is there to be able to provide the patient with an ability to be able to return to high-level sport, but there is a significant link between that ACL rupture and the onset of early structural OA. So post ACL reconstruction, there is radiographic evidence of OA between about 50 to 90% of patients after a 9-year envelope. So that's quite substantial. So 50% of those post ACL recons will develop symptomatic OA at some point, with about 44% of those being symptomatic by 5 years, and 2/3 of those will have worsening symptoms within that 5-year mark. The greatest risk of this is when you have a combined injury where the ACL is ruptured together with another structure. So obviously O'Donoghue's triad of the medial meniscus, medial collateral, and the ACL is the greatest disruption. But unfortunately, those combined injuries are also the most common. If you then have a body mass index of above 25 post-recon, you're about 2 to 5 times more likely to have evidence of OA or radiographic MRI on an MRI. Now, the study that we've been undertaking here in Melbourne is after we've had 3 seasons now of women's AFL football, which has seen that the young women at a professional level who are undertaking it, there's about a nine-fold greater occurrence of ACL ruptures in the women than there is in the equivalent professional men's league. So there's a lot of research going on behind both prevention as well as looking at what the contributing factors are. And one thing that's certainly been coming out from that research is that at 1 year post ACL, if you don't get a sufficient recovery within that first year, so if you have any sort of ongoing symptoms, that it's a great predictor of at 5-year mark where you start to get those symptomatic OAs, that they'll have ongoing issues if they're not right by the 1 year. One of the elements behind this is that there's certainly a suggestion of having a persisting excessive tibial rotation moment post ACL, and that particularly with high loads. So we talk about high loads being more than body weight or more than with walking, which is about 1.8 body weight. That it contributes to that increased tibial rotation, which produces a micro instability and increased stress upon that articular cartilage. Unfortunately, from all of this, there's very little evidence that an ACL reconstruction or meniscal surgery actually halt the structural progression of knee OA. They can certainly provide a functional benefit and a pain relieving, but in terms of the progression of the disease, unfortunately, there's not a whole lot of evidence to support that they'll make enough of a difference to stop someone from ending up down the track needing more progressive surgeries. Now, trauma is, I'll probably actually skip over the trauma because Sunny went into it to a certain degree. Just, I'll point out that certainly it's the impact upon the extracellular matrix, particularly in terms of the role of the chondrocytes and the impact of both the acute stress and the chronic stress upon the cartilage that brings about the event of free radicals within the cartilage that cause an oxidative stress that then increases impacts upon the homeostasis of that extracellular matrix. Now, moving on. So one of the forgotten elements of osteoarthritis of the knees that the patellofemoral or that anterior knee OA is nearly as common as medial compartmental OA. And there's a lot of studies that are coming out that are showing that it's actually one of the major sources of symptoms within the knee, and that it's a recurrence is very, very common in terms of it being not just a medial a compartmental problem, but also the patellofemoral joint. And as Sunny was also pointing out, that there's certainly a high incidence of patellofemoral OA if you've at a younger age had symptoms of patellofemoral pain syndrome. Now, there's a strong evidence with consensus across the medical community that patellofemoral OA certainly has more of a multifactorial etiology rather than it being about just simply the varus stress, and that there's very much at play the local, distal and proximal factors to it. And a very important part that is often overlooked is that there's significant pain mechanisms involved in terms of hyperalgesia and pain sensitivity, fear avoidance, and they're all predictors of poor outcomes from conservative management, but they are also extremely common and need to be addressed with any sort of management options within the OA framework for knees. So on the left is the typical patch or picture of the biomechanical elements that contribute to osteoarthritic changes or patellofemoral pain syndrome within the knee, where you've got the hip factors in terms of a reduction of the hip external strength, external rotator strength, hip abductor strength, producing a forward tilt through the trunk and a contralateral pelvic drop or an increased adductor moment about the hip. Internal femoral rotation, again, from that lack of pull from the external rotators, and then from the bottom up, an excessive subtalar pronation, which is partly involved with that why the lateral wedging is a bit of a point for discussion, contributing to the internal tibial rotation. Now, a Brazilian physio group who specialises in patellofemoral issues did a study on young women looking at moderate to severe patellofemoral joint issues. And they looked at the contributing factors in terms of whether there be the local proximal or the distal factors that contribute to it. And the surprising part about it is that 52% of those suffering from moderate to severe patellofemoral joint issues had all three local, proximal, distal factors being contributing factors to the pain. And 48% had two kinematic factors, with 24% having the proximal and the knee joint factors, and then the remainder having that of this study, that there was not a single person who had only one element that contributed to it. And that includes no isolated knee or patellofemoral joint factors without having either a proximal or a local or a distal contributor. So from a patellofemoral perspective, the patellofemoral stress is really related to the reaction force distributed over the contact area of the patellar facet. So the lateral facet, because of the alignment of the Q angle combined with the mechanical axis, you've got about a 60% greater force through that lateral facet when you get compressive forces than you do through the medial facet. From a functional perspective, the reaction force through that patellofemoral joint, walking upstairs about 4 times body weight, squatting up to about 8 times body weight, although there are studies that say that in a full squat, up to about 20 times body weight, which is a huge, huge pressure upon that patellofemoral joint. And particularly upon that contact area. The increased contact area through flexion certainly helps to be able to distribute the force more effectively, but as you approach that 90 degrees flexion in that weight-bearing position, there is certainly a much greater actual compressive force through there that actually outweighs the element of the increased contact stress area. And it certainly contributes to that much greater joint stress that you get when you're moving towards 90 degrees of knee flexion through that patellofemoral joint. One of the interesting things from a physio perspective that a lot of people overlook is that in-terminal extension, particularly with an open kinematic chain movement, that the actual contact area through the patellofemoral joint is actually quite small. And so if we then choose exercises or other movements that place a significant load or extension load through the knee, you actually, through that small contact area of the patellar facet, you actually significantly increase the joint stress. So for someone who's quite irritable or has those hyperalgesic or pain sensitizing, it can be a significant contributor to the failure to be able to respond to conservative management. So what we've looked at is in terms of using dynamic MRI studies to be able to look at people with patellofemoral joint studies. And so Powers, who's a gent up in Sydney, has looked at dynamic MRI studies with people with patellofemoral, looking at them doing functional tasks such as squatting, walking, everything else. And what they found is that that in an open kinematic chain position, that the least stress through the contact area of the patellofemoral joint is between 90 degrees of flexion through to 45, and then through those closed kinematic chain, it's from 0 degrees or terminal extension through to 45 degrees of flexion. So when we're thinking about kind of rehab for kind of combined joint OA, or certainly for the patellofemoral patients, particularly in the early stages of the OA, we really need to be able to kind of think about those two kind of areas in terms of how we prescribe exercise and how we manage the load through the joint itself. Now, as part of this, as physios, we're in some ways our own worst enemy in terms of our choice of modality. So I know it's a very, very common to be able to do a lot of manual therapy, particularly geared towards massaging through quads and through looking at the lateral structures, and particularly in terms of the ITB. So the ITB certainly blends in with the lateral retinaculum as it attaches on to the lateral aspect of the patella. So it can contribute through to a lateral tilt or glide, and there's certainly evidence through cadaver studies that indicate that. However, there's a growing knowledge in regards to what we talked about with those proximal factors in terms of the lateral pelvic stability contributing. And one of the common variances that we have in terms of lateral pelvic stability is using a passive tensioning of the ITB through an increased activation of the lateral quadriceps, and using the leverage of a lateral shift through the pelvis to be able to tighten up the ITB over the greater trochanter. And this in turn also has been shown to be able to contribute to that lateral tilt and glide down at the knee. So this is where kind of this multifactorial, both proximal, distal factors, where we may need to be able to make sure that when we're addressing these problems that we look both not just at the knee, but we look at both proximal and distal factors. Now, a little bit controversial here, but the studies indicate, as per Hinman here, that there's very little evidence of selective VMO atrophy. Now, we've been, and McConnell taping and so forth that originated here in Australia, we've always been very hard at pushing the VMO activation, and yet the more recent and better quality studies show that there's very little increased or very little variance between effective quadricep strengthening as opposed to trying to isolate VMO. So from certainly in terms of what we're looking at is that rather than it being about a specific localized weakness of VMO, that it is more about that there is a variance in the timing of activation between the VMO and the vastus lateralis instead in the patellofemoral pain patients. Those without patellofemoral pain seem to have an equal or a well-timed activation on both sides, whereas there's potentially a delay in the activation with the OA, or sorry, with the patellofemoral group. Now, one of the other interesting things as well as from the Ferreira study was looking at that the quadricep strength itself is less relevant in terms of what the peak torque of the quadriceps is or the power element to it. And it's what they found is that there's a much greater element of the ability to be able to modulate a quadriceps contraction. So in some ways being able to sustain a hold across a period of time and modulate how well it is. And what they found is that certainly that you get a much greater variance in those with more severe symptoms of patellofemoral pain syndrome and patello-OA than the normal population. So and that comes into certainly an important part in terms of how we start to prescribe exercise to be able to manage these patients. Now, in terms of the proximal factors that contribute to it, there's, as I said earlier, that there's really important MRI studies that show the importance of these proximal factors to it. So what we're really looking at is in terms of the role that the knees, in a way, the middle link in a chain, or the kinematic chain, that the knee is at the mercy in some ways of what happens at both the hip and the foot itself. Now, Powers in a 2009 MRI dynamic study looked at patellofemoral pain patients, and they looked at the squat position in particular, which is often a very well-known kind of provocative element to the patellofemoral joint. What they found was that through the squat and through symptomatic squat, the foot itself was actually fixed, as was the tibia and the patella position. So what they actually found, it was actually the internal rotation of the femoral relative to the patella that actually was at play in increasing that lateral patella facet contact stress. So what they looked at was that in a lot of these patients, when you've got, particularly in terms of the landing phase or the impact phase, is that it's the significant reduction in hip abductor, external rotator, and extensor strength that results in this hip abduction that contributes to those internal rotation moments about there, and that contralateral pelvic drop that you see in those three photos before. And as you can see in those three photos, on the left-hand side, you've got someone who actually controls both their pelvis with a slight increase on the opposite side through the pelvis, which is perfectly normal with the glute med and external rotator contraction. And then at the initial point of contact with the second middle photo, they maintain their alignment. But as they go through that landing phase, the deceleration phase, they get that contralateral a drop on the opposite side. They get the internal rotation from the hip, the foot pronates, and then the knee goes through that valgus moment and then loads up that lateral patellar facet. So what they've found in terms of that is that the hip extensor endurance testing is the best predictor of the internal rotation moment. And that's makes sense because the glute max, particularly dynamically under load, is the primary hip external rotator, to combine with a bit of help from both piriformis in certain ranges, as well as glute med and your quadratus femoris. But again, in terms of from a neuromuscular perspective, the role of the trunk flexion and the core stability shouldn't be overlooked. Now, in terms of the distal factors, the evidence behind improving, look, there is clinical evidence to support the use of distal factors, but at the moment the empirical evidence isn't quite there. There are some suggestions that the navicular drop through loading is a predictor of patellofemoral loading, as is the pronation through the rear foot contributing. But again, it's not really supported at the moment through MRI evidence or through research. Certainly there's added kind of elements in terms of dynamically from the running the sporting population of the role of ankle dorsiflexion range, first ray range, and navicular drop, all contributing to it as well as calf activation, weakness, endurance can certainly play a role in those kind of higher loads. Now, from a physio perspective, I'll get into it a little bit more in terms of from a best practice, what we kind of look at through here is that the clinical assessment really needs to be across the whole kinematic chain. It needs to be across both functional measures. It needs to be across local factors at the knee, proximal and distal factors. So what we kind of look for here, so that if I was to do a functional assessment of the knee with suspected OA or suspected early onset OA or patella joint, we would certainly spend a lot of time looking functionally at that kinematic chain through gait, step-ups, stepping down, straight legs, squats, jumps, landing mechanisms, running, sensitization with local local knee, foot and proximal factors, functional balance and retraining, and certainly looking at it from an endurance perspective, both sustained holds followed by reps while sustaining that hold, to be able to replicate some of those more high demand tasks. Locally, we look at the tibiofemoral as well as the patellofemoral joint assessments, soft tissue assessments, glides, tilts, palpation of the facets, ranging the valgus varus rock, which goes again in terms of the importance of that CAM moment in the impact upon the progression of the disease, as well as sensitizations. From a proximal perspective, we certainly look at a static and dynamic hip assessment, looking at the strengths of the lateral pelvic stability, hip abductors, extensors, extensor rotations, and we'd also look at the prevalence of any sort of intra-articular or extra-articular pathologies around the hip, Faber resistance to look at glute tendinopathies, glute med tendinopathies, looking at the hip flexor lengths and function, looking at quads, obviously, hamstring length and hamstring function, adductor function, and then look at certainly in terms of the pelvic alignment and the lumbar contribution as part of it as well as necessary. Distally, we'd certainly look at the importance, and it's important to be able to look at the dorsiflexion range, the calf endurance, the calf activation pattern. And what I mean by that is in terms of a pure push off through the first ray with keeping that vertical alignment of the Achilles, rather than moving into an everted position as you move both up and then down from a calf raise. Looking at the first ray mobility, which has an impact upon the ability to be able to push off or stabilize through that first ray. Look at the navicular drop, static foot assessment, sensitization with the wedges orthotics. So certainly with those with knee joint issues, popping them on, or that lateral wedge, or popping them on a prefabricated orthotic, and look at some of those sensitizing movements such as squatting, walking, hopping, and seeing whether it does actually change their symptoms at all. And it's certainly given that the previous impact or trauma to the joint is a predicting factor in terms of the development of structural progressions. It's really important to be able to know about what the past rehab and past injury profile is in terms of not just what injury it was, but what the outcome was. Was there any ongoing symptoms? Was there any kind of ongoing deficit across the board that may need to be addressed prior to moving on with the current rehab? So from a treatment perspective, from a physio perspective, I suppose it's too easy to be able to just focus upon the main elements of quad strengthening and symptomatic approval. But really, to be an effective clinician, we really need to be able to look at that whole kinematic chain. Now, I suppose from my perspective, the way that we need to be able to look at it is that what are the predominant contributing factors, not just to the symptoms, but to the biomechanical elements that we know predispose the people to the move, to the structural changes. So certainly trying to find fit them into a subgroup and use that as a starting point of which to be able to direct it. And we know from the research that there is no one kind of recipe fits all notion, that every patient needs to be individually assessed and each individual factor is addressed. So we certainly need to be able to look at the factors that we've identified. Are they actually able to be mitigated or modified? Someone who's at the end stage of the disease with a huge varus deformity, that's going to be the key element in terms of what's contributing to the structural progression of the disease, rather than being anything to do with either the proximal or distal factors, or if you want, either the stability of the quads or the stability of the knee itself. And certainly from our perspective, that you need to be able to keep first and foremost in mind that the patient goals, the expectations, and the knowledge asymmetry that as clinicians, we have a significant increase in our knowledge and our understanding of what's going on. And we often forget that the patient themselves, we're not just the advocate, but we need to be able to be their educator as well, and fill in the gaps and empower them to be able to contribute to it, because we know that the adherence of what we give as clinicians is the utmost important in terms of the outcomes that they'll receive from that. If the patients don't understand or have a good comprehension as to why it's important, then they're less likely to be able to be compliant with that treatment. And certainly, as I said, we need to apply individual treatments targeting all of the contributing factors, rather than just focusing upon knee strength or focusing upon alignment itself. And we certainly, with those with more long-standing or chronic conditions, we need to keep in mind that there is significant evidence behind the use of multidisciplinary treatments for complex or where chronic pain is involved. From when we're kind of choosing how to be able to treat people here, the best practice is really looking at, in some ways, these three primary principles of load management, education, and exercise. And in a lot of ways, load management and education are more important than exercise, of being able to try and both manage pain and function, but to improve the life or the quality of life of the individual. Secondary considerations to all this should certainly be, in terms of the treatment adjuncts, movement retraining in terms of teaching people how to run, how to squat, how to do things differently, and also a focus upon adherence, as I said before. Now, through all of this, I have not mentioned anything of ultrasound, cortisone, ice, heat, massage, TENS, NMS, or other things. Unfortunately, those things kind of lie in the they work in occasional instances for some people, but there really isn't strong evidence to support them as being effective in the treatment of either knee OA or in terms of patellofemoral joint. Certainly here in Australia, we use cortisone very sparingly, if at all, and that we probably go to much more aggressive conservative managements through exercise rehab, and then on to surgical interventions, rather than using the delaying tactics of other surgical options. So I suppose for the physios watching here, I've included this slide to be able to look at, in some ways, how we prescribe exercise and what would be considered kind of best practice or evidence-based exercise prescription. Now, this comes from I didn't put the reference up here, sorry. This comes from a position statement in the physical activity journal. And it's geared towards a patellofemoral focus, but it's just as relevant in terms of the tibiofemoral joint OA as well. So certainly in terms of both of those, we need to be able to really look at, as a first step, that of exercise prescription, looking at that neuromuscular activation. So what we're looking at with there is, in terms of managing the load, is really the load magnitude that we're prescribing as an exercise should really be no more than about 30% of their 1 rep maximum in terms of there. So quite an early on, for the first couple of weeks at least, a really light load, and looking more about the performance of how they perform things, and certainly doing very high reps. So we're talking 20 plus reps, 3 to 5 sets. So really getting that repetition to be able to get that learned behavior of how they activate, where they activate, why they activate. And certainly in terms of the time under tension, actually getting people doing more of the sustained holds rather than those kind of quick flick power loads that we get later on. A second stage of that, and particularly when we're looking at the OA of the knee, if you think about the importance of the endurance of even the hip extensors and the external rotators for the patellofemoral joint OA, is that we look at that endurance element to it. And again, the role of that, the modulation of the quadriceps activation rather than being the peak torque. So from the endurance perspective, we would start to be able to increase the load magnitude 50+% or up to 50%, I should say, of the 1 rep max. And we would look at kind of the volume of work and the form of which they're doing it. Slightly less reps, 15 reps, 3 sets, and we would give them a rest in between each of those sets, 30 to 60 seconds, and we would reduce that time under tension. So we're doing that slow, moderate velocity activation, controlled activation, getting the burn of those muscles and being able to apply it through there. We then jump more up into the kind of the strength field, where we start with people who are not used to doing heavy training or who aren't physically active, looking at about 60 to 70% of one road, or for those that are used to more physical activity, increasing it plus to 80. This is more of the kind of the traditional exercise prescription, 8 to 12 reps, short duration each rep, 2 to 5 sets, and doing kind of 2 to 3 minutes rest in between. And we're starting to be able to increase that kind of, or change that time under tension. Again, familiar for those physios out there who work with the high level athletes, is you're looking at that kind of that power, developing that kind of high torque, high peak performance. Important both, not just for the quadriceps, but particularly important for some of the hip extensors as well as the calf itself. So we're starting to be able to do 60+, 70+% for those low level athletes, and increasing it up for those more advanced. We're talking low loads, 3 to 6 reps, and we're talking high force, high peak force. And certainly looking at a rest in between each sets. Now, a part of that as well is that we certainly need to be able to look at those functional retraining elements to it as well, which should certainly be kind of specific to their sports or activities that they're doing. And we need to keep in mind that that a lot of these kind of programs, there is a big variance when they do them either at home or in a community setting at a local sporting club, or at a local gym, or at a local community group, and when you're in clinical, particularly when in terms of elements of such as the neuromuscular activation and the endurance-based exercise tends to be most affected. And also in terms of, for those athletes, again, if any of you guys work with either the amateur or the professional athletes, the pre-season versus mid-season, there's evidence again that the nature of how you address their exercise loads, it should vary depending upon the point, particularly with the incidence of knee injuries, and whether you exercise in an individual or a group. Okay, I think that's about all I have for you guys today. Is a bit of a whirlwind tour in terms of biomechanics and the role of biomechanics in terms of our physio load. Do we have any kind of any questions or any feedback there?
Yes, sir.
Hello, how are you?
I'm fine, sir.
Any questions there?
Just a minute, sir.
Not a problem.
So very good evening, Dr. Brad.
Good evening to you.
Presentation, and really it was very useful.
Thank you.
Yeah, from I have two general questions. In fact, the basic questions that I would like to ask you. How much do the public aware of their changes in normal biomechanics of the knee joint in Western countries?
Yeah. Not much at all. And look, and this is the issue with the information asymmetry that we get, that I suppose as physiotherapists here, we're primary practitioners, and so we will often see the patients prior to them seeing their GPs or seeing an orthopaedic surgeon. So we often are often the first contact that patients will have, and it's often at a very early stage where they present with low-level pain at the knee. And I suppose that's where our role is, to really start that education process going. So most of the patients themselves don't have a good understanding early on, although in the sporting population that's changing a lot. That there's a lot of emphasis in the local sporting levels and across I suppose the governing bodies for those sports to be able to really implement free widespread prehabilitation programs that do focus upon very much the mechanics of injuries. And so they get taught very much around everything from the agility training, the impact of how ACLs are done, the role of patellofemoral joint issues, the role of hip and knee. So there is an increasing awareness through there, and then that gets, and it's also increasing amongst our medical community as well. So patients are generally getting better educated in an earlier time frame as well. But amongst the population, it's not terrific before they actually come into contact with us.
Okay. There is a second question to you. Do the patients reaches you well in advance or after having a significant complaints?
Look, it depends upon the population that you're dealing with. Look, I suppose here in Australia, we would never get to that point of seeing that kind of severe grade 4 degenerative changes through the AA. That they would have well and truly had a knee replacement at a whole lot earlier time frame than that. So we just don't have that population that comes to it there. So certainly we would be heavily involved in their intervention prior to that. And most of the work that we do through here can certainly make a difference in terms of their pain and their level of function. And everything from that we spoke about through here in terms of the strengthening and that targeted strengthening work, modifying loads and managing their symptoms, you can certainly improve their pain and their quality of life. However, we again still don't have that magic bullet that's going to stop the progression of the disease. So that comes into the education that we do spend a lot of time educating, that it's like pumping up a flat tire that's also balding, that we can improve the performance of it. But if the tread on the tire is already worn out, it's going to keep on wearing out regardless how much air there is in the tire. So there's that element of empowering the patient to be able to manage the symptoms. And you can actually get, and it's been one of the benefits, if you want, of the lockdown that we've had here, is that some of the evidence behind the telehealth consultations has shown that we've been able to get quite significant improvements in people's perceived pain or impairments just from education purposes and from providing telehealth services rather than any of the manual handling or manual therapies or on hands-on type of modalities. So we certainly can get quite significant improvements when managed well.
That's a nice explanation. And thank you very much. It's a very great presentation that we are all definitely benefited out of your.
Not a problem whatsoever.
Thank you very much for your valuable time. Over to Dr. Trupti.
Thank you.
Yes, sir.
Yes.
Brad, there are some questions for you.
Yes.
Can we prevent surgery if we correct knee biomechanically through exercises?
I would love to say yes. From a patellofemoral perspective, yes, I would say yes. If it's a local patellofemoral problem, early onset, you can certainly reduce the likelihood of it. If it's someone who is a more than a 5% significant variance in terms of their CAM, we haven't found clinically or evidence-based anything that kind of stops that progression of the disease process. We can certainly manage their pain, we can manage their function and get improvements, but in terms of the progression of the disease, there hasn't been anything that's been that magic bullet so far.
Okay. The next question is, does VMO play a major role for proximal structures in the hip and in the PF joint syndrome?
So, VMO was once the kind of the golden child of the physiotherapy environment here, where all of the retraining was very much upon the VMO activation, and certainly in non-weight bearing open kinematic chain. And that's where a lot of that came from the initial research of Janet McConnell, who developed the taping techniques that are widely used now. Now, what we now know is that from a clinical perspective and from an evidence base, there's very little difference in the good quality research behind targeted VMO versus just pure quadriceps extensor strengthening. And that's it partly makes sense, is that it has the same nerve supply of VMO versus the rest of it. And it's more of the issue of how you activate and how you time, rather than whether it be have atrophy or weakness itself. So we now kind of focus more upon functional training in terms of those closed kinematic chain positions. But again, for a lot of these people, we would actually start off and focus the rehabilitation upon their proximal structures first and foremost. And unless they can stabilize effectively through their pelvis and reduce that adductor moment about the hip, or that internal rotation moment at the hip, we don't even get to the knee from that perspective. So we would really focus heavily upon getting that kind of activation pattern correct at the hip and the pelvis, and then move down to that middle link in the chain of being the quadriceps. Because particularly at an early population, most have relatively acceptable bulk and power outputs through their quadriceps. But it's more from that functional perspective. As I showed from the pictures previously, it's more about how functionally the person lands, or how they move, or how they load up the joint, rather than it being just because of a strength deficit itself. So I would say that the VMO probably gets too much of a focus, and that we certainly need to be able to look at that. Those proximal factors are really the key to be able to manage those patellofemoral joint problems.
Okay. In case of acute flared up ONE, which works well, GLAD program or water-based exercises?
Okay. Aquatic therapy, hydrotherapy. Look, it's great in theory. People can certainly exercise under very little compressive load, at least through the tibiofemoral joint. It's a way in which you can exercise to a degree. However, there is certainly queries about any sort of gains that you gain in terms of either calf activation, if it's in a closed position, or through quads, whether they do translate to gravity dependent positions and how functional it is. So we may use it in a certain population, but it certainly wouldn't form a mainstay of our early onset OA. So in terms of how we would manage a flare-up of acute OA, it would be more about empowering the patient. So if you looked at kind of a pain scale of 0 to 10, we would look at any pain ratings between 0 to 2 as being acceptable, as being fine, up to 5 out of 10 being acceptable kind of pain range. But anything above that 5 out of 10, we would look at trying to modify that activity, or remove or reduce loading upon those joints, or the parts of the joint that were affected through there. And from an exercise prescription, we would look at really, if they had a baseline of say 3 out of 10, we wouldn't really want to move more than 1 or 2 points above that point when they're actually being loaded up. And certainly after any kind of exercise that we do, you would really want their symptoms to be settled within 60 minutes of performing the exercise, and they shouldn't pull up with any kind of post-treatment soreness the next day from the rehab program that we're trying to do. So in terms of when they do flare up, it's important to be able to not overload them, but on the same level, it's important not to be able to allow them to completely rest and lose that the activation patterns, and get that fear avoidance kind of behaviors into play as well.
Okay, thank you so much, sir. I thank you to be awake such late night, because the times are clashing here in India and Australia. So I thank you wholeheartedly to present presentation.
We have our AFL Grand Final tomorrow here in Australia. So it's a public holiday here in Melbourne tomorrow. So it's perfectly fine for us to stay up late tonight. No work for us tomorrow.
Thank you so much, sir.
Not a problem. Thank you for inviting us.
Thank you. With this, we end the first session. So ladies and gentlemen, let me begin with thanking you for your presence for the first day of virtual conference. Today was a full of knowledgeable and interesting session on BPPV and its management, TM joint dysfunction, and arthritic knee by the international and the national speakers. Ladies and gentlemen, we are looking forward for the same response from you for tomorrow's session, which shall cover the topics of multidisciplinary approach of stroke management, chronic heart failure rehabilitation, which will be followed by a panel discussion and a valedictory function. Thank you so much, and let us meet tomorrow at 9 a.m. for the first session. Thank you so much.